So I welcome all the members on this net at this moment in the Zoom, and all my members of the association for the 16th annual conference of the Association of Oncologists of Northeast India. We had great desire to get together and have a meeting physically at some place. Agartala was assigned, but worldwide things have changed. So we also had to adjust to a virtual meeting. We'll remain content seeing each other, talking to each other, discussing things and evolving ideas and new plans and programs for the next year through this virtual Zoom meeting. I welcome you all, the members, the resource persons which have agreed to be part of our program from across the country. I welcome you all. And with this, I want to give a small information to all the members. Most of you have known by this time, Dr. Vikas Jagtap, who had been toiling very hard for the association as well as to bring this meeting up, had to leave for Bombay hurriedly because his father fell sick post-COVID and has been shifted to an ICU. I pray for the speedy recovery of his father, and I wish all of you pray for his father's recovery. I told him not to worry about, but keep fighting for his father's well-being, and also requested him to join the meeting from wherever if it is possible for him to join. So he may pop up anytime amongst us, I wish. If his father remains stable, he will definitely do. So with these few words, I think I'll say go ahead of the meeting and I request you, Dr. Apurva Kalita, to give an overview of the conference.
Thank you. So good afternoon, very good afternoon to everybody, all my respected teachers and seniors, and my dear colleagues and friends of the association. And we are quite happy that somehow we have managed to hold this 16th annual conference of the Oncologists of the Northeast India, although it has been a little bit delayed due to the pandemic COVID-19. So we have organized it in a virtual platform, and I hope there will be rich deliberations and prostate cancer, cancer of the esophagus, breast cancer, nasopharyngeal cancers, then the rectal cancer, lung cancers, and hepatocellular cancers. So I hope there will be a rich deliberation and we'll all be benefited to update our knowledge. And I hope some more numbers of our oncologists will join in the meantime. And I pray for Jagtap's father's sooner recovery. And I wish grand success for the conference. Thank you very much.
Thank you so much, Dr. C. Bhuyan sir and Dr. Kalita sir for those words. And we'll go ahead with the first session. So the first session is oral presentation. I would call upon the chairpersons, Dr. A.K. Kalita, Professor and Head, Department of Radiation Oncology, BBCI, Guwahati. Dr. Shyam Sering, I don't know if he's joined us. Dr. Shyam Sering.
Maybe he has not joined yet.
Dr. Shyam Sering is consultant in charge radiation oncologist at TRIMS, Arunachal Pradesh. And Dr. Munlima Hazarika, has she joined us? Professor, Department of Pediatric Oncology, BBCI, Guwahati. I think only Dr.
He is also not joined.
Okay.
All right, then we'll go ahead. This session
okay,
will be for the judges for the session will be Dr. Tamsa Singh.
He had joined.
Doctor, whether he has already joined.
He's here.
Dr. A.C. Kataki, the director of B. Borua Cancer Institute. Has he joined?
I don't think
A.C.
so.
Kataki, Dr. A.C. Kataki, and Dr. B.C. Goswami.
Dr. B.C.
director
Goswami is
of the-
joining, sir. I have called him. He is joining, sir.
Okay, fine. So, and Dr. Robbie Kanan.
Yes, sir. Dr. Ravi Kannan has joined.
Yeah.
Ramesh, sir.
So they will be doing the judgment for the abstract number 1 to 6. 1 to 6. It will be followed by Dr. Siddharth Hajarika, Dr. Polomi Mukherjee, Dr. Sheila Bharis, Dr. Gaurav Das, Dr. Anupam Das. So they will judge from abstract number 6 to 13.
Apurva, you have forgotten Ramesh sir. Yeah, he will be judged for abstract 1 to 6.
Yes.
He must have joined.
So Dr. Kataki has also joined. Now I request Dr. Ashutosh to share their presentation. And you will have 7 minutes.
My slides visible?
Yes, your slides are visible.
Can I start? Hello.
Dr. Tomcha Singh, yes.
Hello. Can I start?
You are
Yes, you-
audible and visible. You can start, I think. Apurva. Hello.
Hello. Good evening, everyone. Today, I am presenting the poster paper presentation on synchronous carcinoma of gallbladder and hepatocellular carcinoma. First, coming to the introduction, synchronous primary cancers are uncommon, but detection is increasing with the advancement of imaging. Synchronous carcinoma of liver and gallbladder is a rare occurrence. Only 15 cases have been reported till now worldwide. So here we present such a rare case of synchronous primary cancer involving like gallbladder adenocarcinoma and hepatocellular carcinoma, which were closely opposed to each other. Case report: a 59-year-old lady without any comorbid illness underwent minimally invasive cholecystectomy for empyema of gallbladder at another hospital. On post-op histology, patient it was found to be moderately differentiated adenocarcinoma. It was invading the perimuscular connective tissue, and the cystic duct margin was free. So the pathological staging was PT2NX. Patient was referred to our hospital after the PET CT was done. So PET CT showed the residual lesion in segment 4 of liver, which was extending from gallbladder fossa. So we repeated the blood investigations at our hospital with tumor markers, which showed CA 19.9, 3.2 and CEA 0.99. Patient was taken up for completion radical cholecystectomy. But intraoperatively, it was found that the nodular lesion in the gallbladder bed was extending from segment 4B to 4A and segment 8. and there was no significant retroperitoneal node. Intra-aortocaval node, which was sent for frozen section, was also reported as negative. So patient underwent central hepatectomy with portal lymphadenectomy, as there the lesion from in the liver bed was extending from 4B to 4A and segment 8. So the segment 4, 5, and 8 were removed. Post-operatively, patient had an uneventful recovery, and the post-operative biopsy reported yield that there was 2 tumors in the liver, which were of size 2 into 1.5 into 1.5 centimeter, and another tumor was 1.5 into 1.5 into 1.5 centimeter, and 10 lymph nodes which were isolated were all negative for malignancy, and it came out to be poorly differentiated carcinoma. So the immunohistochemistry was done, and it showed CK and arginine was positive. CK7, CK20, CDX2, GATA3, and CA19.9 were all negative. So it was suggestive of poorly differentiated hepatocellular carcinoma. The final histopathological staging for the gallbladder carcinoma was PT2N0, and for the hepatocellular carcinoma was PT2MN0. And after the final histopath, we repeated the tumor markers again. So where AFP was found to be more than 500, but we will repeat this again in a month, and again we'll see for the marker levels. CA 19.9 was 63.1 and CA 1.69. The patient is currently receiving adjuvant chemotherapy for gallbladder cancer with gemcitabine based doublet chemotherapy regimen. Discussion. The occurrence of multiple primary cancer is between 0.73 to 11.7%. The diagnostic criteria for synchronous primary cancer includes each tumor must present histologically with different features of malignancy. Each tumor should be distinct and separate, and the probability of one being a metastasis of the another should be excluded. Like I said before, only 15 cases of synchronous gallbladder cancer and hepatocellular carcinoma have been reported worldwide, and it becomes difficult because the usual inference of such cases when it comes to us is either it can be a hepatic metastasis or a direct invasion from the gallbladder. So it becomes difficult to diagnose synchronous malignancy involving the gallbladder and hepatocellular carcinoma. This is a table where those all 15 cases in the studies in the case reported have been made, and in China there were 9 cases and 6 other cases over the world. So from this case report we can say that appropriate review of histopathology should be done at the treating oncology center, and the imaging should be meticulously reviewed, especially in case of liver directed imaging, and we should take the help of serum tumor markers which can be helpful in diagnosing such cases. Thank you.
Hello, Dr. Sahewala.
Yes.
So
Yes, sir.
I'd like to know from you what imaging study other than the PET-CT was done before taking up the patient for the surgery.
Sir, as the patient had presented to us with already imaging report, so which already showed
What imaging report?
Sir, with PET-CT patient had been referred to us.
No. In addition to the PET-CT, do you think that there was a need for like ultrasound or the conventional CT scan?
Sir, actually, we were not expecting of second primary, and as because it was a T2 disease, so we had to take this patient for completion radical cholecystectomy. So we took up the case without repeating any imaging, and since the tumor were small, maybe ultrasound would have been helpful, or maybe an MRI could have been done. Means, but at that moment we did not feel like that another imaging will be required, sir.
Okay, I also have a question. You're treating now with chemotherapy following a surgery. Which
Sir.
chemotherapy are you using?
Sir, gemcitabine and cisplatin, sir.
Do you think that will be effective for HCC? For ZB is okay?
Sir, for HCC, for small lesions, the curative intent is either to, if it is resectable, it is just surgery is the optimal treatment, sir, for hepatocellular carcinoma.
Yeah, that's okay. I mean, as adjuvant treatment, the chemotherapy that you are giving,
Yes, sir.
is it you think will be effective for HCC also? Or you want to add some biologic therapy, targeted therapy also?
Sir, at this point of time, I won't like to add anything, sir. If the tumor marker is on the rise, sir, then I would like to assess and add, or else for the time being, sir, I won't add.
Okay.
Dr. Ashutosh, can you please stop sharing your screen? Now I'll call Dr. Pushpa Kishore Singh to share their screen and give the presentation.
Very good afternoon to everyone. Is my slide audible?
Yes, sir, you are audible and your screen is visible, sir.
Okay, then once again I start.
Yes, you can start.
Okay. Very good afternoon to everyone. Today I'm going to present the paper on pattern of clinically apparent distant metastasis at the time of clinical presentation in differentiated thyroid cancer. So I'm coming to a brief discussion. Thyroid cancers form 90% of all the endocrine malignancies with excellent prognosis if treated early and detected. And differential thyroid cancers accounts for more than 90% of all the thyroid cancers, with capillary thyroid cancers being the most common. One of the most important predictive factors of poor outcome is the distant metastasis. Apart from distant mets, age, sex, histopathological subtype, and the completeness of the surgical resections are the other prognostic indicators of survival. The most common site for metastasis is the lungs, the other side being the spine and appendicular bone. The overall incidence of distant metastasis varies from 2 to 35%, with the incidence of 4% during the initial presentation. And during the course of the treatment and follow-up, the prevalence ranges from 2% in the low-risk patient and 33% in the high-risk patients. The survival rate is reduced by 50% in the presence of distant metastasis. Unlike the other tumors, metastatic disease in the thyroid cancer responds well to radioactive iodine therapy. Removal of the primary tumor and accessible local regional disease remain a main component of the initial treatments, even in the most patient with the distant mets. So the aim and objectives of my studies is to observe and identify the pattern of the clinically apparent distant metastasis in different thyroid cancer. Coming to the materials and methods, we are doing a retrospective studies for 5 years from 2014 to 2019, in which we review the hospital details of the patients operated for different thyroid cancer, for which the descriptive statistics will be used to evaluate the pattern of distant metastasis. And in the results, when the amount 200 patients evaluated, 70 patients had clinically apparent distant metastasis. Out of these 70 patients, 12 had papillary carcinoma of the thyroid and 5 had follicular carcinoma of the thyroid. And it was found that majority of the patients with the distant metastasis where the female is above 45 years and had papillary carcinoma of the thyroid. So this figure 1 shows the histopathological subtype of the differentiated thyroid malignancies, in which the papillary thyroid cancer was predominating tumors in 71%, with follicular thyroid cancers, the second most with 29%. This figure 2 shows the age and the sex distribution of patients with distant metastasis, and it was found that it was more common in the female, in those whose age was 50 years and above. This table 1 shows the metastatic patient as per histological subtypes of different thyroid cancer. And in 8 patients of the papillary thyroid carcinomas have found lung metastasis, whereas in 4 patients of follicular thyroid cancers has been found skeletal metastasis. So I'm going to share some of the pictures of the patients who we have operated. This was a case of the metastatic papillary carcinoma of thyroid with the clavering metastasis. This was the intraoperative pictures of the patients. And this is a second case. And this was a follicular variant of papillary thyroid cancers with the metastasis to the left clavicles. This is the CECT neck and the thorax, showing the mass on the left side, causing the erosions of the left clavicles with the bilateral nodules in the lungs. For these patients, we have underwent total thyroidectomy with bilateral lateral neck dissections with the central compartment resection, with the resections of the primary mass with the involved clavicles on the left side. This was the intraoperative pictures. Now coming to the discussion part, the incidence of distant metastasis in patients with different thyroid cancers in our study was 7%, which was comparable with the incidence found in the other literatures. The lungs metastasis is the most common site of metastasis, followed by the bones, with the former having a better prognosis. And this was also observed in our studies. The bone metastasis, it's more common in the follicular thyroid cancers or poorly different or less well differentiated thyroid cancers, with 80% occurring in the axial scan, the skeleton, which was also similar to the findings in our institute. The papillary thyroid cancer classical variant metastasis mainly to the lungs, and the follicular variant of the papillary thyroid cancers metastasis mainly to the bones through the hematogenous routes, and it's more aggressive compared to the classical papillary counterparts. Differentiated thyroid cancers has a survival rate of 80 to 95%, which comes down to 40% in presence of distant metastasis, which again comes down to 20% in the presence of bone matter. The radioactive ion therapy is the preferred choice of treating the patient with distant metastasis irrespective of the age. So in different thyroid cancer, primary treatment of the patients will be the surgery, followed by the radioactive iodine in the high-risk group with the thyroid hormone suppression therapy. Coming to the conclusions of my presentation, the pattern of distant metastasis vary according to the type of the different thyroid cancer. There is papillary thyroid cancer metastasis mainly to the lungs, whereas the follicular thyroid cancers metastasis to the bone. The distant metastasis rate in the patients above 45 years and above in the patients with the follicular variants of the papillary thyroid carcinoma clearly shows the need for the aggressive treatment in this group of the patients to improve the outcome in the thyroid cancers. These are my reference, and thank you.
Hello. Hello, can you hear me?
Yes, sir.
What are the follow-up findings of these studies? Because it is the large studies, retrospective studies. What are the follow-up of these patients?
So we have found like this one. In the papillary thyroid cancer, the most common site of the metastasis was the lungs, whereas in the follicular thyroid cancer, it was the bones. And it was also observed that in the female, especially this distant metastasis is more common in the female above 45 years and above.
No, that is not the answer. I'd like to know a little bit about the survival figures.
Pardon, sir, I can't hear you properly, sir.
Survival figures.
Sir, survival figures, sir, it's 85 to 95, 85 to 90%. It was
No, this is not from the standard test. From this
Yes.
present study, what is say 2 years survival, 4 years survival? What was the duration of the follow-up of this patient?
Yes, sir. So here we have taken these survivals for the 5 years. So we have not individually measured the survivals for 2-3 years, sir.
Okay, in some of the patients, the metastatic side is very bulky and also bone was involved.
Yes,
So
sir.
do you still feel iodine therapy will be sufficient for that?
Sir, if the site of the distant metastasis is resectable, then it's better to resect that particular site, because just to reduce the tumor bulk of the metastasis. If we reduce the tumor bulk of the metastasis, then the dose of the radioactive iodine required will be reduced, and in turn, it will reduce the side effect of the radioactive iodine.
Is there any role of external beam RT?
Yes, sir. If the patient has complaining of back pain, and if there is a chance of the pathological fractures, then before operating for the main primary tumors, we should give the palliative treatment and try to reduce those complications.
If it's a bulky lesion or bone is involved, iodine therapy is not sufficient usually. Iodine therapy is meant for small disease only. Anything bigger than 3 centimeter diameter, unless surgery is done, external beam RT must be considered.
So
Okay.
in this case, what about reducing the tumor volume, sir? Suppose this one because the radioactive iodine therapy is not the definitive treatment for that particular distant metastasis.
Yeah.
That is for the palliation purpose. So, if we resect that particular tumor, and if we reduce the size of the tumor, then I feel like radioactive iodine also going to work.
Yeah, if the level over is small, yes, iodine therapy will suffice. But
Yes, sir.
the is not resectable, and it cannot be contained by therapy also. So sometimes beam RT will be indicated in those situations.
Okay, sir.
Yeah. Okay, we can go ahead with the next presentation.
Now, Dr. Amna, can you please share your slides? So you need to first stop share your screen.
Is it visible, sir?
No, your screen is not visible. Please stop share and again start sharing.
Is it visible, sir, now?
Yes, yes, it's visible.
Thank you. Good morning to all my respected
So
judges.
please go to the presenter view.
Okay.
Now,
Today I'll be presenting one paper on the outcome of salvage neck dissections in head and neck cancer as a retrospective study in a tertiary care center of the Northeast India. As head and neck cancer has a very drastic changes of this neck node metastasis, the aim of the study is mainly to make an effort in being with the study to understand the impact of neck dissection of patients who have presented with residual neck node following the completion of primary treatment. The objectives are mainly to determine the survival status post-salvage neck dissection and to assess any contributing factor affecting the outcome of the survival status. Methods, it is a retrospective study. It is paid in Dr. Beaver Cancer Hospital from a period of 2017 to 2019. The follow-up period is up to 2021 January. All the patients who has undergone neck dissections as the head and neck cancer was the primary was included in the study. Post-operative HP reports were taken into account to assess the nodal status, stage, and the extranodal extension. Factors like perinodal invasion, lymphovascular emboli was kept in account. Any complication during the post-operative period was noted. Kaplan-Meier and survival analysis was done to calculate the overall status in the time interval. Univariate and multivariate studies was carried out to ascertain the factors which affects the overall survival. Coming to the results and observation, a total number of 119 patients was operated. The youngest one was 18 years and the oldest one was 78 years. The study has a male predominance of 99 patients and female predominance of 20% in the study. The 51 to 60 year age group was the highest presenting group. The primary site of the disease, main site was the laryngopharynx, which accounted for about 48.73% of the total study. Coming to the treatment for the primary, the RT, CT, and was about in 92% patient was done, and RT alone was done in 15 patients, and surgery followed by RT, CT was done in 12 patients. The presenting nodal frequency was highest in the level 2, followed by level 3, that is 66 and 47%. The level 4 and the level 1 was a subsequent one. Coming to the nodal stage, the percentage of nodal stage was the highest in N3B, which accounted for about 98% of the total cases. Out of the 190 cases, R&D was done in 92 cases, extended R&D was done in 21 cases, and extended R&D with KMC flap was given in 6 cases. Complications as such was not there. There was shoulder pain and drooping found in 14 patients and stitch lesions in 7, and Kyle leak was noted in 2 patients. 19 patients, that is 15.96% patients, has regional neck recurrence post-salvage dissection. 17 of them occurred within the span of 2 years. 2 cases developed second primary in the esophagus. External extension was seen in 98%, which was spread to the muscle mostly. It is about in 81 patients. The IJV had tumor cells in 6 cases. Salivary gland infiltration was seen in only 1 case. And the most frequently histology was the metastatic keratinizing squamous cell carcinoma, which account for around 68% of the total cases. Coming to the Kaplan-Meier analysis, 119 patients was put into the study. 53 death events occurred, and after the period of the study, 66% was still alive. So the mean came as estimated of 25 months, as the median came into 28 months of survival. The cumulative survival rate at the end of 1 year was 84.9%. At the end of 2 years, it was 57.4%. And at the end of 3 years, it was 44.1%. The overall survival and the disease-specific survival was 44.1 and 73.9% and 90% respectively. Patients with higher number of positive nodes had a significant worse overall prognosis, and also disease-specific survival, which was significant. Extranodal extension was also found to have significant p-value in overall survival. However, PNI and LVE doesn't have any significant p-value in our study. The total number of lymph nodes dissected out does not have any significant p-value in our study. So this is some of the operative cases which we have done with TMC. Here with the treating with the external carotid. Conclusion, the overall survival and disease-specific survival was 44.1% and 73.90% respectively. The recurrence rate was seen mostly in the first 2 years, and the number of positive nodes and external extensions are the poor prognostic factor in our study. Thank you. So
Hello.
yes, sir.
So what was the number of patients who had a pathological CR in the specimen?
So pathological, sir.
CR. How many of them did not have viable tumor cells in the lymph node? See, out of the 100 odd patients you operated, not all of them would have had viable malignancy. Some of them would have had only keratin deposits. Some of them would have had fibrosis and necrosis. So how many were pathologically CR?
Sir, the study group included of 119 patients. These are the positive patients which I have included.
No, those were all clinically positive.
No, sir. This, as it is a random, this is a retrospective study. I looked for the positive reports of the HP reports, and that was the inclusion criteria.
Then that defeats the very purpose of the study. No, you're looking at salvage neck dissections.
Yes, sir.
So you should have looked at all the salvages you have done and then come to any conclusion. Now we lost some very valuable information. I think it may be a good idea to go back and pick up all the neck dissections, because that will give you a lot more information. But good job. Good amount of numbers.
In one of your slides, you have shown a PET-CT. So how you have used PET-CT in evaluation of neck nodes? And
Sir,
where to do the salvage surgery? Has the PET-CT any role?
Sir, PET-CT had a role in high volume diseases, sir, in T3, T4 diseases, in recurrent diseases, or when there is a suspicion on FNAC negative patients. We got the patients who got FNAC negative patients, but clinically it looked that there is a disease, and we don't find any primary in the preliminary investigations. We'll go for this PET scan. If the node is bulky, if the patient has a previous history of a T3, T4 diseases, then it is significant.
Now my question will be, say there is a residual node that is palpable.
Yes, sir.
So clinically positive node.
Yes, sir.
But on PET-CT, it is non-FDG avid.
Okay, sir.
So whether you will do a salvage neck dissection or not?
So if the preliminary investigation will carry out first, sir. If in preliminary investigation, if the size matters, sir, what is the size of the tumor, as of the node, sir, the fixicity of the node, sir. If it indicates towards a metastatic node, sir, then we'll go ahead with that, with the surgeries.
Okay, thank you.
Say in a post radiation setting, any node we would consider as metastatic. There should not be nodes ideally, no? So if you're doing a PET-CT for everybody, then that's fine. But how do you say, you know, a 4 centimeter size node is likely to be metastatic and a 2 centimeter node is not? Like, you can't do that, no?
Yes, sir. Yes,
All
sir.
nodes are metastatic unless proven otherwise. All nodes have viable malignancy unless proven otherwise.
Yes, sir.
Now, Dr. Arnab Kalita, can you please share your slides? Can you please stop share and again share your screen?
उसके बाद में सर जैसे ही यहाँ पे क्लिक करेंगे ना सर सबमिट Is my screen visible?
Yes, sir. Your screen is visible and just in present. So,
Good afternoon, everyone. My topic is T4B oral cavity squamous cell carcinoma. Is it worth resecting? So coming to the introduction, squamous cell carcinoma is the most common type of tumor in the oral cavity. And the majority of the oral cavity squamous cell carcinomas are locally advanced and have a poor prognosis with 5-year overall survival around less than 50 to 60%. The current standard of care for resectable locally advanced oral squamous cell carcinoma is surgical resection followed by adjuvant radiotherapy or chemoradiotherapy. So the American Joint Committee on Cancer 2002, T4 squamous cell carcinomas of the oral cavity are divided into T4A, which are resectable, and T4B, which are unresectable categories. So what is a T4B oral cancer? So involving the masticator space, the pterygoid plates, or a skull base, or an enticement of the internal carotid artery. So there are many hurdles that we face in our T4B disease, being that the masticator space and the pterygoid plates are the deep anatomic sites, and hence preoperative imaging is not possible, and a safe surgical margin is also not possible intraoperatively. And the aims and objectives of this study is to evaluate whether surgery has a favorable outcome in patients with stage 4 T4B oral cavity cancer. So materials and methods were the place of study took place in Dr. Purohit Cancer Institute. It was a retrospective type of study. The time period was from 1st of January 2010 to 31st of December 2017. That was a time period of 7 years. Total number of patients were 145. And the inclusion criteria was T4B oral cavity cancer patients, those who have completed any modality of treatment. Exclusion being those who did not complete any modality of treatment or expired before completion of treatment. So all patients attending to the OPD went thorough workup, the routine blood investigations, the imaging was done, CT or MRI, upper GI endoscopy was done, and histological diagnosis was confirmed before initiation of treatment. So the patients were either treated with these modalities: concomitant chemoradiation, surgery followed by concomitant chemoradiotherapy, surgery followed by only chemotherapy, and only palliative chemotherapy. So out of the 145 patients who completed treatment, there were 89 males and 55 female patients. The age group ranged from 24 years to 85 years. 36 patients lost to follow-up following completion of treatment. The total number of 126 patients had carcinoma of the buccal mucosa. 17 patients had a subset of the retromolar trigon, and 2 patients had carcinoma in overlapping sites in the oral cavity. So the 78 patients received only radiotherapy either as a radical or palliative treatment. 44 patients received only chemotherapy either as radical or palliative treatment. 15 patients received chemoradiation. 7 patients underwent surgery and received post-operative chemoradiation, and 1 patient underwent surgery and received post-operative chemotherapy. So this is the survival, 5-year survival that I got. The overall survival was around 11.2%. But if you can see that the surgery plus radiation plus chemoradiation is around 50%. So that is very high compared to the other modalities. So this is the survival function over 5 years. As we can all see, that's an advanced T4B disease. So it is decreasing. But if you see in this picture, using all the modalities, the surgery plus postoperative adjuvant chemoradiation has got a better survival and better prognosis than the other modalities used. So coming to the discussion, the standard treatment protocol advises against surgical intervention for T4B advanced stage of head and neck cancers.
According to the NCCN guidelines, treatment for advanced head and neck cancer is chemoradiation therapy as palliative treatment and advice against surgical intervention. So this is the NCCN guidelines. They have said that T4B disease is, we can go for, in performance status 0 to 1, we can go for RT or induction chemotherapy followed by RT. In performance status 2 patients, we can go for definitive RT plus minus component systemic therapy. In PS3 patients, we can go for palliative RT or single agent chemotherapy based supportive care. So there is no mention of any surgery in the NCCN guidelines yet. So it is, however, proposed that surgical intervention should not be disregarded as a viable option for patients in T4B head and neck cancers. So Broxton in 2003 study revealed that although the median survival for late stage head and neck cancer is reported to be around 6 to 9 months, with 20 to 30% 1 year survival rate. All the 12 patients who were included in the study that underwent surgical treatment were had survived for 6 months or longer, and 10 of the 12, 83.33% survived a year or longer. So the present consensus is that a mandibular notch between the coronoid and the condyloid process was used as a line of demarcation, and the disease classified as supranotch and infranotch. So a subset of the T4B disease with infranotch subset were found to have a more favorable prognosis, local control of 74%, than those with the supranotch disease, local control of 42%, according to the Lian paper. The distance between the skull base and the mandibular notch is around 2 centimeters, while the distance between the skull base and the lower limit of the pterygoid plate is 3 centimeters. So high ITF is the supranotch structures are the high ITF, and they have a relatively poor prognosis even after surgery. So here we have given this Trivedi's paper where they have reviewed the oral cancers of T4B, and they have said that the surgery of T4B low ITF diseases have a good prognosis after surgery. And this is the Liao CT paper. They have also said that the infranotch disease have a better survival than the supranotch disease, and they have a better prognosis in surgery followed by radiation rather than any other modality. So coming to my conclusion, as is the case with any surgical procedure, there are risks that must be considered. The operating surgeon and the oncology team must work with the patient to determine the best treatment option. With the head and neck cancers, risk of impairing functions vital for daily life, such as breathing, speaking, and swallowing, are imperative to consider, along with disfigurement. So all of the factors need to be judged, and they have to be talked with the patient, and because it's a quality of life issue. So the benefits must be weighed against the risk in some cases. The difference in survival rate versus study may not be significant considering the possible complications and resultant outcomes. So most studies are required in this regard, because our study had only a limited number of cases, 7 cases of surgery followed by RTCT, but with a good prognosis. So this is one of the cases in our institute of low ITF T4B disease. So these are the references.
Dr. Kalita.
Yes, sir.
These patients of T4B who were operated,
yes, sir,
was a part of clinical trial?
Sir?
Is patient part of clinical trial, or this is a routine service for the patients in the?
So it was a routine service because it was a retrospective study. So it was not under any trial.
So will there be any ethical issues involved?
Not that I know of. So this was a retrospective study of 7 years that I could get in the institute.
Okay, thank you.
I have a question. What is your view on this neoadjuvant chemotherapy before surgery? I think you do not have any patient under that column.
Yes, since it was a retrospective study, I could not get any patient of NSCT followed by surgery. But a recent paper has come in 2021. So they have said that NSCT, even if it plays a role in the low ITF disease, but in the high ITF T4B disease, it doesn't play a role. Even if there is reduction of the tumor margins or the tumor load.
Okay, we can go with the next paper, I think.
Thank you, sir.
Now, Dr. Bhuyan, can you please share your slides?
Can I proceed, sir?
Yes, sir.
Yeah, this is Dr. Vikas Jagtap, AONEI President, first year trainee at BBC Guwahati. In the following 7 minutes, what I want to discuss in this presentation is the introduction to this topic, the defects. As head surgeon, we usually have 3 parts in our duty. One is resection of the cancer, reconstruction, and skull base. This presentation mostly will focus on the defect and the reconstruction part. And coming to the defect part, as in the northeastern part of India, the most common addiction is smokeless tobacco, which causes buccal mucosa cancer followed by lateral tongue cancer. In the buccal mucosa cancer, the most common defect that usually we face after resection are paranasal and perioral. So this presentation will mostly dedicated to those defects and reconstruction of those defects. As we all know, the defects according to the plastic surgery guidelines, we say primary followed by local flap, regional flap, and free flap. This presentation mostly is based on the local flaps and their modifications. This presentation, I'd like to thank Dr. Anupam Das, who has guided me over this presentation. With this introduction, I'll go to my topic. There is nasomento-labial flap. As we say, need is mother of invention. The need is the mother of modification in the reconstruction path. So this is the modification of the already present nasolabial flap that was described in the history books from 600 BC by Sushruta, which is a part of nasolabial flap as is described in books. So while as we proceeded in the history, there was many modifications for the nasolabial flap. There came the superiorly based nasolabial flap, inferiorly based nasolabial flap, and the island flap. Depending upon the requirement and depending upon the patient criteria, the modifications are applied to the nasolabial flap. And while choosing a flap for the reconstruction part, there are many things. There are 3 things that are usually considered by a surgeon for reconstruction part. One is feasibility, affordability, and the expertise that is present at the institute to reconstruct the part or reconstruct by using that. So in this introduction, I'd like to present 2 cases that are operated in our institute by Dr. Anupam Das by using the following technique in around 60 to 70-year-old male and a female patient with perinasal and perioral defects. So this is a 67-year-old male presented to our OPD with C-T3 and 2B M0 disease of the left buccal mucosa who underwent bibuccal excision with extended supraomohyoid neck dissection. So this is the image of the defect after the resection of the tumor mass. So this defect is a classical perioral and perinasal defect. So with the kind of morbidities, she is having hypertensive and diabetic. and with the kind of mobility she is having, our options of using a regional flap and free flap are out of question, as the patient cannot undergo that much amount of anesthetic stress. So as a patient is elderly male and elderly female and with comorbidities, and to reduce the amount of stress, we have applied a modification of the nasolabial flap, inferiorly based nasolabial flap to be specific, with a modification of inferior extension to the already present inferiorly based nasolabial flap. So this is the initial picture of the 67-year-old female patient of whom the defect I was showing. So this is the flap after elevating. The superior part is the inferiorly based nasolabial flap, which is commonly used by all of us, and this is the modification that we have given so that we can have excess amount of the tissue to cover the defect intraorally and cutaneous part also by raising the two flaps simultaneously. So this is the modification that we are giving to the inferiorly based inferior nasolabial flap. So while marking the incision for the modification of the nasolabial flap, the inferiorly based nasolabial flap, which we called it as nasolabial flap, the inferiorly based nasolabial flap is marked as routinely with the medial border as the paranasal boundary, and later the nasolabial flap and base at around the defect. The marking of the inferior extension to the inferiorly based nasolabial flap is the base of the inferior extension starts from the base of the inferiorly based nasolabial flap itself, and the apex is directed towards the chin, and the superior boundary is directed towards the defect. So by marking the above, by enlisting the markings above and raising the flap, which is a faciocutaneous flap, we get the flap like a butterfly. The flap opens like a butterfly. Now this method, but in the next part of the method, what we do is we just suture the superior part of the inferior extension and inferior part of the inferior nasolabial flap together, and the inferior and the complete flap, which is like a flag, now is folded on itself medially like this, and it is sutured to the retromolar trigone. So this is the final outcome after suturing to the retromolar trigone. So the external part is reconstructed, the internal buccal mucosa part of the defect is also reconstructed. Now the superior part of the combined flap is sutured to the superior part of the defect, and inferior part of the combined flap is sutured to the inferior part of the defect. And the defect that is created by raising the two parts of the flap is closed primarily. So this is the final outcome of what we call it as nasolabial flap. So this is the intraoral part after the reconstruction of the same lady after post-op by using nasolabial flap. This is also the post-op picture. This is the picture of the patient after 2 months of the post-operative period. We have offered our commissuroplasty, which the patient has denied because she doesn't want to get operated at this elderly age. So now comes the point of why to modify, because the patient, because every center is not affording the feasibility of microvascular surgery, and every patient is not the same having the same GC, so that everyone can undergo a free flap and regional flap. So there is always a place for local flaps, and with the kind of elderly morbidities that we are having and the technique and lack of expertise at the peripheral institutes, the modifications like the nasolabial flap to the nasolabial flap, which is most commonly practiced worldwide, will provide an opportunity for the surgeons to deal with these kind of cases like elderly patients, diabetic patients who cannot tolerate excessive stress in OT, excessive duration of surgeries in the operational theater. These flaps can be used to cover the defects both intraorally and intraorally and cutaneous part also. And while reconstruction, the three important parts that every surgeon considers are the aesthetics, functionality, and patient satisfaction. And with the nasolabial flap, we have achieved the patient acceptable aesthetics and satisfaction and functionality. The patients were able to swallow after coming. Even if we apply this flap to the younger patient after giving the commissuroplasty, the patient will have good mouth opening. There was around 2 to 3 fingers of mouth opening, which can be improved by giving commissuroplasty to the patients. So this flap as we say in conclusion, what I want to say is this lab is, we propose this lab only as an adjunct to the already present recon techniques. This flap, the advantage of this flap are this can close the most commonly possible defects, which are moderate to small size defects in the perioral and paranasal defects. There is minimum post-operative stress for the patient, minimum intraoperative stress for the patient, and there is no separate surgical site morbidity. This can close the defects that are not usually closed by the nasolabial flap, and it also closes the defects that are initially closed. That can be closed by using a PMFC in a smaller part. So in it all, what we want to say is nasomento-labial flap is a good addition to the surgeon's armamentarium. Thank you. Any questions, suggestions, and comments are always welcome.
Any questions from the judges?
Yeah, it should come from the surgeons. Any surgeon?
Yeah. Hi. A nice idea. I think I'm Dr. Caleb from NEIGRIHMS, Shillong. So, what is the level of oral incompetence after the surgery in such a patient?
It's good, sir. There is no ruling. There is no treatment after giving a commercial plastic to the patient. There is no ruling and no treatment. The patient can have acceptable amount of outcome.
Okay, thank you.
So now I invite Dr. Kriti Khandelwal to share the presentation. Dr. Kriti Khandelwal.
Good afternoon. The topic of my, I'm Kirti. The topic of my presentation is outcomes of salvage neck dissections and head and neck squamous cell cancer. It was a retrospective study. It aims to see the outcomes of salvage neck dissection and head and neck squamous cell cancers. Primary objective was to look at the 5-year survival, overall survival, and recurrence-free survival. Secondary objectives were to identify factors affecting overall and recurrence-free survival, and also the morbidity associated with the neck dissection. This study was conducted in 2011 to 2016. 85 patients were underwent salvage neck dissections, out of which 73 were enrolled in the study. Overall survival was calculated from the date of the salvage neck dissection to date of the death or last follow-up, whichever applicable. And recurrence-free survival was calculated from the date of the salvage surgery to date of the regional or loco-regional failure or death, whichever was earlier. We included head and neck squamous cell cancer patients of oropharynx, hypopharynx, metastasis of unknown origin, and nasopharynx, who completed definitive treatment, that is either a radical radiotherapy or a concurrent chemoradiotherapy. The exclusion criteria was patients with inadequate data, non-squamous histology, distant metastasis, and residual primary lesion. Response assessment was done after 12 to 14 weeks of the primary treatment. Initial OPD examination was done by clinical examination and indirect laryngoscopy, followed by the upper GI endoscopy. PET-CT was done in 10 patients. In rest of the patients, metastatic workup was done with CT CT skull base to thoracic outlet and CT thorax and ultrasound outlet. Response assessment was categorized into residual and recurrent disease. Residual disease was defined as persistence of biopsy-proven disease after 12 weeks of the primary treatment up to 6 months. And recurrence was the emergence of new disease after 6 months, which was once previously proven disease free. Statistical analysis was done using SPSS 17. Kaplan-Meier analysis was used to see the overall and recurrence-free survival. And Cox regression was used to assess the risk hazards. In our studies, males contributed to the majority of the population, 78%, while females 22%, but females had a better overall survival, so this was not significant. Hypopharynx had the maximum number of cases, accounting to 46, followed by oropharynx, then metastasis of unknown origin, followed by nasopharynx. Residual lesion was found in 28 patients, and recurrent lesions was found in 45 patients. However, there was no significant difference in the overall survival between the two. The primary stage 3 were the maximum who underwent salvage neck dissections in our study, followed by 402. In 21 patients, extended radical neck dissection was done. In 26 patients, radical neck dissection was done. In 16 patients, modified radical neck dissection was done, and in 10 patients, selective neck dissection was done. Overall survival was 93%. 5-year was 31.1%, and at 3 years was around 77%. Recurrence-free survival at 1 year was 77.5%, and 5-year was 30%. Perinodal extension had a significant correlation with the overall survival. However, lymphovascular invasion, presence of lymphovascular invasion reduced the overall survival by 50%, and perineural invasion reduced the overall survival by 15%. Metastasis of unknown origin had the highest overall 5-year survival, 50%, followed by the oropharynx, which was also nearly same, 48.5%. Hypopharynx has the least overall survival. Complications were graded according to the Cleveland-Dindo grade, and complication rate was 19.7%. We encountered complications of grade 2 and grade 3A, which were successfully managed. And these complications were more in the radical neck dissection and extended radical neck dissection group, which was 87.5%. This was significant. We included just the salvage neck dissection patients in which there was no primary disease, and follow-up was a strength of the study, as we were able to do a 5-year follow-up. It was a retrospective study. There was no comparison group, and PET-CT was not done in all cases because of the timing of the study. Our overall survival was well in accordance with other studies, 5-year overall survival, and complication rates were 19.7%, similar to the other studies. So we conclude that salvage neck dissection can improve prognosis of patients in residual or recurrent head and neck cancers. Extranodal extension is a poor prognostic factor for the overall outcome, and extended neck dissections are associated with higher complications. So in certain cases where we can afford, we can go for the selective neck dissection. Thank you.
So, doctor, you are addressing the neck problem. What about the primary? None of the patients who have this residual disease or recurrent disease at the primary site?
No, sir. We included only those patients whose primary was resolved in our study.
Whose primary is total control?
Yes.
No. Can I ask one question? So, great presentation, Dr. Khandelwal. So you had talked about how during your study earlier it was done extended neck dissection and now up to selective neck dissection. So in the current scenario, what you should be doing, and can you explain the history as to why this has changed, this practice has changed?
Like for example, if the primary is an oropharynx or hypopharynx, we can well go for the 2, 3, 4 neck dissections. We can spare the level 1 and level 5 neck dissections. So studies have come up which shows that selective neck dissections have a equal survival and lesser complications as compared to the extended neck dissections. So this.
No, given a chance today, if a patient comes to you, will you do a selective for the residual disease or will you do a radical?
If depending on the primary site, if the primary echelon nodes are not in, for example, oropharynx or hypopharynx, we will do 2 to 4 neck dissections. There is no rule of, we can do extended neck dissections, but even if we do a selective neck dissection, outcomes are good enough.
So you tell me whether you do selective or more than that. That's it.
Complications are less.
No. Will you do selective or will you do more than that? Will you do just the residual disease alone removal or will you do everything? If there is a residual disease in level 2, would you do only 2 or will you add 3 and 4 also?
If it is a case of salvage, we can go for nidosectomy or superselective neck dissection. But in case of salvage neck dissections, the primary echelon nodes of the primary site should be addressed. There is a role of superselective neck dissections also, sir. But in our setup, we go for at least 2, 3, 4 neck dissections in case of oropharynx. Because we took patients who had not undergone neck dissections previously. So post RT or post CT RT patients only we took up. So that is why selective neck dissection.
Okay. No. The logic is that somebody has given radiotherapy, so the radiotherapy also has taken effect, and only the residual is there. So it's enough if you take care of that alone.
If we are doing PET CT and there is no viable tumor cells, then we can go for superselective neck dissection.
Any other questions from the judges?
You are from surgical oncology or radiation oncology?
Sir, I'm head and neck surgeon.
Surgeon. So will you take into account the amount of radiation that has been given earlier?
Yes, sir. We took account of that. We took up patients only those who had undergone a definitive radical radiotherapy or a chemoradiotherapy, like more than 60 days.
Yeah. What are the other factors that you take into account? Yes, radiation dose is one. What are the other factors?
Sir, whether surgery was done or not previously.
Okay. And one important point, at least another one important point.
For the whether it is
Anyway, it's okay. Yeah, it's a good effort, and yes, definitely is a good treatment. You know, we have to rescue post-RT failure, mostly surgical rescue.
yes.
Okay, thank you.
Thank you so much, judges. I request all the judges to share their evaluation sheet on aoneioncology@gmail.com. I have written in the chat box also. Please share their evaluation sheet on that mail ID. Now for next 6 presenters, I invite the judges Dr. Siddharth Hazarika, Dr. Paulami Mukherjee, Dr. Selim Harris, Dr. Gaurav Das, and Dr. Anupama Das to evaluation.
Or it is not now, na? It is not now.
Now our next presenter, Dr. Naveen Kumar. I request Dr. Naveen Kumar to share their presentation.
Am I doing? Am I
Yes, you're
audible?
audible. Yes, sir,
Okay,
you are
okay,
audible.
okay, okay. Thank you for giving me opportunity. And I am presenting on the management of chest wall chondrosarcoma, AIMS New Delhi experience. So it's retrospective studies, and the chief surgeon is Dr. Sunil Kumar and Dr. S.P.S. Dev, and radiation oncologist is Dr. D.N. Sharma. So coming to introduction, chondrosarcoma of chest wall is a rare soft tissue sarcoma. It is often mismanaged at community level. So suboptimal surgical interventions and high recurrence rates are often in contact due to rarity of the disease, paucity of the literature, and innocuous clinical presentation. So combined treatment and approach leads to paradigm shift in the treatment outcome. So the study is to present our experience of treating 23 cases of chest wall chondrosarcoma. So coming to material and methods. So data of histopathologically proven chest wall chondrosarcoma was retrieved from prospectively maintained thoracic surgery database and analyzed for clinical profile, multimodality treatment details, relapse pattern, and survival outcome. So a period of study was from 2008 to 2017. So coming to demographic profiles. So 74% patients were male and 26% patients were female. Mean age of presentation was 38 years, and it range from 18 years to 58 years. So most common age group was in first decade of life, and mostly patient present with the chest pain or localized pain with swelling. So coming to surgical profile, previously 35% patients had undergone some sort of surgery. Some have only excision of the lung or excision of that lesion with no any documentation. Mostly patients were surgically resectable. 22 patients were surgically resectable. One patient was found inoperable due to involvement of the great vessels intraoperatively. So coming to surgical details, chest wall resection was done in all 22 patients. 2 or more than 2 ribs were resected in 13 patients. External resection was done in 8 patients. Lung parenchymal resection was done in 3 patients. Diaphragmatic resection was done in 2 patients. 1 patient underwent scapular resection. Reconstruction was done in 12 patients with synthetic mesh plastic with vascularized muscle transposition left mostly with pectoralis major, latissimus dorsi, and serratus anterior. So bone cement was used in 3 patients, and the mean defect size was 16 centimeter, but it ranges from 6 centimeter to 30 centimeter. So these are the few intraoperative picture. In the first photograph, we can see there is a manubral resection, and this resection was reconstructed with the pectoralis major muscle, and it was resected from the insertion point, and it was transposed to the defect site. In the second picture, we can see the defect of whole body of the sternum, and in the later picture, the 2 pectoralis major were cut from the insertion site and transposed and approximated in the midway with ethibond and PDS1 suture. So coming to results, all patients had microscopic negative margins except one had microscopic positive margins. Post-operative radiotherapy was given in 2 patients. One had microscopic disease while another had microscopic positive margin. So none of the patients received adjuvant chemotherapy. Median follow-up time was 19 months. 8 patients had lost to follow-up. So this Kaplan-Meier curve shows that about 66% of the patients had 5 years of disease-free survival. 3 deaths was reported, 2 by disease recurrence and progression, 1 by non-cancer cause like some sort of CAD. So coming to conclusion, chest wall chondrosarcoma is an aggressive type of tumor and it more commonly occurs in male in fourth decade of life, presented with the complaint of pain and swelling. Surgical treatment for chest wall chondrosarcoma remains challenging. So reconstruction of the large chest wall defect can be achieved by autogenic or allogenic or combined techniques. So optimal surgical resection with negative margins and judicious use of reconstructive surgery can result in excellent outcomes. These cases should be ideally be treated in tertiary care center with expertise for successful outcomes. Thank you. So these are a few references. And lastly, a quote by Albert Einstein: anyone who has never done a mistake has never tried anything new. Thank you. Thank you very much.
Thank you, Naveen. Can you keep it at your complications, your results slide?
Yes, sir.
Can you go back to that? Because some of the judges couldn't see your slides. Okay. Where is your complications thing?
Complications, early onset complication or late onset, sir?
Yeah, both.
Okay.
How many patients were on ventilator for how long post-operatively?
Okay. So it's actually a retrospective study, and a lot of mostly patients did not go for ventilator. Mostly patients after immediate surgery, we kept these patients for ICU for 1 day for elective ventilation, not for all patients.
Okay, and like in your follow-up, do you have data of how many patients had complications after radiotherapy?
Radiotherapy, sir?
Yeah.
Only 2 patients underwent radiotherapy, sir, and there is no significant complication related to radiotherapy, like grade 1 skin toxicity was there. So only 2 patients, and no wound dehiscence or no other things are reported, sir.
What was the reconstruction done in the patients who underwent radiotherapy?
Reconstruction was in adjuvant settings and not in new adjuvant setting.
No, I'm asking the patients who received post-operative radiotherapy, what kind of reconstruction had you done, or where did you not reconstruct?
No, sir. It depends on the chest wall defect size, sir. Like if 2 ribs defect partial only.
Naveen.
Yes, sir.
Please understand my question clearly.
Yes, sir.
I'm just asking you, in those 2 patients who had radiotherapy, were they given any reconstruction with any mesh or cement, or was it without any reconstruction?
No, sir. No, sir. These 2 patients, one had microscopic disease and one has closed margin. So we have done in these 2 patients only 2 ribs resected. So we have not done any sort of reconstruction, sir. We have done only primary things.
What is the dreaded complication following use of cement and mesh together?
Yes, sir. So lung adhesion is most commonly seen in the proline mesh where the bone cement are used, sir. So we have done only in 3 cases where bone cements are used.
Okay.
So we generally use Vipro mesh in Vicryl on the inner side and proline on the outer side, sir.
Okay. Any other judges? Any other judges would like to question? Other judges? Gaurav?
Yes, sir. I wanted to know what are the margins that the surgeons attempt for.
So in grossly we take 1 centimeter margin, sir. In recurrent setting we take extra margin because we don't know whether they have done incomplete surgery or whether there is a like gross contamination. So in that recurrent setting we should advise extra margin, not in upfront setting or in the new cases, sir.
Any other judges would like to? Okay. If that is the case, then we'll move. Thank you, Naveen.
Thank you, sir. Thank you very much.
Thanks for participating and thanks for good presentation.
Thank you, sir.
Next participant.
Now invite Dr. Pallavi Kalvande to share the presentation.
Am I audible?
Yes, you're audible. Ma'am, kindly share your screen.
Showing only one participant can share. Okay. Share the screen. Is my screen visible?
Yes, very much.
Can I start?
Yes, please start.
Good afternoon, everyone. I am Dr. Pallavi Kalbande from MGIMS Sevagram. My study was about an evaluation of cost-effective nutrition supplement using homemade recipe versus commercially available formulated in cancer patients on liquid diet from the middle income group countries. As we all know, the cancer patients are at high risk of malnutrition and they may need liquid dietary support during their course of disease. And it has been reported in the literature that 10 to 20% of death are only because of the malnutrition and that contributes in the cancer patients. And especially cancer patients from the low middle income group countries, they are already undernourished and their requirements to maintain the nutritional support during the course of disease is high as compared to the other patients. And these patients also have resource constraints. So especially for these patients, that diet to maintain their nutritional needs during their course of disease and treatment, it should be cost effective, affordable, palatable, easily available, and nutritious. Keeping this in mind, we have designed a homemade recipe for liquid diet to provide 1000 kilocalorie energy per day and 90 grams of protein per day, with dietary requirements was calculated as 25 to 30 kilocalorie per kg per day and 1 to 1.5 gram proteins per kg per day for an average adult male of 65 kg. And our secondary objective was to compare the cost of homemade recipe versus other 5 commercially available formulations. Our homemade recipe included the pudina water or haldi water, then sattu powder, mixed dal water, yogurt, chicken or legume, then dalia kheer, jaggery water, soya milk, sattu powder, puran water, honey water, haldi milk. After preparing this recipe, we have calculated their protein, carbohydrate, fats, and their calorie content. And we have seen that their protein content was made as per the daily requirement of 90 gram and their calorie was made at the daily requirement of 2000 kilocalorie per day. These our homemade recipe. For the comparison, we have used 5 commonly available and commonly prescribed 5 commercial nutrition supplements, that are the Protein X, Azura, Salvida, Advitam, Nutrimax. These are the 5 brands, and we have compared among themselves with the energy, proteins, fat, and carbohydrate and their cost for per 100 gram of powder. In that, we have found that they varied for their energy, protein, fat, and carbohydrate content, and along with that, their cost was varied from 132 to 450 rupees for per 100 gram. When we looked at the each content, we found that the calorie content per 100 gram varied from 260 to 474 among all the 5 brands, whereas their protein content per 100 gram varied from 16 gram to 49 gram, whereas their fat content per 100 gram varied from 0.5 to 19 gram, and their carbohydrate content, it varied from 25 to 84 gram. When we looked at the cost of all the 5 commercial brands and compared with our homemade recipe, we found that the cost of our homemade recipe was around 10 to 12 times less as compared to that of the 5 commercial available commercially available supplements. And the cost of the daily cost to deliver the 2000 kilocalorie, the cost of commercially available preparations ranged from 746 rupees to 3462 rupees to meet the calorie requirements of 2000 kilocalorie per day. And in the same 2000 kilocalorie, we could deliver the proteins. That protein was variable, whereas in our homemade diet, we targeted the proteins of 90 gram, whereas in other commercially available brands, it varied from the 84 to 231 grams. Thus, we have concluded that the homemade recipes can be designed to adequately meet the dietary requirements for cancer patients on liquid diet, and it can be highly cost effective. It can be adapted according to the local customs and the individual choices. It will be most useful, especially for the low middle income group countries, and it can be used as a supplementation along with the commercial nutrition formulation depending on the available financial resources. Thank you.
Yeah, excellent presentation, Dr. Pallavi. The other judges, Paulami, are you there? Paulami, Dr. Siddharth, anybody can ask questions, please.
Hello, Dr. Pallavi.
Yes, sir.
Can you hear me?
Yes, sir, I can.
Yeah, it was a very nice presentation, and your layout and everything was quite well. I think to make the presentation more objective, it would have been great to see if you could have given in the range of improvement in hemoglobin level, improvement in albumin level, and weight gain. So these things I think should have been added in your study to make it more objective kind of thing. The comparison that you have done is mostly the amount of calorie and the affordability thing, or the price per calorie kind of thing you have done. But to make the study more exciting, I think the other things could have also been added.
Yes, sir. This study is ongoing. We have started implementing after preparing this formulation. Now we have started using on a patient, and patient recruitment is ongoing. Soon we will be publishing the results of our impact.
And is it possible to feed patients on nasogastric tube these formulations that you are making? Is it possible to feed them too?
Yes, sir. Yes, sir. It's a total liquid formulations, and it was designed for the liquid diet only, so it can be easily given through the nasogastric tube also.
Okay.
Okay. Thank you.
Yes, go on. Yeah, like I would just mention again what Dr. Anupam mentioned. That's a really good thing. I'll just ask the question in a different way. So if you are doing a study like Dr. Anupam asked, if you are doing this study in vivo in the patient, so then what will be the endpoints you'll be looking at?
At present, we have designed a study, and there we are looking at the mean weight gain, hemoglobin level, and their proteins at the start of treatment or at the start of the supplementation, and then we'll measure at every 1 month, 3 months, and then 6 months.
Okay. And what is that sattu powder you had mentioned in your dinner?
Sattu powder, it is local ingredient which is made up of the soya beans, chana dal, the gehu, chawal. All ingredients will soak for a night, and then they will be dried, and after dried all will be grinded up, and the powder will be made of all this. The equal quantity of each ingredient will be included.
Okay, thank you.
Hi, though I'm not a judge, can I ask a question?
Of course, please.
Dr. Pallavi, so you have given eggs and chicken as the main protein source in your diet. Suppose if the patient is vegetarian, so what are you going to replace that with?
Yes, sir.
With an equal amount of, the protein value.
Yes, sir. Actually, egg and chicken are optional, and there is another option in veg. We have mainly included the soya milk, which is the richest source of the protein, and another one is the sattu powder and the puran water that you must.
The powder is what made out of gram.
Pardon, sir?
The sattu powder. What are you making it out of?
Yeah, that's what I just told, sir. Sattu powder, we are using the ingredients with the soya bean, chana dal, moong dal, tuar dal, gehu, and rice. All the ingredients will be mixed and then grinded, and the grinded powder will be made of all these ingredients, and that will use will form a liquid form of that in water or in a milk, and then that will be given. Another is the soya milk.
Okay.
Yeah. Anybody else? Paulami or others? Dr. Siddharth? Okay. Meanwhile, what will be the modification required if you have to give it as a jejunal feed? Jejunal feed.
Not much modifications. If we are just starting just after the jejunostomy, for the few days, we'll avoid the high proteins one. We'll just start with the only liquid diets with less protein. Afterwards, if patient is tolerating well, then gradually will increase to the soya milk. Will add soya milk and sattu powder. Will add gradually after if patient is tolerating this foods first, then we'll add.
Thank you. Then excellent presentation. I think we can move on to the next candidate.
Thank you, sir.
Dr. Pallavi, can you stop share your screen? Now, Dr. Rohan,
My screen visible, sir?
Yes, visible. Yes, it's visible.
Good evening, everyone. I am Dr. Rohan Doke, MCH resident, surgical oncology from Bhuyan Cancer Institute, Guwahati. The title of my paper is Morbidity Following Groin Dissection and Malignancies, which remains a challenge in experience from Northeast India. By this study, we aim to study morbidity and complications associated with groin dissections, which is traditionally seen. And we have seen that a lot of surgeons hesitate while performing groin dissections for node-negative groin especially. So we've just tried to analyze these morbidities and complications associated. Materials and methods. It is a retrospective observational study. Study period being from 1st of January 2016 to 31st of December 2019. Patients who underwent inguinal and ilioinguinal block dissection for diagnosis including cutaneous malignancies of the lower limbs and cancers of anal canal and penis were included. Complications were recorded using proforma to note down demographic details of the patients, the history of tobacco use, comorbidities, tumor stage, use of chemotherapy and radiation, and the type of lymphadenectomy done was noted. The incidence and spectrum of complications in our series was compared to the existing literature. Perioperative and post-operative antibiotics, elastic plate bandage and stockings were used, and closed suction drains in subcutaneous low molecular weight heparin till mobilization of the patients, which were used in all cases. This is a table showing the demographic characteristics of the patient. A total of 79 patients were included in the study. The most common diagnosis that we had seen in our patients was malignant melanoma of the lower limb, seen in about 34 patients. And the age of the patients, a lot of patients, 48 to be a number, were more than 50 years of age. And there was a male predominance of 64 patients. And some patients also had comorbidities, including diabetes, hypertension, which are 3 and 2 respectively. Coming to tobacco use, 33 patients had history of tobacco use. And 3 patients underwent neoadjuvant chemotherapy, and 7 patients also had post-operative radiotherapy. The nodal disease burden which was seen, most of the patients, about 51%, had palpable discrete mobile nodes. 29% had non-palpable nodes, and nodal mass or matted nodes were seen in about 20% of cases. The type of surgery done. Superficial inguinal dissection was done in 25 cases. 46 cases underwent radical inguinal dissection, and 8 cases of ilioinguinal block dissection were done. The complications which we observed, lymphedema was the most common one, which was seen in about 24% of the patients, followed by skin flap necrosis, seen in 17% of patients, and wound infection in 16%. This is a table comparing the morbidity seen in our study to the various existing studies. You can see that lymphedema is a predominant complication seen in most of the cases. And the other complications are infection and seroma formation. So in conclusion, I would like to say that the reluctance to advocate inguinal lymphadenectomy in patients with node-negative groins that stem from the morbidity of the procedure. And although in recent years, post-operative complications have been reduced by improved perioperative care as well as technical modifications of the procedure. Thank you.
Yeah. Thank you, Rohan. The content was very good. But I think next time you should have a bigger size fonts when you pick up the slides. Even to check your name, it was with great difficulty we had to do it. So coming to your presentation, you said that the maximum complications are like lymphedema and
yes, yes, sir.
Yeah. What are the ways to lymphedema, seroma?
Sir, lymphedema prevention, you can use elastic plate bandings, stockings, and the extent of dissection can be modified, such staying medial to the femoral artery and trying to preserve the long saphenous vein, and the extent of the flaps raised that can be lesser.
So for seroma, what can you do?
You can apply tight compression bandages, sir, to prevent seroma.
Will tight compression, any other, in how many patients did you use flaps?
Yes, sir. Flaps also is another option which you can use, sir. TFL flaps.
Any other flap apart from TFL?
Sartorius.
Anterior lateral thigh flap also can.
Anterior, yes.
Okay, anybody else? Other judges, please ask questions. You'll have to be quick. Yes, Dr. Ganesh Das, please ask.
So all are all inguinal dissections are therapeutic or prophylactic also?
Sir, some of them had groin node negative, so some were prophylactic also.
Prophylactic. What are the indications in this study?
Sir, most commonly we had malignant melanoma of lower limb, squamous cell carcinoma, carcinoma penis, and anal canal, sir.
Okay. So what are in your institute? What are the indications for prophylactic lymph node dissection? Any criteria or what are the cases you will observe? You will not do a groin dissection. Do you have any protocol?
Sir, we do practice sentinel node biopsy also in our institute. So we can do a sentinel node biopsy and then, if needed, proceed or stop the procedures.
No. In melanoma, any case where you don't do nodal dissection in prophylactically, or always you do?
Always we have, because the cases that we have seen are advanced only. Most of them with palpable nodes.
No. I'm talking about the negative groin, ultrasound and clinically and ultrasound also negative groin.
Yes.
That is the case basically. I'm telling you for the prophylactic lymph node dissection.
Yes, sir. We prophylactically we do superficial and send for frozen sections.
Okay, then.
Then depending on the report of the frozen section, then we proceed or stop the procedures.
Okay.
Rohan, what was you said you were doing sentinel node biopsy? What is your institute false negative rate?
False negative. Pretty sure.
Okay, you should analyze your data to tell what is your false negative rate. Okay, I think we are short of time. We'll go on to the next presenter. Thank you, Rohan.
Thank you, sir.
Next, I'll invite Dr. Ravindra Das to share the presentation. Dr. Ravindra Das, kindly share your screen.
Is my screen visible?
Yes, it's visible. Please go on.
First of all, a very good evening to my respective judges. So I'm going to present my paper. The topic is high-risk human papillomavirus and Epstein-Barr virus prevalence status in the oropharyngeal and hypopharyngeal cancer patients of Northeast India. So, as you all know, there are certain cancers in the head and neck region which are associated with oncogenic strains of viruses like human papillomavirus and Epstein-Barr virus. This particular oncogenic virus-associated head and neck cancers, they show or they display different etiological and pathological behavior. And as we all know, the northeastern region of India has a high incidence of hypopharyngeal and oropharyngeal cancers. So we took up this study, and the main aims and objectives of the study are to see the prevalence of high-risk human papillomavirus infection in oropharyngeal and hypopharyngeal cancer patients of Northeast India. Secondly, to also to find out the prevalence of Epstein-Barr virus infection in oropharyngeal and hypopharyngeal cancer patients in North India. And lastly, this viral infection, how it is associated with the lifestyle factors. So coming to the materials and methods, the study was conducted in the Department of Head and Neck Surgery, in our institute, that is Dr. B. Bora Cancer Institute, from 1st April 2019 to 31st March 2020. In this study, we included 77 patients, and out of these 77 patients, 34 were hypopharyngeal carcinoma patients, and rest 43 were oropharyngeal carcinoma patients. And tissue samples were collected from these particular patients, and they were analyzed for high-risk HPV DNA and EPV DNA using the PCR method. And lifestyle and dietary associated factors were collected through a self-designed questionnaire. Now coming to the results. First of all, the characteristics of the patient. In our study, we found that 65 of the patients were male, whereas the rest 12 patients were female. There were, as I already told you, there were 34 patients in the hypopharyngeal group and 43 in the oropharyngeal group. And the mean age of the sample group was around 56 years. Dietary habits and their lifestyle factors. Majority of the patients, that is around 88.3% patients, they followed non-vegetarian diet, while the rest, that is 11.7%, followed vegetarian diet. In our study, we found that among the bad habits, tobacco consumption was the most common bad habit seen among the population, that is around 70%, followed by alcohol consumption, betel nut consumption, and smoking habit. Whereas both alcohol and tobacco habit were found in 57% of the total population, whereas both alcohol and smoking habit were found in 62% of total study population. So coming to histopathological characteristics, commercial carcinoma was the only histological type found in our study, and in this histopathological feature, we found that moderately differentiated commercial carcinoma was the most predominantly found feature. Now, coming to demographic profiles and its association with high-risk human papillomavirus positivity. The whole study population was grouped into HPV positive and HPV negative group based on the presence of high-risk human papillomavirus DNA and its association with certain factors like age, gender, dietary habits, and other bad habits were analyzed, and it was seen that there was a significant association between high-risk human papillomavirus infection and alcohol consumption, basically in hypopharyngeal cancer patients, whereas there's no significant association seen between other factors. In oropharyngeal cancer patients, there's no such significant association was seen. So similarly, the study population was grouped into EBV positive and EBV negative based on the presence of EBV viral DNA, and their association in other factors were analyzed. So out here in the oropharyngeal cancer patients group, there was significant association between betel nut consumption and the EBV infection. And the hypopharyngeal cancer patients group, there was significant association between tobacco consumption and the EBV infection. So coming to the conclusion, from our study we can conclude that since the high-risk human papillomavirus infection is seen to be more prevalent in the alcohol consumption group, this particular habit or alcohol consumption may act as risk factor for HPV infection in hypopharyngeal cancer patients of Northeast India. And in our study, we have seen that the prevalence of high-risk human papillomavirus is not found in majority of the oropharyngeal cases. But since our sample size is a bit less, by analyzing in a larger population, the result may show variation, and it may also be possible that high-risk human papillomavirus infection is in oropharyngeal commercial carcinoma is low in our northeastern population. Thank you.
Thank you. The judges, anybody else want to ask questions?
Rupjyoti.
Yes, sir.
Rupjyoti.
Yes, sir.
Did you just look for the presence or absence of this thing, or did you go for the viral loads? Like for EBV DNA in oropharyngeal cancer, did you go for the presence or absence of viral loads, or just present or absent?
No, sir. We just went for the presence of the EBV or HPV DNA. So we didn't look for this viral loads. So we just wanted to, in our study, we just wanted to see the prevalence of those EBV infection or HPV infection in the cancer patients. Like, so.
I'd be interested to know what is.
Yes,
hello?
sir.
Hello.
Yes, sir.
Dr. Das, you can go ahead. You can go ahead here with your question. Dr.
Oh,
Anupam,
yes, sir.
you can go ahead with your question. After that, I will ask.
Okay, sir. And in this group of patients, did you see what was the response assessment? Because these were like 2019 patients. So at least did you go for any response assessment in relation to the HPV or EBV status of the patient?
Yes, sir.
Did you find
yes,
any
sir.
difference?
So sir, in this particular study, I have not included the response status, but I'm still working on another paper where I'm looking for the response assessment of this particular group of patients. Sir.
Okay. And why nasopharynx was not included in the paper?
Sir?
Yes, sir. Sir, go ahead.
No, I'd like to know from Dr. Das, Dr. Rupjyoti Das,
Yes,
because there are many different strains of high-risk human papilloma virus. How many strains were studied in this series?
So, sir, as you know, sir, there is a low risk types as well as high risk types, sir. So under
No,
high
there are
risk,
different high-risk type of virus. No? There are different types,
yes,
16, 18, 31, 34.
Sir, there are HPV 16, HPV 18, or HPV 31, 32, which are considered to be high risk types. The in our study, HPV 16 was the most commonly found strain, sir. HPV 16.
Did you also utilize immunohistochemical studies to detect the HPV 16, which is cheaper, which can be done easily?
Yes, sir. Yes, sir. We went for we went for P16, which can be determined by sir IHC method, sir.
So Dr. Rupjyoti Das.
Yes, sir.
How can you explain the higher incidence of HPV with higher intake of more use of alcohol? What is the relation? No, you said like the prevalence of HPV was higher among those people ingesting alcohol, right?
Yes, sir.
Among the group of people who took alcohol. So what is the relation? How is it? How do they get higher incidence of HPV?
So, sir, as we know, sir, in HPV infections are there's inactivation of the treatment suppressor genes like P53 and retinoblastoma pathway. So alcohol consumption must have some impact on that particular pathway, which might have contributed to the effect, sir.
Okay.
Okay. One last question, Dr. Rupjyoti.
Yes, sir.
What is the clinical implication of doing HPV testing in today's practice?
Sir, it's nowadays it is very important to go for HPV testing because we can categorize into HPV positive and HPV negative because HPV positive patients tend to have a better prognosis and they're more radio sensitive tumors, and though they're basically prevalent in young patients with without any smoking history and also.
No, I'll rephrase the question. So if a patient is HPV positive, will you change the treatment in any way as compared to a HPV negative patient?
No, sir. No, sir.
Okay.
What does the current literature review on the HPV virus infection in hypopharyngeal cancer? Like we know that in oropharynx, it's an important predictive factor. In what is the take on literature in hypopharyngeal cancers?
So there's not much literature on HPV.
Yeah, it's not a according to most of the literature, it's not a very significant association between hypopharyngeal and hypopharyngeal cancer, and there are not many trials assessing the role of HPV and prognosis in the hypopharyngeal group of tumors.
Okay, there are no more questions. Then we'll move on to the next presenter. Thank you, Rupjyoti.
Thank you very much, sir.
Dr. Rupjyoti, can you please stop share your slides? Now I request Dr. Dipen Mistry to share their slides. Is Dr. Dipen Mistry present?
Hello, Dr. Bhavan is there? Ravindra.
So now I invite Dr. Jahanavi Das to share their slides and present their paper.
Yes, ma'am, I have shared my slide. Can you see?
No, we are not able to see your slides. Can you please stop share and again share your slides?
I had shared my slide. Ma'am, can you see now?
Yes.
Yes, now your slides are visible.
Good evening, judges and my colleagues. Today, I will be presenting on the dosimetric study and acute toxicity of adaptive radiotherapy for locally advanced head and neck cancer, which is done in our institute, State Cancer Institute, from the Department of Radiation Oncology. And my co-authors are Dr. B.C. Goswami, Dr. Smriti Goswami, ma'am, Dr. Pankaj, Dr. Vikashri, and the physicist Louis Das. So the aim objective of the study is, since adaptive RT is a promising model to improve the rates of xerostomia and coverage in the individuals who experience significant volumetric changes during radiation. So my main aim and objective of the study is to evaluate the changes in the radiation dosimetric parameters of the target volume and the organometrics during adaptive radiation treatment in locally advanced head and neck cancer. And the second objective is to evaluate the acute toxicities during and after adaptive radiotherapy. So this study is a hospital-based prospective study which was conducted from April 2020 to January 2021. So we had included histologically proven head and neck cancer patients, stage 3 to 4, and whose ECOG performance status is less than or equal to 2. I had excluded from my study as history of previous irradiation, metastatic disease, patients with recurrent disease, post-operative head and neck cancer, performance status more than 2, and patients who had received induction chemotherapy. So a total of 10 patients who had received definitive intensity modulated radiation therapy to the head and neck regions were evaluated for the study. So first we had taken the CT scan of the patient, we had simulated the patients, and then images were transferred electronically to our planning system, which is Monaco version 5.1 for contouring and planning. After the acquisition of the CT images, target volumes, OARs, were contoured in the planning CT. Then images were acquired, that is midway during the radiation, that is during the 22nd fraction during the course of radiation therapy. So I had controlled the body contours, target volumes, and organs at risk, which were redrawn on the new set of images, which I had taken during the 22nd fraction of radiotherapy. There were 2 sets of additional treatment plans generated. One is a non-optimized plan, that is the plan 2. In the plan 2 consisted of the overlay of the original plan, that is from the plan 1 on the new set of the contours, and an optimized plan, that is plan 3, with a new set of contours. These 3 set of plans were then compared for dosimetric differences. It will be more clear in the following slide. So figure A is the baseline contour. So this case is a case of C nasopharynx stage 4. So here I had contoured the node as well as the DTV. So this is the baseline contour, and during the 20-second fraction of RT, I had re-simulated the patient. Means again planning was generated. So this is the patient B, and from this the contours of image A was then overlaid to the B, and in another set, that is the second contouring, that is the second set of CT, I had redrawn the contours again. So in this B option, B is the non-optimized plan and C is the optimized plan. So the statistical analysis was done using SPSS version 17, and the p-value of less than 0.05 was considered as significant. So coming to the results, there are 4 patients had locally advanced nasopharyngeal cancers, and 4 patients had locally advanced oropharyngeal cancers, 2 patients had locally advanced hypopharyngeal cancers. So coming to the volumetric changes, first I have the target volume. So there is a reduction of the target volume. Here GTV is the gross tumor volume, CTV is the clinical target volume, which consisted of the microscopic disease, and PTV will consider the setup margins. So here you can see that the original CT volume is 107.68 cc. While doing the replanning, the GTV volume has decreased 70.58. So there is a percentage volume of reduction is 34.45 cc. Coming to the CT volume is 837.65 cc. Replanning CT is 691.54 cc, and the percentage volume reduction is 17.44 cc. Coming to the setup error, that is the PTV margin. So the original CT was 1512.32 cc. Replanning CT was 1148.25 cc, and percentage volume of reduction was 24.07%. So we can see a huge difference between the original CT and the optimized plan. That is the replanning CT. So if we do not redraw the structures, there will be a miss of the target volume. Now coming to the parotid volume changes, in the original CT, the parotid volume was 21.77 cc, replanning 15.83. So there is a reduction of volume of around 27.28% in the right parotid. Left parotid 19.60 cc original CT volume, while the replanning CT volume was 14.11 cc. So percentage volume of reduction was 28%. Now coming to the dosimetric effect of the PTV and the OARs between the plan 1 and the plan 2. Plan 2 is the plan 1 is the original plan, and while the plan 2 is the unoptimized plan where we do not make any changes. So first I will so coming to PTV, that is D99. This D99 is a dose received by 99% of the volume. In plan 1 it was 98.68, while we had missed a target in plan 2. It is around 89.64. And it is significant, p-value is significant. I won't go through all the parameters. So it's a PTV D99, I already said. Then coming to the right parotid, is the D mean is 63.15 in the plan 1, while it is 68.69 gray in plan 2. So we can see that plan and plan 2, in the unoptimized plan, the parotid, right parotid is receiving a higher dose, but the value is not so significant. So coming to V26 of the right parotid, so 67 V26 is the volume receiving 26 gray. So 67.20 gray is in the plan 1, while in the V26 of plan 2 is 74.96. So there is higher dose received by the volume, higher dose received by the volume receiving 26 gray in the right parotid. Now coming to the left parotid, the D mean is the mean dose received by the left parotid in the plan 1 is 63.09, while in the unoptimized plan it is 68.2, which is significant. Z is 0.05. V26 was 69.7 gray in plan 1 and 77.97 in plan 2, that is unoptimized plan. Now coming to the spinal cord, so we review the Dmax, that is the maximum dose received by the spinal cord. In plan 1, it is 58.96 gray, while in the unoptimized plan, the dose received by the spinal cord is 68.76 gray. Similarly, coming to the brainstem Dmax, that is the original plan, it is 65.16, while in unoptimized plan, it is 70.51. Now comparing the PTVs and the OARs from plan 2 to the, that is unoptimized plan with the optimized plan. So come to PTV D99, that is the dose received by 99% of the volume. The plan 2 is 89.64. That is dose received by 99% of the volume is 89.64 in the unoptimized plan and 98.65 in the optimized plan, and which is significant, that is 0.04.
Ma'am, you have 1 minute left.
Okay, ma'am. So coming to the skin reactions of the patients during and after RT. So grade 1 skin reaction was more in the first week and the second week. Most of the patients had grade 1 reactions, and mucositis was more during the 5th week of the radiation RT, and during follow-up there was no mucositis. So replanning between the RT for the lesions in the head and neck regions was useful in the selected patients, and large tumors that have significantly decreased in the size leading to changes in the body contours and potential using of the immobilization devices during the course of the RT. The worst grade of skin reaction during RT was grade 2, and during follow-up was grade 1. And the worst grade of mucositis during RT was grade 2, and during follow-up, and no mucositis, only dryness of the mouth persisted during the follow-up. Thank you.
Any questions from the judges?
Yes, I think all the judges are surgeons. So any other radiation oncologists, maybe you should ask some questions. Maybe Dr. Ashish. Or other surgeons also. Gaurav, anybody else can ask also.
So should I call next, sir?
Yeah. Yes. Okay. We can go on with the next presentation.
So
wait, one minute, Dr.
It's okay. It's okay. It's fine.
Sir, please ask.
No, it's okay. She has presented very well.
Okay. No.
Go ahead.
One question, sir. It's a competition, sir.
Yeah. She has done well.
Okay. Okay. Thank you.
You can call the next speaker.
Okay, now Dr. Abdul Wahid, can you please share your screen and start the presentation?
Yeah, please, ma'am. Yes, ma'am, I'm audible.
Yes, you are audible, but please share your screen.
Yes. It's okay.
No, we're not seeing it.
We are not getting your slide. Please share your screen.
So, I'm trying, sir, but
Dr. Abdul, I am sharing your slides. Just tell me next when you need to share the next slide.
Please.
You can start, Dr. Abdul.
Very good evening. So I'm presenting is the prospective study that is a paclitaxel-induced acute pain syndrome. So next, please. Introduction, paclitaxel is an antineoplastic agent used in solid tumors like portion of esophagus or ovarian lung, breast and head and neck cancer or other solid tumors. It has been known since 1993 that treatment of paclitaxel can immediately induce pain syndrome in patients. More recently, such pain is defined as a PAP, that is a paclitaxel-induced acute pain syndrome. So PAP is characterized by its earlier onset, maybe develops within 1 to 3 days after drug administration, and is a short lasting period, usually resolved within 7 days. Presenting symptom includes numbness, paresthesia, and burning pain in a glow and speck distribution. Patient commonly reports the simultaneous onset of the symptom in cues and figures. Next, please. So, aim of the study is to describe the incidence and characteristic of paclitaxel-induced acute pain syndrome, to assess the change in pain related to paclitaxel dose and number of cycles. Next, please. Next, please. Inclusion criteria is patient with documented case of malignancy, patient with age of at least 18 years old, patient able to provide a written and informed consent, and patient with life expectation of more than 6 months. Exclusion criteria is patient who did not give any consent or patient who have known psychiatric disorders. Next slide, please. So material and methods, and the study was a prospective one in which we include eligible patients scheduled to receive taxane weekly dose or 3 weekly dose. Weekly is the 45 to 50 milligram per meter square, or and 3 weekly 175 to 200 milligram per meter square. Patient report outcome of acute pain were collected and evaluated. Participants for the study were all the patients who received paclitaxel as their primary chemotherapy agent. Patients were asked comprehensive history about their symptom and timing of symptoms after each cycle of chemotherapy received. The most sensitive and reliable method of detecting paclitaxel-induced acute pain syndrome is by history, with specific attention to pain questionnaires. These questionnaires were derived and adopted from the Lance pain scale. Next, please. So total 200 untreated cancer patients were enclosed in the study, whereas because of the various regions, only 195 patients were variable for this analysis. Next, please. So far as the demographic profile is concerned, majority of the patient, that is a 29.6, is more than 61 year of age. The mean age is 54 to 0.17. However, females are more in numbers than males. Next, please. So far as the malignancy is concerned, majority of the patients have esophagus, that is a 42.3%, followed by breast, followed by lung, and least to most is stomach and nasopharynx. Next, please. So far as chemotherapies, in this trial, we have one group, is there some patient receives the taxane only, or some receives the taxane plus carboplatin. It has been found that 76.5% receives a combination of chemotherapy, either weekly or 3 weekly. There's a paclitaxel and carboplatin. However, when we compare the weekly and 3 weekly, it has been found 61% receives weekly protocol as compared to 38.77 receives 3 weekly protocol. Next, please. When we compare with the 3 weekly and weekly, it has been found 65% in 3 weekly protocol receives combination of chemotherapy, that is a paclitaxel plus carboplatin. And however, in weekly protocol, there is a 60% receives taxane-based chemotherapy alone. Next, please. So far as when we compare with the chemotherapy alone and concurrent chemo radiation, any difference in the, it has been found there's as such no difference development of symptom who receives concurrent or who receives concurrent chemo radiation. There is radiation as so far has no effect on whatever the patient reports during the chemotherapy or after chemotherapy. So it is a chemotherapy which induces this pain symptoms. When we compare with the taxane alone and taxane plus carboplatin, it has been found that there is 43% of the patient who receives combination of chemotherapy develops more pain as compared to who receive alone taxane. Next, please. And that was statistically significant. So far as the onset of symptoms, it has been found day 2 is one of the most common presentation for development of symptoms. When we compare with the 3-weekly protocol and weekly protocol, it has been found both the groups, whether received 3-weekly or weekly, all majority of the patients present at the day 2nd with chief complaint of pain. Next, please. So majority of the patients present with the pain pricking sensation, followed by dull ache pain, followed by burning sensation. However, the location is most common location is knee, followed by lower limbs, followed by hands. Next, please. So far as the duration is concerned, it has been found majority of the patients develops the second day pain, but it remain maximum it's up to 5 days, and after 5 days subside subsequently. But when we compare with the single drug versus combination of drugs, it has been found that those who receive a single drug, the duration is very small, there is less than 3 days. And those who receive a combination of the drugs, there's a peptide they develop remain symptomatic for more than 4 days. So this gives us clues that scopolamine have some roles which have addictive effect for this pain syndrome. Next, please. We use in this study a Lance pain scale. According to Lance pain scale, there's a 15 numbers. Those who have more than 14 number, that means the patient have nephropathy type of pain. This is a hypothesis. As compared to those who have less than 14 or less than 12, it's look like a myalgia. In our study, a majority of the patient, that is the 57.14 patients have 8 to 10 numbers in scale range 8 to 9. So that majority of the patients have this this pain because of the myalgia. This is a hypothesis. As compared to for 25% of the patients who have more than 14 scores, so it reveals that this 25 patients develops pain because of the neuropathy. But these 25% of the patients, those who have more than 14 scores, it has been found all these 25% receives the combination of chemotherapy as a paclitaxel plus carboplatin, and they all those have 3-weekly protocol. There is a taxane who have the higher dose, more than 175 milligram per meter square. They have some relation with the neuropathy, and those with less dose, there is a 45 to 50 milligram weekly protocol that have some relation with the myalgia. Next, please. So conclusion, clear this current prospect study at the understanding of the PAP is patient treated with chemotherapy, which is quite bothersome side effect and can often lead to stop or discontinue potential curative chemotherapy in cancer patients. To sum up, the following conclusion I drawn from this present study: the incidence and characteristic of pain is related to paclitaxel dose and number of cycles, and subsequent cycle of paclitaxel is having no effect of intensity of pain syndrome. And duration of pain increase if patient receives a combination of taxane and carboplatin, and addition of radiation is having neither synergistic nor protective effect in our study. In addition to that, this study help us to that the patient who receives, when we treat the patient as a curative intent or palliative intent, the aim is to make the life smoothing, less comorbidity, less side effect of the drugs or other target therapy. This will help us to use some prophylactic treatment so that patient complains very less with this pain. Next slide, please. Thank you very much.
Thank you, Dr. Abdul. Very nice presentation. Can you explain how you are planning to apply these learnings in your practice? In what way is this study clinically relevant?
So actually, this is an observation study. So as usual, we are using the taxane in or wire solid tumors, majority of tumors. But when we during the follow-up at the end of the week or monthly, patient complains there's a pain, there's a knee, hand pain, and we have correlate with this. This is a taxane which causes the pain. There is a taxane is known to cause pain rather than other taxane or alkylating agent or other drugs. So we have to observe these are taxane which cause the pain. So we use some prophylactic so that stop this painful event during the chemotherapy, make smoothing events, smoothing during duration of the chemotherapy time.
Okay, thank you. Any other judges want to ask any questions?
Good evening. Hi, Caleb. Sorry, I joined late. This is Follow Me. Am I audible?
Yes, Paulami, please go on.
Yeah, I just had to add a small question. It's more of a continuation to what you asked. How do you differentiate a neuropathic pain with a myalgic pain?
Ma'am, we use a Landspace scale. According to Landspace scale, is a hypothesis. Landspace scale reveals that if patient who have more than 14 scale numbers points, so it is some neuralgia somehow, but it's not proved. It's a hypothesis. Those who are then 14 or 12 is myalgia. But there are the various studies which shows during the taxine, when we treat the patient with the taxine, there are various hypotheses related to protein-related PRA proteins, which act on the neurons, which cause neuropathies. There are various proteins which act on this Schwann's. It's called this demyelination. So this reveals that taxine has some role with neuropathy as well as myalgia, but it's a hypothesis, not proven yet.
Right. So when you have when you're going to give prophylaxis to the patient, do you cover for both neuropathy as well as myalgia?
In our practice, we are now presently using this multivitamins and duloxetine as prophylactic, and patient responds very well, and less number of patients complain with these pain.
And duloxetine, it helps in myalgia as well.
Not it helps as such neuropathy.
Right. Right. Okay. Thank you very much.
Okay. Any other judges want to ask questions? Okay, if there are no more questions, then we'll move on. Thank you, Dr. Abdul, and thank you to all the participants. We appreciate that you come forward and participated. And please join in tomorrow to know the results. Tomorrow evening during the valedictory, we'll have the results being announced. Thank you so much, and please all the residents, please participate in the quiz which is there also. And we'll move on to the next session. I would like to invite the chairpersons. I'd like to invite Dr. A.C. Kataki, the director of B. Burua Cancer Institute. It's always a pride to have him here, and he's been a very dynamic director of B. Burua. Thank you, sir, for being here. Thank you. And we also invite Dr. Tomcha Singh. Dr. Tomcha Singh is a ex-professor of the Radiation Oncology Department of RIMS in Imphal, and now he is a senior consultant in the American Oncology Institute in Imphal. Thank you, sir. We welcome you. And we also have Dr. Arup Roy Burman. He is a consultant radiation oncologist at the RCC, which is in Tripura. Welcome you, sir. Thank you. And I request the chairpersons to take it forward with the next session, which is the session on prostate cancer. Please introduce the speakers and we can go on. Please unmute yourself. Okay. Okay, I think we've lost them. So meanwhile, we'll get going with the session. It's glad to see Dr. Vedang Murthy. So it's always a pleasure to hear Dr. Vedang Murthy. He's a professor in the Department of Radiation Oncology, and he specially concentrates on genitourinary cancers. And another piece, he's an avid marathoner. He has done a lot of marathons. He goes all over the world running a marathon. And he's visited Northeast also several times. It's always a pleasure to hear you, sir. Please. Go on, sir.
Hi, Caleb. You're looking very dashing. Nice to see you.
Thank you, sir. Thank you.
Thank you to Northeast Roy for the invitation, and it's a pleasure to be here. I know Vikas is not here. He's the one who invited me originally. I'll be talking about the dilemma of radiotherapy in metastatic prostate cancer. And just to give an overview, In metastatic prostate cancer, radiotherapy has a long established role for palliative treatment. And not going to talk about that. You all are aware of this, and and you've been doing it for several decades now. So, what I'll be talking about is what we call, in inverted commas, curative intent, or treatment for longer term control or improvement of survival or outcomes. And that is what is exciting and new right now. And this could be local, nodal, or for distant mets. And this leads to a lot of dilemmas that I'll try to answer some of them today. So before we start, let us get some definitions out of the way. Metastatic prostate cancer, M, has got M1A, M1B, and C. M1A is non-regional lymph nodes that includes common iliac and mainly para-aortic. This is a misconception often certainly students have, that common iliacs belong to the pelvis. In prostate cancer, unlike bladder cancer, they don't belong to the prostate. They belong to M1 category. M1B is bone and M1C is other sites. The standard treatment for metastatic prostate cancer, for those who don't know, has been ADT alone over the last several decades, and the median survival is about 40 to 45 months. More recently, there is evidence, very, very strong evidence, that these patients would benefit with adding either abiraterone or docetaxel, increasing their median survival to about 52 to 55 months. So this kind of maximal ADT is called the standard of care today. There are some other definitions that you'll come across in the literature or when you're hearing enthusiastic uro-oncologists talk. We talk about metastatic either as oligo or polymetastatic. We talk about burden of disease, low or high burden, and we talk about hormone sensitive prostate cancer and castration resistant prostate cancer. To try to define what oligometastasis is, a whole lot of people from around the world got together a couple of years back in the Advanced Prostate Cancer Consensus Conference. I was fortunate enough to be there at that time. They asked a very simple question to the panelists. What is your cutoff for the number of metastases to consider a patient as oligometastasis? First, to define oligometastasis. And the options were 2 or less, 3 or less, 5 or less, or we don't know. The consensus was defined as if 75% of the respondents agree, but this did not reach consensus, but a large majority said that they consider 3 or less as a definition for oligomets. There is another definition that one must be aware of, that is based on the volume. And this comes from a trial called Charted. This was a trial that looked at the benefit of adding docetaxel to ADT in metastatic prostate cancer. And they defined high or low volume. High volume is defined as 4 or more metastases, and one of them should be outside the vertebral column or the spine, that is the axial skeleton, or they should have visceral metastasis. Anything other than that is low volume. So if a patient has 20 lymph nodes anywhere in the body, including supraclav, that still constitutes as low burden disease according to Charted. Latitude is another trial that has looked at defining burden by risk features based on the number of mets, visceral mets, and Gleason score. Why are we talking about this? Because we are detecting more and more patients with oligometastatic disease, because we are doing more and more scans. There might be some stage migration as well. We are doing more PET scans, PSMA PET scans. Vikas told me that we have started doing PET scans in Assam as well. I may be mistaken, but that is what I believe. And this is only going to increase. There is also a biological basis for this oligometastatic, and it is theorized that this is different from polymetastasis, not only in biology, but also in how it occurs. So there is a hypothesis that both the primary and the existing metastasis can seed new mets, and treatment of the primary and the met will prevent the seeding and further progression of the disease. So a number of dilemmas arise to the practicing radiation oncology and oncologists, which we'll try to resolve today. And I'll broadly divide this into two categories, either in newly diagnosed metastatic patients or in recurrent or what we call oligo-recurrent, that is after their initial treatment, that kind of metastasis. So in newly diagnosed, let us try to answer if radiotherapy to the prostate helps. What is a good dose and technique if you do consider radiotherapy to the prostate? And in case of oligometastasis, should we only treat the prostate or we should include the metastasis also? And in patients who've had their primary treated and they have recurred somewhere in an oligo fashion, does radiotherapy to the mets help? And if they do recur in the pelvis, which we often see in practice, what should be the volume of treatment? So these are some of the questions we'll try to answer. So let us start off with a typical PSMA PET scan of a newly diagnosed oligometastatic patient. This gentleman had a T3B node negative, M1B to the bone. There were two mets. I have only shown one. One was the L3 spinous process and ischial tuberosity. Patient was asymptomatic and, as I said, started on ADT and abiraterone. The question arises, what do we do to the prostate? And that has been answered by in the most recent NCCN guidelines, that EBRT to the primary tumor for low volume M1, I already told you what low volume is, should be considered. There is level 1 evidence for that. The EAU also says offer ADT with prostate radiotherapy to patients who present with M1 and low volume disease as per charted criteria. So I have already told you that there is strong evidence to do that. And that evidence is based on results from two large randomized trials. One is the Stampede and one is the HORAD. And I'll show you a little bit about that, what these trials show. The Stampede trial is a multi-arm, multi-phase, multi-stage trial in which this arm H showed was in that arm H, which is relevant to us now. 2,000 patients with metastatic prostate cancer were randomized to receive either the standard of care, which is ADT. Some of them also received docetaxel or addition of RT. And after a median follow-up of 37 months, there was no difference in overall survival, but a large, reasonably good difference in failure-free survival by adding radiotherapy. But most interestingly, when it was divided, and this was a planned analysis, by high or low metastatic burden, in patients who had high metastatic burden that I showed you, 4 or more, or visceral, or one outside, including one outside the axial skeleton, there was no difference. On the right, you can see the panel B. But in low metastatic burden, there was an overall survival difference when you add local radiotherapy to the prostate. So that has what has led to this coming in the guideline. The question is, now who benefits? Who benefits? So one is the low metastatic burden, but which type of patients benefit? So this is a very recent analysis of the same Stampede data. They divided the type of mets into only non-regional lymph nodes, 3 or fewer, 4 or more, or visceral. And it was clearly seen that patients who had less than or equal to 3, or who had non-regional lymph node mets like para-aortic or common iliacs low, they are the ones who had an overall survival advantage by adding radiotherapy. So in your practice, if they have this 1 or 2 or up to 3 mets or only lymph nodes, then it is would be standard to treat the prostate. There was another trial called HORAD, much smaller trial, which did not show an overall survival difference in the entire cohort. But when they looked at patients who had less than 5 bone metastasis, prostate radiotherapy had a large overall survival difference in the for the hazard ratio. Now, once you're planning to treat, what is a good dose and technique? These people use 70 grain 35 fractions in HORAD using 3D CRT or IMRT, and Stampede use 2 fractionations, either a weekly 36 in 6 or 55 in 20. Now, this is not very high dose as compared to the standard prostate radiotherapy that we do. So it is important to understand, people have said that if you had given a higher dose than this 74, 78 gray that we do nowadays with IMRT, the outcomes could have been even better. Remember that only prostate was treated, none of the pelvic nodes or mets were treated. Now, does dose matter? This very interesting paper a few years back, uh, they looked at 6,000 men who had metastatic prostate cancer from the THEAR database. They picked out about 500 people who had received prostate RT, and they compared with people who had got prostatectomy and ADT alone, etc., and divided the radiotherapy patients into two different doses, less than 65 gray, more than 65 gray. And you can see here, if you receive less than 65 gray, it is as good as not giving any radiotherapy. This dark line is ADT alone, dotted line is less than 65 gray. So if you have to give a radiation dose, it's got to be at least more than 65 gray, if not higher. So that is one conclusion from this. Second is, what technique should you use? And another very interesting study, population-based study, 4,000 patients, they picked out people who had some form of local treatment. Some had prostatectomy, some had conformal radiotherapy, some had IMRT, and most had no local treatment, as was the standard at that time. And you can see again a big difference between 3D CRT, which is the brown line here. I hope you can see my cursor, and the green line on top, which is as good as ablating the prostate with prostatectomy. So, and this probably is a reflection of the higher dose that I showed you. So essentially, you have to give a higher dose and use an appropriate technique to give that higher dose. Moving on to the next scenario, again, a newly diagnosed metastatic prostate cancer, T3B N1M1B, and this patient had a rib lesion, as you can see here. And this could be on a bone scan. There's no problem. You don't have a PSMA for that. The question is, should we treat only the primary, or is there any benefit on treating the node of that metastasis also? Now we have all sorts of equipment. We can treat this rib lesion easily to a high dose. So the question is, does it help? And remember, the Stampede and other trials did not treat the mets. There's very little data on this. Many people do treat that, but very little published. This is from the MSKCC, a small number of patients. They treated the prostate and the metastasis along with ADT and systemic therapy. What they showed was high survival probability overall, and almost 50% of the patients are able to actually stop their ADT and still remain controlled. So that, and another arm of Stampede called arm M is testing this hypothesis, but that gives credence to the fact that if you treat the prostate and the metastasis, very little remains to be seeded. So this could in fact even be curative, but the data is not very great in this regard. To summarize this issue, low metastatic burden state is when we have with or without regional lymph nodes. As the definition, it's important to know what it is. Patients who receive prostate-directed radiotherapy, they benefit. That is the standard of care for non-regional lymph nodes or 3 or fewer mets. RT should be given to the prostate only. There is possibly a case of giving to the mets also, and the dose should be at least 64 to 66 gray or higher, and preferably using IMRT. Let's move to the other scenario. This is a scenario of isolated nodal recurrence. So a patient who's had previous prostate radiotherapy in 2012, after a DFI of 8 years, there's a biochemical failure. And when a PET scan is done, there's an inguinal node. Now the radiation oncologist will think, what should I treat now? Should I only treat the node? Should I treat the bed, entire, that's one side, both the sides? So this has been answered very nicely by this recent article. They actually looked exactly at this. People who have a single lymph node metastasis or less than 5 within the pelvis, they compared whether you should treat only the node or the pelvis and the node. And they found that if there's only a single node, then it's better for elective nodal RT than the node alone. If there are multiple nodes, then it probably doesn't matter. So again, an indication that if there's one node, go ahead and treat the whole pelvis, provided you do it safely. Finally, another scenario that we commonly see, this is oligo recurrence. So patient has been treated with high-risk prostate cancer, radiotherapy received, ADT received. After 2 years, there's chest pain. Patient comes back with biochemical failure. You can see a PET scan shows nothing but a rib lesion on the 6th rib, high SUV, and we treated this patient with SBRT to that rib. The question is, why did we do that? What is the rationale of doing it, and does it help? So one of the ideas is, when such a thing happens, the standard is to start on systemic therapy. You start ADT, you give chemotherapy, you give abiraterone, this, that, and the other. That has toxicity. Can that be avoided? And that has been shown by this trial called STOMP. It's a smallish trial. This was recently presented at ASCO also. Such patients were randomized to doing nothing, no ADT also, or giving metastatic directed therapy, either surgery or SBRT, mainly SBRT. And you could see almost 40% of the patients, 34% of the patients at 5 years were free of ADT. They did not even need ADT. So that is not a very hard endpoint, but still useful. Another trial, very similar, patients who had few metastases were either observed or received SBRT, and you can see improved progression-free survival. So there seems to be a benefit in treating those oligomets. So in a case of nodal recurrence, it is better, if that is the dilemma, if previously it's not been treated, the pelvis, the whole pelvis should be treated. Don't go after that single node. And in patients who have recurrent, oligorecurrent metastasis-directed therapy can improve ADT-free survival and PFS. I'm going to stop there. That is about my time. Thank you so much. I'll be happy to take any questions.
Okay, any questions from any of the participants?
Hello, sir. This is Dr. Ashish from Sikkim, sir.
Hi, Ashish.
Hello, sir. So I just wanted to ask, sir, you said that for the oligometastatic side, you are giving SBRT, sir. So usually when it's painful, we just give palliative RT, sir, 8-way single fraction or thing. So will that also help, or is it only with the SBRT, sir?
So, Ashish, no?
Yes, sir.
Ashish, it really depends on what you're trying to do here and what the case is. If it is a patient who has had previous local treatment and now a single or 2 mets come in the rib, your question is whether to give 8-gray single or a higher dose, correct?
Yes, sir. So, I mean, what I mean to say is, are the results same? I mean, have they come?
No, it won't be the same.
Like,
it won't be the 8-gray single fraction you're giving for the pain.
Yes,
Here
sir.
you're trying to ablate the cancer by giving a reasonably high dose of 30-35 gray in 5 or 6 fractions. So it's ablative treatment, and the local control is in the tune of 95% with that dose. And of course, that will take care of the pain as well.
Yeah, it being this oligometastasis or low volume metastasis, actually, they are trying to give a curative sort of this thing, dose, for longer this thing, disease-free survival and all that.
Yes.
It's not totally palliative in this setting.
Yes. Thank you.
Any other clarification? In that case, I would like to conclude. Thank you, Dr. Vedamurthy, for your very lucid presentation. It was so clear, it must be clear to all. So it has been, yes,
I hope so.
a very good update.
I hope so.
Yeah, thank you so much.
Thank you, sir. How are you doing?
It's okay, fine. Please come down to Imphal once.
Well, I'm waiting. Things are getting worse here.
Yeah, we'll invite you some appropriate
Thank you,
time.
sir.
Okay, thank you.
See you, Kali. Bye.
Then we'll go to the next paper. Next paper will be on beyond hormone therapy in prostate cancer, defining the strategies. And this shall be presented by Dr. P.S. Roy, medical oncologist from BBCI Guwahati. Dr. Roy, please.
Thank you, sir. Thank you, Khaled. My screen is visible to all of you.
Yeah, it's visible.
Okay, thank you. And I hope I am audible also.
Yes, it's audible.
Okay, very good afternoon, all of you who are connected over online. Good evening, Singh sir, and good evening, Khalid, and all my dear friends. So I have been asked to talk on beyond hormonal therapy in prostate cancer, defining the strategies. As you all know that prostate cancer is a hormone dependent cancer, that is androgen dependent cancer. So what should I talk beyond hormone therapy will be focused on today's discussion. So for that purpose, I will omit that localized disease part and the locally advanced disease part. I should stick to the metastatic disease part. And as you all know that metastatic disease, prostatic metastatic cancer again can be divided into two heterogeneous groups. These are castrate sensitive group and there are castrate resistant group. And as I have already said that hormonal therapy plays a major role in the treatment, and androgen deprivation therapy usually becomes the first line therapy for almost all the patients with prostatic cancer. Unfortunately, majority of the patients, they do fail once on or sometime during the androgen deprivation therapy. And then the patients become disease state is referred as castration resistant prostate cancer, that is short CRPC. So today's discussion is focused basically on CRPC. If you would like to see the progression of the disease, biologically, they do start from clinically localized disease, but down the line, they become rising PSI with the, still they retain the hormone sensitivity. Gradually, they lost the hormonal sensitivity and ultimately they become metastatic disease before the patient succumbs to his disease after a prolonged suffering. So for those who wants to see the stage-based overview of the therapeutic strategy, I am not going in detail about all those things. I will only focus in the below two line, that is castration-resistant group in the first line and the second line. So we have few molecules like abiraterone, docetaxel, enzalutamide, immunotherapy, cabazitaxel, and radium-223, which should take up one by one in my subsequent slides. So for my simplicity, all the treatment for the prostate cancer can be divided into, as you all know, that hormonal versus non-hormonal. Non-hormonal approach, apart from surgery and radiotherapy, these are systemic chemotherapy and immunotherapy. So way back in 1941, we have two seminal papers which showed that the effect of castration and effect of injection of estrogen, which reduced serum acid phosphatase level, and subsequently they have effect on reduction in the metastatic prostate cancer mass. So since the publication of those seminal papers, since last 80 years, still the standard of care in case of metastatic hormone sensitive prostate cancer is androgen deprivation therapy. However, beyond conventional hormonal therapy, during the last 30 to 40 years, we have seen the development of too many molecules addressing towards the prostate cancer, starting from mitoxantrone, estamastine, docetaxel, sipuleucel, abiraterone. Then nowadays, the era of immunotherapy and some other targeted therapy like MET inhibitors. To add on in the last in the list is a Prostavac, which is the vector-based immunotherapy. So amongst those all drugs, the drug which are associated with the survival benefit based on different phase 3 clinical trials, I have listed all those drugs in the left side. You can see these are sipuleucel T, docetaxel, cabazitaxel, and radium. I have highlighted those in red color just because we are concerned about all those four drugs in related to CRPC. All four drugs are associated with overall survival benefit, in addition to abiraterone and enzalutamide. So this is the cartoon. I am not going in detail of the cartoon. Only thing I need to highlight is that for your information, the drugs like abiraterone, enzalutamide, apalutamide, then your docetaxel, cabazitaxel, they all works inside the prostatic cancer cell. Whereas radium, they do work or they are concentrated in the bone directly. Whereas immunotherapy like your ICI, then your CPLUCL-T, they work in the tumor milieu outside the prostatic cancer cell. So what all these agents approve, where do we stand in terms of overall survival of the metastatic cancer is concerned? So we have not less than 20 or 40 molecules. Despite of that, what you are actually standing today as far as overall survival is concerned. So in present era, in metastatic prostate cancer is concerned, the median overall survival stands around 42 months, which is not more than 3.5 years. Whereas failure-free survival is median failure-free survival is around only 11 months. So meaning is that whatever you drug use, whatever the best drug you use, you cannot achieve a disease-free survival beyond 1 year with a single modality of treatment. That is the agony of this disease. So while driving the biology of the castration-resistant prostate cancer, there are few driver mutations are there seen both in primary tumor as well as in metastatic disease, like androgen receptors, PTEN loss, PI3K inhibitors. Out of this, not all are targeted as of today. Few are undergoing different phases of clinical trial. So as I have said, the CRPC patient is a heterogeneous group of disease. Two patients are there, two group of patients are there. First group is that these are known as M0 disease. That is, they are having only biochemical failure, characterized by only PSA raise. On the other hand, they are frank M1 disease, that is extensive high volume symptomatic metastatic disease, either with visceral mets only or without bone metastasis. So coming to the non-metastatic group, that is M0 disease, the treatment of the M0 disease basically depends upon the prostate-specific antigen doubling time, that is known as PSA doubling time. So we need to see whether the patients are associated with faster PSA doubling time or longer PSA doubling time. For the cutoff for the purpose of treatment, 10 months PSA doubling time is considered as shorter PSA doubling time. It's less than 10 months. The patient should be tried with some drugs like androgen stimulation and the drugs that are interfering with the androgen stimulation for prostate cancer. In this group, we have 3 approved drugs like enzalutamide, apalutamide, and darolutamide, and at least 3 randomized clinical trials has proved that these are the drugs which are associated with progression of the survival and interfere with the drug. In addition to these 3 agents, cytotoxic chemotherapy like taxanes, either docetaxel or cabazitaxel, are also can be used in this group of patients. But the use of cytotoxic chemotherapy is generally reserved for those patients who are symptomatically progressing disease, and in those group of patients where this less toxic hormonal therapy is not approved. Coming to the second group, there is for those men in M0 CRPC having longer PSA doubling time, the optimal approach is not clear. However, observation or continuation of the same hormonal therapy can be appropriate options. Choice of this initial therapy for CRPC basically depends upon the prior systemic therapy, whatever you have used in the prior time, then site and extent of the disease involvement, the presence of the and absence of the symptoms, disease burden, presence or absence of the comorbidities, PSA doubling time, especially in M0 disease, as I have already highlighted, in addition to the cost, availability, and most important, not to forget about the patient's preference. So this is the initial approach. I know this is a very cumbersome slide. Don't go into details. I'll make you simplify. So you need to see few things before planning treatment for metastatic, both castration-resistant and non-metastatic castration-resistant patient. So you need to see whether the patient having disease metastasis or not, and then you will see whether the patient has received for androgen deprivation therapy with or without androgen in the past. And then you need to see whether the patient have got DNA mismatch repair or not. And then you need to take the history of prior docetaxel and see whether the patient is symptomatic or not. And then patient's performance status and minimal comorbidity. After this, once you have all those things, you need to decide now what will be the line of therapy. As far as the metastatic CRPC is concerned, based on different phase 3 data, agents which showed improvement in overall survival, we have altogether 3 broad approaches. The 3 broad approaches are, number 1 is interference with the androgen stimulation of prostate cancer growth, characterized by enzalutamide, apalutamide, and darolutamide. In the second group, I have inhibition of androgen biosynthesis. For example, abiraterone. In the last group, it is chemotherapy using taxane, either docetaxel or cabazitaxel. In addition to this drug, which are associated with improvement in OS, we have immunotherapy, we have bone-targeted radiopharmaceuticals, we have PARP inhibitors. I shall discuss one by one in my subsequent slides. So this is the schema of the agents which are available to us today. And I have already shared this slide. On the right panel, you can see the drug, all the drugs are associated with median overall survival. In addition, docetaxel and cabazitaxel also is associated with PSA response to therapy, unlike sickle-cell T and radium. The one most important thing before going for further therapy is that germline genetic testing. It has been seen that 5 to 12% of the men with advanced prostate cancer, they do carry some deleterious germline or somatic mutations in homologous repair gene, also known as DNA MMR gene. This presence of germline or somatic mutations in HRR or DNA MMR gene, they actually affect the further treatment decision. And hence, NCCN, both NCCN and AUA, that is American Urological Association, has recommended that for all patients with metastatic disease, genetic counseling and germline testing or next generation sequencing or assay of circulating free DNA should be done based on these genes like MLH1, MSH2, MSH6, TMS2, BRCA1, BRCA2, ATM, and etc. Based on the availability of the germline testing, whether these mutations are present or not, you will divide further treatment into two modalities. First, we will discuss men without any germline or somatic mutation in this DNA mismatch repair genes. So in this category, we have chemotherapy, we have immunotherapy. Chemotherapy first, as you know that prior to development of the taxane, cytotoxic chemotherapy were considered to be very ineffective. Whereas taxanes are the only cytotoxic chemotherapy agent that have significantly prolonged overall survival. They have PSA, they have showed PSA response and also objective tumor regression. The vast majority of the benefit from chemotherapy is seen in those group of the patients who had rapidly progressing symptoms. So in case of chemotherapy naive patients, so we have two molecules, that is docetaxel and cabazitaxel. Docetaxel is always preferred over cabazitaxel as initial chemotherapy regimen, whereas cabazitaxel is preferred over docetaxel in select group of patients where the patient is elderly, patient is frail, with relative poor performance status, and patient is considered to have a high risk of neutropenia based on result which showed that cabazitaxel is as equivalent to your docetaxel, but toxicity wise is less. So it has been seen that in tumor tissue model of prostate cancer, both in primary tissue model and metastatic tissue model, both in CSPC and CRPC, it has been seen that there are two clones of cells are there. One is androgen receptor dependent clone, other is androgen receptor independent clone. Based on this result of this hypothesis, probably all the trials in CSPC, they have addressed combination of both ADT in addition to docetaxel to address both the clones. So although beyond my discussions topic today, so I will just show you this slide. In metastatic CSPC, various trials has documented that a combination of docetaxel in addition to ADT, when compared to ADT alone, has shown improvement in overall survival. Especially these are the two trials, Charter trial and Stampede trial. And the meta-analysis of overall survival, that is top cap meta-analysis, also confirmed that addition of docetaxel added to androgen deprivation therapy is associated with improvement in overall survival. Probably majority of you have come across in some time about this trial, that is TAX 327 trial. This is a landmark trial on metastatic castrate-resistant prostate cancer. It has 3 arms. The first arm is conventional docetaxel at 75 milligram per meter square at 3-weekly interval. They have compared the other 2 arms with weekly docetaxel versus metoxantrone pro. This trial has shown that 3-weekly docetaxel is comparatively better in terms of overall survival, better in terms of serum PSA level reduction, better in terms of response to pain and quality of life in compared to metoxantrone. And actually, this TAX 327 trial has established the dose of is actually the docetaxel to be used as 3-weekly interval since last 2004. In the same year, in 2004, one more trial based on docetaxel plus extramastin combined in comparison to metoxantrone has been published by SWOG group that has also established the overall survival benefit of docetaxel. However, other alternative docetaxel schedules like weekly regimen, combination of docetaxel with other agents like bevacizumab, then capecitabine, epirubicin, vinorelbine, they are failed in different trials. So, docetaxel 75 milligram per meter square used 3 weekly remains the standard of care as of today. Now, what is the space for cabazitaxel? Docetaxel is generally preferred over cabazitaxel as the initial chemotherapy regimen for chemotherapy naive patients. I have already discussed this part. However, cabazitaxel at the dose of 20 milligram per meter square may be preferred in a select group of patients. I have already discussed this part. Based on the ability to prolong overall survival when in case of docetaxel resistant patient, cabazitaxel is nowadays also has been tried as first line therapy. I'm coming to this part also. So first I will discuss role of cabazitaxel as second line after failure of the docetaxel. And this has been established by the phase 3 TROPIC trial published in 2010. Cabazitaxel plus prednisolone showed anti-tumor activity in terms of overall survival benefit. In case of metastatic CRPC patients, those patients who has progressed post docetaxel. So cabazitaxel has been established as second line therapy based on this TROPIC trial. Now coming to the Fistula trial, this is another phase 2, phase 3 trial. Here the cabazitaxel is directly compared with the docetaxel as first line therapy, but in CRPC, metastatic CRPC patients. This trial again has three arms. So cabazitaxel 20 and cabazitaxel 25, these two arms have been compared, and it has been seen that now the single arm is superior to one another. Having been said that, Fistula is the first trial in which two active life prolonging metastatic CRPC therapies, namely docetaxel and cabazitaxel, has been compared, and there is no difference in overall survival. That does mean that when you are using either cabazitaxel or docetaxel as first line, there is no difference in the efficacy. The only difference is in the safety. The safety profile of cabazitaxel is preferably better in comparison to docetaxel as far as neutropenia, neuropathy, and edema is concerned. So if you are concerned about those toxicities, you can avoid docetaxel. You can directly go for the cabazitaxel as first line based on this phase 3 trial. Coming to another setting, that is a CARD trial. It has actually established the role of cabazitaxel in third line when the patient has already CRPC and patient has already used docetaxel. So you can use cabazitaxel in third line also. And in this trial, cabazitaxel has proved to be superior in comparison to our abiraterone or enzalutamide in terms of overall survival is concerned. So cabazitaxel actually proved in all the three settings, first line, second line, and third line, metastatic CRPC. We should not forget the old friend, our old friend, this metoxantrone. Although the approval of the metoxantrone was not based on improvement in the overall survival, it was based only on symptom palliation, that is pain. But still nowadays, even though we are failed on metastatic, we are failed on docetaxel, cabazitaxel, metoxantrone is recalled sometimes because of the failure. So this is the setting, men who have prior docetaxel. Nowadays, we are facing this problem more and more. The reason behind is that increasingly men with high volume CSPC, that is castration sensitive disease, are being offered combination of both docetaxel and androgen deprivation therapy based on the results of Chartered and Stampede trial. So we are getting more and more number of patients who are actually failed on docetaxel. So for this group of patients, what are the options available? The first option is the first and preferred option is the cabazitaxel based on the phase 3 TROPIC trial, as I have already showed you. And then the second option is the docetaxel rechallenge. This is for docetaxel rechallenge, there is no cutoff time for the simplicity. The people has fixed it at 3 months. If the docetaxel free interval is more than 3 months, you can pretty go for docetaxel rechallenge in absence of cabazitaxel, which happens to be a preferred option. The other option remains metoxantrone, and lastly, androgen signaling targeted agent in absence of all those agents are still an option. Sorry. Now coming to the other option, other scenario where you have failed on both docetaxel and cabazitaxel. Now actually in this scenario, there is no established rule that any chemotherapy can actually improve your survival. It has not been proved in any trial. So people has tried to manipulate with the platinum-based regimen, and most of the regimen in this scenario, they used to use a combination of either one carboplatin, cisplatin, oxaliplatin, or in combination with the capecitabine plus paclitaxel, but in absence of any phase 2, phase 3 data. So coming to the second scenario, in presence of HRR repair gene aberration. So as I have said that these are the genes BRCA1, BRCA2, JAK2, PALQ, ATM, FANCA. In presence of those diseases, there are two groups of drugs are there. One is the PARP inhibitor, that is poly-ADP ribose polymerase inhibitor, and second group is platinum-containing chemotherapy. And among all the genes, abnormal genes, it has been seen that BRCA2 mutation is the group of the patients who benefit the most from the PARP inhibitor. And it has also been seen that platinum-based chemotherapy, all carboplatin, cisplatin, and oxaliplatin shows are reasonably activity in this group of the patients with HRR alterations. Two PARP inhibitors, that is olaparib and rucaparib, they are approved as of today for use in this setting. Olaparib can be used in any group of the patients having any abnormalities in the gene, whereas approval of the rucaparib is limited to those group of the patients who have only either BRCA1 or BRCA2 mutations. Approval of olaparib is based on this phase 3 profound trial, which is a phase 3 trial. And approval of rucaparib is based on, again, this trial, which is approved in May 2020 only, based on the objective response rate of 44% in comparison to placebo. Coming to the role of immunotherapy, the options of immunotherapy, as I already highlighted, these are autologous dendritic cell vaccine, that is CPL, which is already proven. Second is the immune checkpoint inhibitors in the form of pembrolizumab. Third is Prostavac. That is Prostavac is the viral vector-based immunotherapy. All three have showed overall survival benefit in phase 3 trial. Apart from this, we have CAR T-cell, we have Listeria monocytogenes vaccine therapy. Few line about the CPL. CPL is known as the autologous dendritic cell therapeutic vaccine. It has established its role from phase 3 impact trial, especially in group of the patients who had minimally symptomatic metastatic CRPC. In that group of patients, patient prolongs overall survival. Therapeutic vaccine is appropriate only in those group of patients who are asymptomatic and minimally symptomatic. I won't go in detail about the trials. A systematic review and meta-analysis of the CPL has confirmed that it is associated with overall survival, but it is not associated with any disease-related progression. So PSA benefit and radiological PFS benefit is not there. PFS benefit is also not there. Only overall survival. Coming to the immune checkpoint inhibitors, it has been seen that in the patients with deficient MMR and MSI high group of patients, and also group of patients who are associated with high tumor mutational burden, these are the group of the patients. They are susceptible to anti-PD-L1 or anti-PD-1 therapy in the form of either pembrolizumab or nivolumab. So coming to this Keynote 119 study, which has shown that pembrolizumab monotherapy is a feasible option in this group of patients. Probably you have came across this trial. It was published in 2019 only. Phase 2 Keynote 158 study had shown that benefit of pembrolizumab monotherapy in varieties of malignancies. These are all non-colorectal malignancies which is associated with high MSI high or deficient MMR. And this, based on this trial, pembrolizumab is now approved for across the malignancies, including prostate cancer, which are associated with high TMB mutation more than 10. So coming to the radium, which is alpha particle emitting bone seeking radiopharmaceuticals. Again, the use of radium-223, although it is associated with the overall survival benefit, it is limited to those group of the patients who had only symptomatic bone metastasis without any visceral metastasis. So this is the limitation of use of radium. I can skip this trial. This is a LSIMCA trial based on this, which had approval for radium. So coming from highlights of the ASCO GU 2020 on prostate cancer, I would just like to highlight you two major trials, Keynote 365 and Checkmate 9KD, which showed that first trial, Keynote 365, showed that combination of pembrolizumab with docetaxel plus prednisolone in previously highly pretreated patients with very significant result. Probably you have to see their final result to mature. The second trial, Checkmate 9KD, they have gone further ahead. They are using nivolumab with docetaxel and prednisolone in the chemotherapy naive patient. It is in the first line setting only. So again, excellent result. We need to wait further till their further result. I can skip this slide. New potential therapy targets are there.
Can you fasten a bit, Dr. Parth, please?
Yeah, almost finished. Can I have 1 or 2 minutes? Almost finished.
Okay. Please finish in 1 minute.
So this is only a special category of patients like pure small cell cancer and neuroendocrine carcinoma of the prostate. Unlike your adenocarcinoma, this needs to be treated in the differently. Majority of the patients are treated in the line of small cell carcinoma of the lung or with platinum taxane combination. So this is latest NCCN guidelines showing that prior novel hormone therapy group preferred regimens are docetaxel, which is category 1 classic recommendation, and sipuleucel T1 is there. In addition, we have cabazitaxel, olaparib, pembrolizumab, radium, rucaparib, etc. I have already discussed those things. So coming to my last slide, to summarize on, therapeutic landscape of advanced CRPC is continuously changing because of the new therapeutic options and improvement in understanding of these molecular characteristics. Rapid evolution of the treatment and lack of high quality RCTs, particularly in this group of the patient. For man with metastatic CRPC and metastatic CSPC, both multiple active agents are there. I have already showed those in my previous slides. The drugs like docetaxel, cabazitaxel, abiraterone, enzalutamide, sipuleucel T, and bone-specific radionuclide targets, all are there. All shows overall survival, but they are not curative. So taxanes are the only cytotoxic agent which prolongs overall survival in clinical trials. Either docetaxel and cabazitaxel are an appropriate choice for chemotherapy naive patients. Cabazitaxel is preferred over the docetaxel in case of rechallenge. With this much, I would like to conclude here. Thank you for your patience hearing.
Okay, thank you, Dr. P.S. Roy. From the participants, any clarification? My co-chair persons are there.
I think we are running behind schedule. The next speaker is already
okay.
Ready.
Then we'll take up the last. Okay, then we'll take up the last paper, which will be on surgical management of locally advanced prostate cancer. This shall be presented by Dr. Zubaraja. He is a head robotic surgery consultant urologist. He is from the St. KDA Hospital, Mumbai. Dr. Zubaraja, please.
Thank you. Good evening to all of you. Can you hear Dr. Harris?
Yes, sir. Very much, sir. Yes, sir. We can hear you, sir.
You can see the screen also, right?
Dr. Path, I think you should close your screen sharing.
Yeah. Can you see my sharing?
No, sir. We are still waiting, sir. Yeah. Now we have seen your screen, sir. Thank you.
Fine. Thank you so much. Good evening to all of you. In the beginning, I would like to thank Dr. Vikas and the association to give this opportunity. So my job is to give you an overall view how surgical management of locally advanced prostate cancer has evolved over last decade, and now we're in a different era where we understand and treat it in a different way. So in this regard, I will start my presentation. So to define what exactly locally advanced prostate cancer. So there will be a lot of overlap here because some associations also include high risk localized into advanced cancers. So actually pure definition is any PSA, any score, whether it is 7, 8, 9, 10, and T3, T4, important. T3, T4 or CN plus N1. Actually, it is N1. It's called as locally advanced prostate cancer. So more or less, this group of disease was considered as advanced, and then we never used to do localized therapies, but nowadays the advances have taken place where we are trying to cure these patients, which we never used to think about curing this group of patients. You can see these are the group of patients in that picture. So now, what is the current scenario? So now, almost 25% of the men with newly diagnosed prostate cancer have locally advanced disease. So in India, so might be around say 35% of our cases are locally advanced when compared to Western population is around say 10% or 10 to 20%. So we know that there are heterogeneous tumors not have uniform prognosis, and generally they become metastatic at 5 years, around say 50% of them. So however, we are lacking randomized trials to compare whether what type of treatment test is advised in this group of patients. However, so there is no consensus as such. So as of now, still I can't say that surgery will be the standard of care, but however, radiation is now presently the standard of care. So as a surgical technique, now we are slowly creeping into this area for the management. However, recently the terminologies or the method we are using is multimodal therapy, and there are investigations are going on in the entire world. So regarding the use of molecular markers to identify this group of patients which where the surgery will be used, or trying new molecules in a new adjuvant setting to make new adjuvant, new targeted therapy followed by surgery. So now, when you come to the local advanced prostate cancers, the question we always ask in our mind: do they need to be cured, and can we cure? Because, however, earlier we always used to think the local advanced, we cannot cure it, we can just control it. But I think now with the treatment options like radical prostatectomy, radical radiotherapy, so mainly they were there earlier, but the advances which have been taken in these two fields is huge. And always the hormonal therapy and systemic therapy add into the armamentarium of this management. So now the treatment modalities, if you just see a skeleton of the treatment, so monotherapy, either surgery, radiation, or hormonal treatment alone. However, we are going away from this monotherapy. We cannot boast ourselves saying that surgery will cure these patients or radiation will cure these patients. So the now terminology is multimodality treatment, whether you do with radical prostatectomy followed by adjuvant therapy or a new adjuvant therapy, or radiation therapy with the adjuvant and new adjuvant therapy. So now the question is that whether should we target these tumors either with a prostatectomy or radiation therapy? That was the question. So now we try to answer this one. So now currently published status, if you see that there are majority of them are all radiation plus ADT. You can see that I think it is now we are a majority of these locally advanced cancers are treated by radiation therapy along with the ADT in a new adjuvant as well as in adjuvant setting. However, it has got some issues. So you can all of you know all these side effects. So mainly it is a cardiovascular side effect, ADT, because we always add ADT. ADT has got its own complications. GU and GU's toxicity, although it is less, however, it is seen in quite significant number of patients. Recurrence, the most important. Once the recurrence, we know that 50% of them, at least, 30 to 50% of them recur, and salvage surgery is disastrous. So, although there are a few papers in a very high volume centers, it's not a surgery to be done. So that means we are going to be devoid of one good surgical treatment or a local treatment for these patients. However, so the survival is persistent local disease, occult metastasis, so inadequate treatment of lymph nodes, and most important, the local symptoms what these patients develop. So that is one of the problem what we always have. Why not surgery? So was discouraged mainly because increased risk of positive surgical margin. That means, so earlier positive surgical margin means is a bad surgery or a bad surgeon. So nowadays it doesn't hold good any diseases with locally advanced cancers in any organ. So incontinence was high. So now you cannot say that now because incontinence is very well improved with the robotic technique. Impotence, of course, now we can't because now we are going to do a wide excision. So impotence is one of the part and parcel of this treatment. Complications, no way different from treating surgical method in a localized disease. Lymph node metastasis. So of course we can see the lymph node metastasis, but we are going to clear the lymph nodes. Robotic surgery is difficult in locally advanced cancer. Definitely no. That means we have progressed a lot when come to robotic surgery. So now it's a very quite comfortable surgery when compared to open surgery in locally advanced cancer. So RT was toxic after RP. So that is also not true. That means the radiation dose after surgery is quite less. So now we don't see any significant side effects when compared to our radiation given per se in the primary setting. So now advantages of surgery, we know that improves technique, less complications, and better radiation or hormonal treatment can be included in after surgery. Accurate staging is possible. That means we remove everything and we know the lesions post stage, lymph node metastasis, everything, so that we can plan our treatment and prognosticate these patients. So no, there is no local issues like hematuria, obstruction, so that we significant number of patients undergoing radiation or hormonal treatment will happen. So now, if you see the literature, there is a lot of literature which is there, but however, all these are all large case series, meta-analysis, systematic review. However, there is no randomized trial which we can see that. And if you see, this is one of the paper, which is an earlier paper. If you see that 60% cancer-specific death when compared to radiation, which is quite high. So this is how this just I'm going to give you overall view. Is not going to detail of any study for that matter. So there is one more meta-analysis in 2017. If you see that RP versus RT in 10-year overall survival rate is 70 versus 65, it was statistically significant. Again, it is just a systematic review, and it includes all comers So there is no selection of patients here. So even in spite of that, the significant improvement when you treat this patient group of patient with radiation therapy. Then the question came, can we improve our oncological outcomes by adding something? So now, earlier they said that, we used to do only radical prostatectomy sufficient. So definitely we know that. So that is not sufficient. So the next question is that, can we add neoadjuvant hormonal therapy? So I think I have a slide, but even otherwise I'll mention here only. Neoadjuvant hormonal therapy has been explored widely. There are 4 trials on, and as of now, the neoadjuvant, the role of neoadjuvant hormonal therapy is questionable. And I think in next couple of years we are going to get the results. However, we use neoadjuvant hormonal therapy if the patient is waiting for a longer period of before surgery. Adjuvant RT, quite easy, as I told you. Early or late salvage radiation therapy, whether you give early or late, we know that nowadays we are going into the tune of early salvage therapy. Adjuvant hormonal therapy is quite useful, and improving surgical techniques, robotic surgery, we know that, and increased overall surgical expertise that mainly depends on case load. So we have to have expertise to do this type of cases. So with these things, we can improve the oncological outcomes. So at this slide, I have the neoadjuvant therapy. So recent meta-analysis says that there is a reduction in positive surgical margin after the neoadjuvant hormonal therapy to the tune of 2 to 6 months. And we can say that it is going to be useful, although it doesn't translate into overall survival. So however, there are studies which are going to tell us in future. So multimodality treatment, as the first, it becomes logical to do surgery, as surgery after radiation therapy is difficult. Radical prostatectomy with extended pelvic lymph node dissection is the standard one, and it integrates the approach combining local and systemic therapy. That's what we do in a multimodal approach. So there are few studies which adjuvant and salvage therapy, when to give a radiation after doing a locally advanced prostate cancer. Majority of in clinical practice, we give adjuvant radiation therapy if there are very high risk features where it's an extensive margin positivity or a lymph node positivity. Otherwise, we wait and do early salvage therapy. That is as soon as the PSA started rising up, before any radiological imaging shows metastasis, we start adjuvant therapy. So this is one of the paper by Abdullah. So it's a strongest data emerged from the Swedish also. It clearly shows there is an advantage of primary treatment with surgery rather than radiotherapy. They have assessed almost 34,000 men, especially in Sweden, for a 15-year period, comparing surgery and radiotherapy outcomes. So this is 2014 paper retrospective series. You can say that cancer-specific survival at 15 years, 5, 10, 15 years, almost 90-95% at 5 years. That is a very good report when for surgery. So if you see, there are other cohort studies which say that the 5-year survival, cancer-specific survival, and overall survival is around to the tune of say 90% versus 70%. So multimodal approaches should be discussed with the patient coming to you with locally advanced prostate cancer, and the timing whether to give a radiation first and all those things. It depends on how we explain to the patients. So again, so there is a CR database of larger database in US. If you see that RP with adjuvant radiation therapy versus radiation plus ADT, a huge difference in survival. You can see that. So this is again a 10-year cancer-specific survival, a large studies. You can see that whether it is a 3A disease, 3B disease, either whether it's a cancer-specific survival or a overall survival, there is a difference in survival. So similarly, so in there is 2020, there is another systematic review and meta-analysis published in World Journal of Surgical Oncology. It says that the meta-analysis always favors if we take any criteria, cancer-specific survival, overall survival, that favors a radical prostatectomy. Again, there is a systematic review and meta-analysis 2014. Again, it favors radical prostatectomy. So that means in over last 10 years. So I think if I remember 10 years, before 10 years, last 10 years, if you say that surgery for locally advanced, I think we will get 5. Even in the exams now, I think this is one of the part of the treatment. However, when I say this, so out of 100 patients, only say 30-40 patients will be suitable for this. Majority still patients still will be not valid for this type of treatment, and we go and do radiation therapy. Lymph node positive disease, don't scare. So if it is N1 disease, definitely radical prostatectomy. If it's N2 or N3 disease, still we don't do surgery because metastatic is what we consider. So increased use of radical prostatectomy for locally advanced prostate cancer. If you see, even in US, after 2010, there is a divergence in the curve. And Germany, they always prefer to do surgery, so that you can see the curves never met, radiation or surgery. That means there is a trend towards choosing these patients for a multimodality setting, and in that, so the surgery comes as the first line of treatment. If you see the guidelines, say guidelines around 5-6 years back never included radical prostatectomy as one of the options for this type of patients. I think if any patient has got more than 5 years survival, according to our calculation, I think the radical prostatectomy and PLND becomes one of the important part of our treatment in a multimodality setting. Again, so there is a Scandinavian Journal of Urology which showed the prospective randomized study comparing primary radical prostatectomy and this thing. And I think, we are going to get the results in future. I think that will tell the answer. If you see the other guidelines like European Association of Urology, they combined high risk and the locally advanced, again, offer RP2 to patients if there is a more than 10 years of life. That is a strong recommendation. That means we are going towards locally advanced cancer and surgery as a first line treatment with or without neoadjuvant treatment. So in our clinical setting, so in our hospital, almost 60% of the patients who undergo with a locally advanced prostate cancer undergo surgery, who have 5 to 10 years of life expectancy. The main criteria is when we do a rectal examination, the cancer should not be, it's too huge a cancer which is fixed to the pelvic wall, we don't do that. Or to the rectum, we don't do surgery. And that means the patient, the prostate should be operable. Imaging, no large lymph node meds, that is only N1 meds. Any Gleason score who accepts importance, understands multimodal therapy. So remember that when I do surgery, so first they have to accept that, radiation will be required, and they will understand and accept the radiation as the next treatment. It is not the one treatment. And neoadjuvant short-term hormonal treatment generally we use in locally advanced prostate cancer, which makes surgery more easier. And even when the patient is naturally, we wait for around 6 weeks after the biopsy. So during that period, we take that opportunity to use the hormonal treatment as one of the methods. So surgical aspects. So now we know that we have advanced quite a lot. Robot-assisted radical prostatectomy is coming a big way to help these patients. So radical prostate extirpation, extended lymph node dissection, we go up to the common iliacs. Clean apical dissection, more important, because these are the ones who are going to fail in the apical region, not in the base. None of sparing, so without any hesitancy, remove everything. Resection of the seminal vesicles, and if it is infiltrating in the bladder neck, we don't hesitate to do the bladder neck resection and reconstruct the bladder neck during surgery. It hardly takes 10 minutes more. So lymph node dissection, as I told you, we do extended lymph node dissection. So nowadays there is a lot of advances, like we use indigo cyanide green and identify the lymph nodes all over, and including presacral nodes. We do a lymph node dissection. However, we don't know the overall survival, but definitely prognostication as well as the adjuvant treatment can be guided by the lymph node dissection. So with this, I can give you brief take-home messages. We have to come to an era of a big change in the treatment of our prostate cancer patients. So next step is we are already there are 4 trials going on in a role of radical prostatectomy in metastatic prostate cancer, especially oligometastasis. That means we have already gone into the metastatic setting. But remember that we have not doing surgery for a early low risk prostate cancer. That means we used to do it. Now we have moved away from that, where those patients will be given an option of active surveillance. So locally advanced prostate cancer is a heterogeneous disease. Lot of work on surgical treatment studies in patients with LAPC and lymph node positive disease has been done. So I think the still improving in the surgical technique, and new techniques are coming up. However, the RCT is required, few ongoing. So I think we'll get the results. So monotherapy, so very rarely we use it monotherapy, where when the margin becomes positive. Say for example, it is T3A. That means microscopically the disease is just outside the capsule, but the margin are negative and the score is less than 4, not 5. Then we can opt for that. Otherwise, it is the multimodality treatment, RP first, radiation and hormonal treatment as and when it is needed. Thank you so much for your patient hearing. I finished in time and 16 minutes. Thank you so much.
Yeah. Thank you for keeping the time and also for the nice presentation. I think as we are running short of time, we may go ahead with the next paper, next session.
Thank you.
Thank you so much, Dr. Zuberaza, for your nice presentation.
Thank you.
So I hand over to the organizers for the next program.
Thank you. We want to thank Dr. Yuvraj for being there, and we'll move on to the next session, which is I want to thank Dr. Tomcha Singh for being there all through. Thank you, sir. I think the other chairpersons couldn't log in.
Thank you.
We want to move on to the next session, which is a panel discussion on locally advanced esophageal cancers. We have Dr. B.K. Das, who is the ex-professor of surgical oncology in BBCI. And he is currently in the State Cancer Institute. Has sir been able to log in? Are you there, sir? Okay, and we have Dr. V. Kamo. She is a pathologist at the Naga State Health Authority. Is Madam logged in? Okay. Okay, then we'll move on with the session. It's my pleasure to invite Dr. Ritesh Tapkire. And Dr. Ritesh is the head of the surgical oncology department at Kachar Cancer Institute in Silchar. And over to Dr. Ritesh for the panel.
Hi, good evening, everyone. And thank you, Alex, for.
Will you please introduce your people, or shall I introduce the panelists?
Yeah, you can go ahead. You can go ahead and introduce.
Okay. So I want to invite the panelist, Dr. Ganesh Das. He is a senior consultant surgical oncologist at Arya Wellness Center, Guwahati. We have Dr. Partha Roy, who is the medical oncologist from B. Burua Cancer Institute. We have Dr. Aftab. He is a consultant surgical oncologist in Guwahati. Dr. Joydeep Purkyasta, who is the head of surgical oncology at BBCI. Dr. Jumi Burgain, who is the consultant radiation oncologist at Northeast Cancer Hospital in Guwahati. Dr. Gayatri Gogay, she is the associate professor of pathology at Assam Medical College, Dibrugarh. And we have Dr. Mandakini Fukan, who is the consultant in nuclear medicine at State Cancer Institute. So over to Dr. Ritesh.
Are you able to see the slide?
Yes, very much. Please.
Yes.
So we will directly start with the management of locally advanced esophageal cancer, and I welcome all the panelists. So we know that this is a common cause of cancer-related mortality across the world as well as in India, more so common in Northeast. And we have more of squamous cell cancer as compared to adenocarcinoma. The incidence of adenocarcinoma is increasing in the West. And so I would like to start with the question, is there a difference between the etiology of squamous cell cancer of esophagus and adenocarcinoma? Dr. Ganesh is there?
Yes. Mostly that squamous cell carcinoma, mostly in the upper third and middle third, adenocarcinoma in the G junction mostly. And mostly adenocarcinoma has been more common in Western countries related to reflux disease, acid reflux disease.
Yeah, correct. It is more related to the obesity and GERD. While cancer is more related to the ingestion of tobacco, alcohol, and areca nut in in the Northeast region. So let's start with the case scenario. So there is a 45-year-old gentleman presented with dysphagia for solids of 3 months duration. So how are you going to evaluate the patient? Dr. Joydeep sir is there. Would you like to take the question, sir?
The patient having dysphagia for the last 3 months, most importantly, you should go for an upper GI endoscopy.
Right. So this is, one more thing actually. Would you like to ask relevant points in history, like, you know?
We need to the dietary history, then the family history, because certain dietary factors are there which can lead to this esophageal cancer, because mostly related to this addiction, smoking, alcohol. Combination of smoking and alcohol increases by many folds. Okay. And then sometimes we have some data where there is some genetic factors also there. So we have seen esophageal cancer in families. So certain genetic factors also there.
Okay.
And also,
Any
of course,
specific?
we should know about the socioeconomic status, because depending upon the socioeconomic status, you can plan the treatment. There are a lot of cost involved. So in the history, you should know about the socioeconomic status of the patient.
Any specific points which will tell us about the status of the cancer, whether it is early esophageal cancer or locally advanced esophageal cancer?
At this the grade of dysphagia.
Yeah.
The grade of dysphagia and any
Yeah.
other. Yeah.
So we should ask about the history of cough and hoarseness of voice, recent onset backache, because these points would signify that probably we are dealing with locally advanced esophageal cancer. And specifically the magnitude of dysphagia, because if there is a grade 3 or more dysphagia, it will correlate with the degree of invasion. That is probably we are dealing with a locally advanced cancer, T3 cancer. So yeah, in endoscopy, what would you like to know? Like, from your gastroenterologist, what are the specific points which you would like to ask your gastroenterologist?
You should know the level of the disease, the upper end of the disease, how did they length from the upper incisor teeth, then the lower end of the disease, whether it is possible or not, the amount of circumference it has involved, and of course the biopsy and brush cytology. And biopsy.
Yeah, very correct. Very correct. So we have to know the morphology of the lesion, whether it is an infiltrative disease or it is just ulceroproliferative disease, whether we are able to pass the scope easily or with difficulty, or it is not, we are not able to negotiate the lesion, the distance from the cricopharynx and from the OG junction to decide about the future plan of treatment. So
one point just I like to.
Yeah.
One point I just want to highlight. Before introduce the scope, we can see the vocal cord mobility, and if it is vocal cord is fixed, that means it is very advanced. You can involve that indicates.
Correct. Absolutely correct. That we have to see the status of vocal cord also, whether vocal cord is fixed or not. And what about, is there any role of bronchoscopy?
Yes.
There is a role of bronchoscopy.
Yeah. So we do bronchoscopy all cases of esophagus before plan for surgery.
Upper third is better.
So this patient has an ulceroproliferative growth in esophagus.
No. So lower third is required because sometimes nodal metastasis and that compressing the trachea or bronchus is very well visualized. So.
Yeah, I think that's a good point, but this is an institutional policy.
We are not doing on all patients.
Yeah, you can actually for upper thoracic cancer, it is mandatory to do the bronchoscopy, and for lower thoracic cancer or cancer at the OG junction, it is institutional policy whether you want to do the bronchoscopy or not. So this patient has an ulceroproliferative growth in esophagus at 34 centimeter from incisor, involving 3/4 of the circumference, and which is extending up to 38 centimeter, and rest everything is normal. Biopsy is taken, and this we have already discussed. So what would you like to see in bronchoscopy? What are the important points?
Yes. First, before introduce putting the scope into the bronchus, so we see the vocal cord movement. This true.
Yeah, correct.
The moment we go inside, then we'll see the posterior wall of the trachea, whether there is any infiltration or fistula or something like that, and there is a mobility of the posterior wall of the trachea and carina and bronchus.
Yeah, this is very important. This is very important. Sometimes you may not have an obvious fistula or obvious disease in the trachea infiltrating from the esophagus, but the mobility of the posterior wall will be hampered. It won't move.
Yes.
That signifies that locally advanced cancer. Correct.
Yeah. Just one question can I ask? I didn't understand. You said in a lower third OG junction, it depends on institutional policy. Want to know if CT scan doesn't show the tumor any near the bronchus, why would how would the bronchoscopy help?
That's what I was saying.
It won't help actually, but as he was saying that it is a probably some people would prefer to do bronchoscopy in all cases of esophageal cancer, but generally it is not indicated for lower thoracic cancer.
You see the extent of the disease on CT scan, then we plan whether bronchoscopy is required or not.
Yes.
Generally, we reserve the bronchoscopy for tumors which are at or above the carina, not below the carina.
Okay.
So I'm not going to discuss about endoscopic mucosal resection because we are dealing with locally advanced cancer. So how will we decide the clinical staging of the disease? What are the investigations we would like to do? Imaging modality.
Imaging CT, and if, for locally advanced, you can go for PET scan also. So,
Yes, After we can do the PET CT scan also. Nowadays it is becoming a standard of care to do a PET CT scan before starting the treatment for esophageal cancer. So generally, by doing a CT scan, we would like to know, some information about the thickness of the tumor or whether we are dealing with advanced cancer or early cancer. And in CT scan, roughly, if there is any thickening which is more than 5 millimeter is considered as abnormal, regardless of the invasion. So T1, T2 is generally between 5 to 15 millimeter, and if it is more than 1.5 centimeter, it is considered T3 lesion. So how the PET CT scan is going to help? If suppose we have this much information in CT scan of the chest that it is a T3 or N1 or N2 disease, how PET CT scan is going to help? Is it going to change the stage of the disease?
PET scan is can detect micrometastasis, metastasis around 15% of patients. They can upstage a tumor in around 15%.
Correct.
So if the patient can afford and if it is available, then I think PET scan is the first choice.
Yes, absolutely correct. If it is available, then we should do the PET CT scan before starting the treatment for esophageal cancer. And it is also used for the response assessment. Once we complete the neoadjuvant in the form of either chemotherapy or chemoradiation therapy. Correct.
Exactly.
The histopathology report is moderately differentiated squamous cell cancer, and it is T3, N1, M0. So how we are going to manage? Dr. P.S. Roy is there. So I'd like to ask him, how he is going to manage the patient. Or anybody can take. Dr. Ganesh, you can take the question.
Yes, this is a locally advanced cancer. Mine policy and always will start neoadjuvant chemotherapy. Neoadjuvant chemotherapy. We send the patient to medical oncologist.
No, I would like to differ.
We are following neoadjuvant chemoradiation, following the
chemoradiotherapy, exactly.
We follow the cross protocol nowadays.
So, which is better, neoadjuvant CTRT or neoadjuvant chemotherapy?
CTRT.
Neoadjuvant CTRT.
Is there any head-to-head trial comparing NACTRT versus NACT?
Yes, there are studies going on. The study.
Now, as of now, do you have
NACTRT versus
no. Why would you like to choose NACTRT over NACT alone?
Because they show some survival benefit. NACTRT.
No. But there is no trial which has shown survival benefit in NACTRT.
There's no head-to-head
trial. No. They are studying.
No head-to-head trial.
Head-to-head trial is not there.
But head-to-head trial which has compared chemotherapy.
Okay. Ritesh, can I add something?
Yes, please.
I'm sorry, because of the poor network I had to left. Hello.
Yeah.
So regarding the decision about NACT versus NACT, there is no head-on trial to go ahead with the NACT versus NACT. It is always has been seen that trimodality is better. Hello. Am I audible?
Yeah, you are audible but not visible.
Okay. So when we are considering for surgery, that is trimodality therapy, if the patient's performance status is good and your institutional policy is going for trimodality therapy, then I think trimodality therapy should be offered to those patients, particularly in our case, in this patient. However, in absence of, yes, Ritesh has rightly pointed out, in absence of any NACT and NACT versus data. So it is absolutely depending upon the institutional policy.
Yeah, and we prefer giving NACT.
I would like to add one thing.
Yeah.
Because this is a squamous cell carcinoma. Had it been adenocarcinoma, okay, I would have said, okay, we can go for neoadjuvant chemotherapy only, and we can, of course, omit trimodality. But because it is a squamous cell carcinoma, there is enough evidence that if we miss NACTRT, we miss the train.
No, but in the cross study,
Aftab, to add on, Dr. Aftab, to add on your justification that we have to go for NSCRT. In that scenario, we will be landing up with 40 gray of radiation along with chemotherapy.
41.
That is fine. But in majority of the centers, post neoadjuvant chemo radiotherapy, the surgeon, your surgical colleague will definitely find problematic in performing the surgery.
Exactly.
So in that scenario, surgical morbidity is high if your expertise is not that adequate. So that's why I'm telling you,
Exactly.
1 minute,
Aftab,
basically depends upon your expertise. If you are expert
Aftab,
enough to go ahead with,
I agree.
Right?
So in cross study, most of the centers are giving NACTRT based on cross study, and in cross study, 75% of the patient had adenocarcinoma.
That's what.
G-junction
tumors.
Institutional
It was for
policy.
G-junction tumor, but the pathological response of the squamous was quite high, pretty high. Did I cross anything? I hope I actually
I'm just stopping my
in a histopathology examination there was a complete response.
So I'm stopping my video because the
nearly
connection
23%.
is poor. So
Yeah.
So there is no head-to-head trial, but any kind of neoadjuvant treatment is preferable. Whether if you are comfortable with chemotherapy, go ahead with chemotherapy, or you can give NACTRT. Okay. So suppose once you have given the NACTRT, is there any necessity? Those patients who have complete clinical response, would you like to operate or would you like to keep them under observation?
I'll operate.
It's better to. Operation is better.
You don't know you have to know the pathological response, isn't it?
Yes, correct. Absolutely correct. Because we don't know whether there is pathological complete response or not. So it is better to operate, because in few of the trials, it has shown that operating, by doing the surgery, we are improving the chances of overall survival. Now, one more thing. When would you like to operate after giving the neoadjuvant treatment?
What do you mean this time?
Timing, yes. Timing of surgery after neoadjuvant chemotherapy or neoadjuvant CTRT.
We reassess. Our policy do 4 weeks after surgery. 3 to 4 weeks after surgery.
There is no
3 to 4 weeks.
There is no clear-cut consensus, but generally it is preferable to operate between 4th and 6th week.
Yeah.
But there is no clear-cut consensus on the timing of surgery. But it is said that it is better to operate between 4 and 6 weeks.
Yes.
So I'll just go ahead with all these things. How will you reassess the patient before doing the surgery? Suppose patient has received the NACTRT, how will you reassess?
If the patient had PET scan, then you should push to repeat the PET scan. And otherwise, if you had only CT thorax abdomen, then we repeat the same CT thorax and abdomen.
Okay. Right. So this we have already covered. So coming to this is a surgeon's dominated area. So what kind of surgery would you like to do? Which approach? Lymphadenectomy, whether it is going to be no lymphadenectomy, 2-field or 3-field, open versus. Before going to the surgery, I would like to ask Jumi. Jumi is there. So I would like to ask Jumi one question. What is the difference in neoadjuvant CTRT versus definitive CTRT? How much of radiation would you like to give in definitive CTRT and in neoadjuvant CTRT?
In neoadjuvant CTRT, we generally give 4140 centigrade. And for definitive, we go for 50.4 gray in 28 fractions. Yeah.
Any role of boost?
We actually boost can be done for patients for definitive chemoradiation patients after 50 gray, giving a 2 weeks break, but then we can give some 3 fractions, 5 gray each. But actually not much benefit has been seen even with the boost dose. So even 50 gray is actually enough for see esophagus, definitive radiation.
If the patient is not a fit candidate for surgery, or if suppose the tumor is located above the level of carina, would you like to consider giving him brachytherapy also?
Above the level of will be, I don't think the patient will be a candidate for brachytherapy.
And in lower thoracic tumor, can you consider giving brachytherapy if the patient is not a candidate for surgery, or if you are considering definitive CTRT? What is the role of brachytherapy?
It can for residual can be given as a boost in those if there is given as a definitive radiation.
Okay, and okay, I think brachytherapy, it is only like, not many centers are following this, but wherever it is appropriate, we can consider the patient for brachytherapy, especially if they are not fit for surgery. And what chemotherapy would you like to give? This is a question to Dr. P.S. Roy, with neoadjuvant CTRT or with neoadjuvant chemotherapy?
Okay, in both the situation, as because it's a case of squamous cell carcinoma, I would like to go ahead with the cisplatin plus 5-FU based chemo regimen given on day 1 and day 28. That thing we are giving in BBCI based on RTOG 485001 trial, also US intergroup trial. Those has tried in squamous cell carcinoma combination of 5-FU and cisplatin. Had it been a case of adenocarcinoma, then probably I would like to go for the cross trial, Dutch cross trial that has used weekly Pecli plus carboplatin. In your case, cisplatin plus 5-FU.
Okay, so now the neoadjuvant part is over, and now what surgery would you like to do? Which approach? Lymphadenectomy, open versus minimally invasive? Jaideep sir.
Our policy is do a transthoracic approach.
Okay.
Yeah, because though there is no difference in the between all the literature shows that between THE and TT there's not much difference, but there's the intramortality and the postmortality is more higher in TE. But there's no difference. But our plan is to do for a transthoracic approach for better lymphadenectomy, and we are doing a true field lymphadenectomy. And regarding open versus lap, there's no difference, but shows that in experienced hands, laparoscopic surgery is non-inferior to the open surgery, as shown by some trials, the time trial, or the leukotic trial. That shows that if you do even do a laparoscopic approach, there's no difference, and it's non-inferior to an open approach.
Absolutely correct. I think the only trial which has compared TT versus THE was done long back when we did not have a good ICU backup and other things. So, yeah. And what are the two fields you would like to address?
The celiac nodes, then the mediastinal lymph nodes, the paraesophageal lymph nodes, then along this rectal laryngeal nerves, we go for all the middle and upper mediastinal lymph nodes.
So complete mediastinal lymphadenectomy.
Yeah.
Both recurrent nerves, right and left.
We'll try to remove at least 18 nodes as per TMH. I mean this TNM approach. At least 18 nodes for adequate staging. And
anything you would like to add, Dr. Ganesh?
Yes, more or less correct. So we don't do too much lymphadenectomy, including that lower neck. So because of high complication rate.
When would you like to do a 3-field lymphadenectomy? Is there any particular subset of patient? Caleb, you can also add.
The 3-field lymphadenectomy is the ideal, because the lymphatic drainage of the esophagus, since the efficacy index of all the 3 stations varies according to the location of the tumor.
Okay.
So in your case, it's a mid esophagus. So definitely we have to go for the cervical as well as mediastinal, upper mediastinal, lower mediastinal.
It's a 34 to 30 is lower esophagus after 34 to 38. No?
Sorry.
It is lower thoracic.
It is 30,
lower down.
It is 34 or 34. Oh, sir. By 34, yeah. There is nothing ideal lymphadenectomy. We actually lymphadenectomy we have to find out if it is 34 below lower. We can go for 2-field also. Like we can avoid cervical, because the efficacy rate is in lower third, but in cervical nodes is quite low. It is somewhere 14 or something like that.
Okay, so actually whatever data we have for three-field lymphadenectomy was before the neoadjuvant era, when there was no role of neoadjuvant chemotherapy or neoadjuvant CTRT. Now, in the context of neoadjuvant treatment, when we have given the neoadjuvant chemotherapy or chemoradiation, we don't know how much the three-field lymphadenectomy is going to benefit the patient. So we have to choose the patient very appropriately, and only in a selected subset of patients we should do a three-field lymphadenectomy. I think in Tata Memorial Hospital there was a trial, between three-field and two-field lymphadenectomy. That accrual is probably complete, and we'll get the result in next 3-4 years' time. So we will get a much clearer view about the role of lymphadenectomy. But till that time, I think the two-field lymphadenectomy is the standard of care. And wherever possible, we should try to do the surgery with minimal invasive approach, that is VETS esophagectomy, to reduce the pulmonary complications, since the VETS esophagectomy is not inferior to the open esophagectomy. And
the problem is dissection in the superior mediastinum.
Pardon?
Problem is the dissection in the superior mediastinum. That is.
Yeah, that along the recurrent nerve, that is a problem.
Yeah, exactly.
Yeah, Ritesh, just one point I would like to make.
Yeah.
So with regard to these two-field versus three-field, as of now, we don't have the strong evidence that three-field has added advantage in terms of survival. We don't have evidence for proving it. But we are very sure that the morbidity increases. And the trial which you said two-field versus three-field trial, we used to dread whenever we used to call up and randomize the patients, and whenever three-field happens, we used to dread it because we know that post-operatively patient is going to have a stormy course. So I think we should think twice before we decide on doing a three-field in a patient who doesn't have enlarged nodes. As of now.
Yeah, very true, Caleb. We have only 2 small randomized trial comparing, limited lymphadenectomy versus three-field lymphadenectomy, and both the trials were biased. They had very limited number of patients. One of the trial had shown some survival benefit, but again, it was highly biased trial. So we don't have a clear-cut evidence to suggest that three-field lymphadenectomy is better than two-field lymphadenectomy. Very true. So especially in the era of neoadjuvant treatment. So now coming to what is the role of adjuvant treatment? When would you like to consider adjuvant treatment? You have done the surgery, patient is all well, patient is eating orally. So would you like to, what is the basis of considering adjuvant treatment? Some cancer of esophagus.
In residual, if there is a residual, say either nodal residual or tumor residual, then in that case you can go for adjuvant, I think so. Otherwise, with neoadjuvant surgery is enough.
Okay. Before we go to the adjuvant treatment, I would like to ask Dr. Gayatri. Dr. Gayatri is there. See, for reporting the histopathology report in patients who have received neoadjuvant treatment, do you always do the response assessment criteria, pathology response assessment criteria? Is she there? I think once she comes back, we will ask her. I think she is not able to log in. So regarding the adjuvant treatment, we will go ahead with the adjuvant treatment. So for squamous cell cancer of the esophagus, Dr. Jaydeep sir, or anybody, Dr. Jaydeep, Dr. Aftab, Dr. Ganesh, Dr. P.S. Roy, anybody can take the question.
There's R0 resection, I think.
With R0 resection, no adjuvant.
Yeah, correct. Yeah. So when we have the squamous cell cancer of the esophagus, except for R1, R2 resection, there is no role of adjuvant treatment as of now. For adenocarcinoma, of course, based on intergroup 115 trial, we can advise adjuvant chemoradiation. So now take-home message is for locally advanced cancer, multimodality treatment is indicated, should be discussed in multidisciplinary tumor board, minimal invasive surgery at high volume center, and three-field lymphadenectomy is optional but not mandatory, requires learning curve. Tumor regression great to be reported in pathology following neoadjuvant treatment. That is, has Dr. Gayatri came? Is she there?
Yeah, Ritesh. So
Yeah.
who would be the ideal candidate for three field in a say in a high volume
As I
center?
said, it is optional only.
Like
Generally, we do not do three-field lymphadenectomy. If you have a tumor in the middle thoracic esophagus with too much of lymph node burden, you can consider three-field lymphadenectomy, because in those cases, chances of finding positive node in the supraclavicular area would be high. Otherwise, for lower thoracic cancer with minimum tumoral burden, I don't think we should consider three-field lymphadenectomy. And the other good strategy. Yeah.
One point, but I think the message should be there that if you see a patient who has a supraclavicular node which was positive before the chemotherapy or before your neoadjuvant therapy, then probably that is a patient for whom you surely have to do a three-field lymphadenectomy.
Yes, correct. Very true, very true. I think that's a good point. That's a good point.
But that's the
And
metastatic
especially, yeah. Yes, sir.
So that's the metastatic disease for lower third tumor.
Yeah, mediastinal tumor nodes also.
Yes, of course, we have to take into account mediastinal tumor. Some people suggest doing a frozen section of the superior mediastinal lymph nodes, but we know that the skip metastasis is quite common. So that I'm not sure whether that will really help, doing a frozen section of nodes along the recurrent laryngeal nerve in the mediastinum and then taking a call on doing a third field. So,
study here, because we have so much of CSR patient, we can do a study of.
We'll go to the next question. So there is a 65 years old gentleman presented with progressive dysphagia and recent onset cough, increasing expectoration. Endoscopy shows fixed right vocal cord and circumferential ulceroproliferative growth at 24 centimeter, and scope is non-negotiable. So, and bronchoscopically, there is a bulge and ulceration in the posterior wall of the main bronchus, suggestive of esophago-bronchial fistula. Non-metastatic disease, how we will manage?
First, we have to deal with the fistula.
Would you like to consider radiation for this patient?
We do it our esophageal stent first.
Yes, correct.
So we have to go for stent.
Ideally, should put a stent both in the trachea and in the esophagus, if it is possible.
Trachea and esophagus.
Covered self-expanded metal stent in the esophagus. And then, if the patient condition improves, I don't think they will any definite treatment can be given, since there is already fistula.
Any difference of opinion?
CTRT, definitive CTRT for this patient. They will after dealing with the fistula.
Actually, generally what we do and generally what is indicated is if you have a compromised tracheal lumen because of the tumor and the fistula, then probably it is preferable to put the tracheal stent as well as esophageal stent. Tracheal stent first, followed by esophageal stent. But if you have a good tracheal lumen and only the presence of fistula, then esophageal stenting alone would be sufficient to plug that fistula, because tracheal stenting has a lot of complications, So it is preferable to avoid tracheal stenting unless it is absolutely indicated, like in those cases where there is compromised tracheal lumen. So that's what we will do, like, palliation of dysphagia, less than 3 months survival, stenting. And if suppose there is no fistula, but only dysphagia, metastatic cancer, less than 6 months survival, it is preferable to give radiation because it has durable relief from dysphagia. So, and coming to your point on giving definitive CTRT after placing the stent, actually there is a recent publication, in 2021 only, where they have looked at doing the stenting followed by giving chemoradiation, and they did not find any significant benefit in terms of quality of life or overall survival benefit after giving the CTRT. So one more case, this is more for radiation oncologist, Jumi, 40 years old gentleman diagnosed with upper thoracic esophageal cancer, well differentiated squamous cell cancer with bulky paratracheal node, bilateral supraclavicular node. Bronchoscopically, trachea is uninvolved, lung is normal, liver is normal. How will you proceed? Would you like to give neoadjuvant chemotherapy or directly, sorry, not neoadjuvant. Would you like to shrink the tumor by giving some form of chemotherapy, or you will directly go ahead with CTRT? Jumi is there?
Told well-differentiated squamous cell carcinoma, bulky nodes. Okay, I think I would like to go for direct definitive chemoradiation.
Chemoradiation. Okay. So, what would be the like, you know, how will you decide whether you would like to consider radiation directly or would you like to shrink the size of the disease? Whether that particular thing would be covered in the field of radiation? The nodes and
actually, it can be covered, but actually we also can, because I'm sorry, because it is bulky paratracheal nodes, bilateral supraclavicular nodes, of course, the field will be very large. So we can maybe consider neoadjuvant also, followed by definitive chemoradiation. But with IMRT and all, we can actually consider definitive directly also.
Yes.
Hey, can I add, Ritesh? As far as this patient scenario is concerned, this is beyond T3 and N3. So in this scenario, NCCN guideline says that directly you go ahead with the CTRT, as because we don't have any guideline to say that NACT followed by CTRT will benefit it rather than CTRT alone. However, being a special case, being an individual case, this can be considered as 1 or 2 cycles of neoadjuvant chemotherapy followed by CTRT. But as I have said,
I just wanted to have some idea about the field of radiation, whether everything can be encompassed in one radiation field.
Yes, again, the same point will come if you ask for neoadjuvant chemotherapy. If the patient has responded in the supraclavicular node, then how will you going for planning about the radiotherapy is concerned in definitive CTRT? That is the $1 million question.
Yeah, and the other thing, sometimes we get a patient who has celiac lymph node metastasis as well as supraclavicular lymph node metastasis, and that becomes in a middle thoracic tumor. You know, in middle thoracic tumor, we cannot say that, you know, it is a metastatic cancer just by having celiac lymph node or supraclavicular lymph node, and that those patients become.
But this can be covered with IMRT. Of course, the constraints will be difficult, but still achievable.
Okay.
Ritesh, I just wanted to interrupt you. You just said one scenario in middle third esophagus with the celiac axis node metastasis, right? So probably this is the scenario while I will go for neoadjuvant chemotherapy rather than neoadjuvant CTRT followed by surgery.
Okay,
because in this scenario, neoadjuvant CTRT, my radiation colleague is not able to incorporate the entire abdominal field and thoracic field. So probably this is the patient, this is the group of the patient. Similarly, in mid-thoracic esophagus, if the patient is presenting with bulky supraclavicular node, as Caleb has rightly highlighted. So those are the group of the patients where I will prefer giving NACT rather than NACRT.
Yes, correct.
How many cycles do NACT followed by NACTRT?
Sorry, Purkasada, I had not heard you.
How many cycles of NACT?
That everything depends upon which protocol you are following. For example, if you are using Magic Trial or
I'm asking our protocol. What do we follow?
Our protocol is 3 to 4 cycles of cisplatin plus 5-FU.
I agree with Dr. Partha. I also probably do that only. But then there is always a discussion between me and Vikas on this because there is not much of evidence to say that.
I do agree. I started my discussion saying that I don't have any evidence. This is absolutely personalized.
But probably, I think probably we may not have evidence also because Western world may not see so bulky disease.
Right.
On that note, Ritesh, I think you should.
Yeah. So one last question I would like to ask Dr. Partho. What is the role of giving Paclitaxel instead of cisplatin 5-FU? Can we consider that?
That's what I also.
You are asking in neoadjuvant chemotherapy?
Yeah. Neoadjuvant chemotherapy.
You are asking the setting of neoadjuvant chemotherapy?
Yes.
Why I have categorically said about the cisplatin 5-FU, that is based on our result from RTOG and US intragroup trial, which is used for squamous cell carcinoma, cisplatin plus 5-FU. They have not used paclitaxel plus carboplatin as neoadjuvant chemotherapy. Whereas for adenocarcinoma, as far as Dutch cross trial, they have used paclitaxel plus carboplatin. But there is no head-on comparison between these two regimens.
Okay.
If you ask me personally, I am comfortable with giving both carboplatin is more less of comparison to cisplatin 5-FU.
Okay.
What about FLOT? FLOT. Why
Tolerability
you
is
not
definitely
using FLOT?
plus cisplatin.
Plot
So
is
this
for
is
adenocarcinoma.
no for squamous. You are asking me about squamous cell carcinoma.
Plot is
Dr.
for
Aftab,
adenocarcinoma.
Dr. Aftab, you are asking me about squamous cell. Plot is.
So I think Dr. Partho, we are already up. I think the time is over. Caleb is looking very serious. So thank you everyone. And thank you, Dr. Jaideep, Aftab, Dr. Ganesh. I think Dr. Gayatri has logged out. And Jumi also. Thank you so much.
Thank you so much. Thank you so much.
Thank you.
It's not that I was angry. It's just that the next presenter is Gaurav, and Gaurav feels all the seniors are doing dadagiri with him by not giving him much time. That's the reason. So,
thank you so much.
So has Dr. BK Das or Dr. Kamo joined and logged in? Okay. Okay. Since they're not there, I'll take the privilege of introducing Dr. Gaurav, our young and dashing newest entrant to our AONEI, and he is now the associate professor of surgical oncology in Bibarua, and he is doing the region proud by doing all great work there. Welcome, Gaurav. And to join him as panelists are Dr. Jadunath Murugahen, whom all of us know is a pioneering surgical oncologist of the Northeast, and Dr. Niju. Niju is again our young and up-and-coming star. Niju, are you there? Niju is a consultant.
Yes, sir. I'm here, sir.
Yeah, Guwahati. Welcome, Niju. Glad to see that you are all here. And we have Dr. Partha Pratim Medi. He's again the assistant professor at Bibarua. We have Dr. Kakoli Lakar, who's the consultant medical oncologist at Manipal Cancer Center at Bangalore, and Dr. Anupam Sharma, who is the professor of pathology at BBCI. We have Dr. Indipur Singh, who is the professor of radiation oncology at RIMS Infal, and Dr. Palash Joshi Das, who is the oncoradiologist at Arya Wellness Center. So for those of you who are here, it would be nice if you can switch on your videos. We will be love to see your faces. And over to Dr. Gaurav. Thank you.
Thank you, Caleb, sir. And good evening, everyone. Unfortunately, I have very poor network, so I won't be able to switch on my video. But I hope I'm audible.
Yes,
am I audible?
same here.
Everyone?
Same here, Dr. Gaurav. Same here. My network, if I switch on the video, you won't be able to hear me.
Yes. So we'll begin right away. Our topic is a panel discussion on locally advanced breast cancer. Next slide, please. Yeah. So as we all know, that locally advanced breast cancer is that subset in which we don't opt for surgery upfront. So this includes tumors where the primary tumor is too big, like it may be a T4 disease, or it may be a very big T3 disease, like more than 5 centimeters. Or when the nodal burden is too big, like it may be an N2 disease with matted nodes, or there may be supraclavicular node. This is a subset which we usually think that it is a locally advanced breast cancer. The picture here shows one of the common scenarios which used to be present previously, but of late we are seeing much less of this, fortunately. Next slide, please. So our first case is a 40-year-old multiparous lady. She has a lump in her left breast for last 3 months. Next slide, please. Yeah. So as we can see from the picture, she has large and pendulous breast. There's a tumor which is very big in size. Right now it is 9 centimeter by 7 centimeter, occupying the upper quadrants and the central sector of the left breast. The skin and the pectoralis muscles are free, and there is single discrete 2 centimeter node in the left axilla. The supraclavicular region is normal. So clinically, we have staged this as left breast carcinoma, CT3N1 M0. Next slide, please. So my question is to the surgeon friend here, Dr. Niju. Like, how would you like to proceed in this case?
Good evening, everyone. As this is a locally advanced breast cancer, T3N1. So after details history and after details of physical examinations, first I would like to advise her for bilateral sonomammography. After that, core needle biopsy, and as it is advanced, so I will advise for metastatic workup as well and routine blood investigation.
Yeah, as rightly pointed out, you will be doing the imaging first, and then that will be followed by the needle biopsy, not the other way around. And because it is locally advanced, you will be doing the metastatic workup. Can you just tell us what the metastatic workup would comprise of?
Yeah, either we can do CT scan of thorax and the abdomen along with bone scan, or if we have PET, then we can do a single modality PET scan also.
Okay, fine. Next slide, please. Yeah, we have our radiologist here, Dr. Palas Das. Palas Das, like, what information could you give us from a sonomammogram? Palas, yeah.
Yeah. Am I audible?
Yes.
Yeah. In sonomammography, actually, we have to look for a character of the lesion, and main and important thing is that we have to rule out any additional lesion in the same base.
Yes.
And presence of any lesion in the contralateral base.
Okay.
So most of the time, small lesion, a deeper lesion may be missed clinically, and we have seen many patients with multiple lesions in the same base and also presenting with contralateral and non-palpable lesions.
Yes. And probably we'd also like to know whether there is a microcalcification in area of the breast other than the region of the tumor. Palas, could you tell us, like, when do you suspect metastatic node on an imaging?
Actually, an imaging, we have to look for three things in to leverage the metastatic node. First thing is the size of the node. If it is more than 1 centimeter in short axis, usually suspect metastatic node. Then shape of the node. So oval nodes are usually reactive rather than metastatic, and if node shape is round, we suspect it to be metastatic. And the main important key is the character of the node. So we have to look for the normal morphology of the node, whether it's preserved or altered. If there is alteration of the hilar configuration, if there is capsular thickening and there is capsular irregularity or any perineal soft tissue thickening is there, definitely it will be a metastatic node. Irrespective of the size, if the lymph node is a smaller size also, either 4 millimeter or 5 millimeter, it is round, and if it is have some irregularity around the capsule, then we have to suspect it as a metastatic node.
Okay, the points well taken. Next slide, please.
Gaurav, one question.
Sure,
Sonomammogram means you are trying to say that for all patients you get a sonology ultrasound of the breast also done, is it?
We get a mammogram, and we also ask the radiologist to have a ultrasonic correlation that helps us to characterize the nodes.
No. My question is with regard to the breast alone. So what additional information do we get from the mammogram?
No, the ultrasound part is usually for the axilla.
Yeah. Okay.
So now we have some additional information. This tumor size was found to be 18 to 6 centimeter on imaging, and there was no microcalcification outside the area of the tumor, and only a few enlarged nodes within the axilla, and all of them had fatty hilum. The metastatic workup was negative, and the biopsy came out as the infiltrating ductal carcinoma, grade 3. ER and PR were negative. RTNU was 3+, and Ki67 was 40%. Next slide, please. So the surgeon was the first person to counsel the patient about the treatment options. So he explained the overall treatment plan and the surgical options. Patient was very keen on breast conservation surgery. Next slide, please. Yeah, my next question would be to Jadu sir. Like, would he consider breast conservation surgery as an option in this case?
Yeah, definitely.
Hello, Jadu sir. Jadu sir, are you there?
Can you hear me? Hello.
Yes, sir, I can hear you, sir.
Yes, definitely the T3 lesion and one disease, and a young patient, 40 years, the breast conservative surgery is possible. But in spite of going directly, instead of going directly to primary surgery, I will definitely ask for my medical oncologist to look for neoadjuvant chemotherapy before considering directly to surgery for a 9-8 centimeter tumor size.
Yes, sir. So before starting neoadjuvant chemotherapy, like what are the things that we should take care of?
Yeah, before definitely all investigation you have done, like you have already mentioned regarding the pinpointing tumor location, axillary node FNSC. These are like it is important sometimes what happen that tumor may disappear completely following chemotherapy. You may not be able to find out the disease. So if possible, always you should mark the tumor before starting chemotherapy.
Yes, sir.
So that is
And
one thing. And if you know the auxiliary that we already about the node, so it is better always if you had suspicious node, but always you should go for the ultrasonography of the axilla, and if there is any suspicious node, you should do the FNSC to know the pathological status, because if it is positive subsequently following chemotherapy, it may completely disappear. And
yes,
sentinel node biopsy, that also one possible option, but I am not doing that neoadjuvant, I mean sentinel node biopsy before doing prior to neoadjuvant chemotherapy, but that's an option definitely.
yes, sir. Sure. Next slide, please. As sir rightly pointed out, we need to take a good clinical photograph, or at least draw a diagram in our case record. Preferably, we need to have a radio marker at the center of the lesion, so that will help us when the tumor shrinks. And we can also resort to tattooing so that we get an appropriate idea of where the tumor was once the chemotherapy is done.
Yeah, but who the surgeon who has seen initially, he should describe the location of the tumor correctly, because the
Yes, sir.
same person institute where many surgical oncologists will be there. So for later on comparison also, you need to document it from which side, how far away from the areola margin, what is the exact size, and in between also, between every chemotherapy, prior to each chemotherapy, you should assess and document the finding.
Yes, sir. Next slide, please. We took the patient to the multidisciplinary tumor board. Next slide. My next question is to the medical oncologist. Kapuliba, are you there?
Yes, I'm here.
Like what neoadjuvant systemic treatment should be given in this patient?
Actually, yeah, in an ideal world where finance is not a concern, now with all the evidence, so we should ideally give, a combination of chemo-targeted therapy, dual HER2 in light of the Neosphere trial. I would probably give 4 cycles of docetaxel, trastuzumab, and pertuzumab. So that would be the ideal world situation. In case finance is a concern, at least trastuzumab, so TCH in that case. So
okay, ma'am.
Yeah, because
Yes,
a significant PCR, I'm sure you were aware, with addition of pertuzumab, there is a very, very significant pathological complete response. And so that would be my choice, first choice.
Okay, ma'am. Next slide, please. So madam would have preferred TCH, but this patient received 4 cycles of AC followed by 4 cycles of TH. And after that, the clinical examination revealed a good response. The tumor became much smaller. It was just 1.5 centimeter. Next slide, please. My next question is to Dr. Niju. Like, at what point would he consider surgery for this patient? Would it be midpoint of chemotherapy or the completion of all the chemotherapy cycles?
If a tumor has marked prior to neoadjuvant, then better to do surgery after completion of the chemotherapy. And if it is not marked prior, then we should do at when just before it is physically impalpable.
Okay, I take the first point. Like then the thing is, like, how frequently should you reassess the patient when the patient is on neoadjuvant treatment?
If we advise for neoadjuvant, then after first 2 cycles, we should usually we do examine after each cycle. After first completion of 2 first cycles.
Okay, the take home message is like we have to examine, the surgeon has to examine the patient after every cycle of chemotherapy. And what is your opinion about insertion of a chemo port?
Chemo port, it is not compulsory, but it is better if we put chemo port. It is both beneficial for the doctors and for the patients also. For doctors, it is very easy to very easy to give medicine or chemotherapy through ports, and as it is very difficult to cannulate a vein in a chemotherapy receiving patients. And for the patients, the benefit is it is less painful, and also it is less less chance of infection compared to.
Okay, next.
Can I barge in, Dr. Gaurav, just about the chemo?
Sure, madam.
Yeah, yes, no. In this patient, I would say it is almost compulsory because first of all, in breast we can use only one side of the only one upper limb. Okay, we are supposed not. Yeah, that is one point. Secondly, the patient here we have used anthracycline, so extravasation. Thirdly, patient will need 1 year of adjuvant treatment. At least the trastuzumab will go on for 1 year, so repeated pricks.
Exactly.
So, and given that it is HER2 positive and locally advanced, there is also a chance that it will relapse. So chemo port once inserted, we can at least keep for 3 years easily if we keep it flushing regularly. So yeah, definitely in this case a chemo port.
Yeah, it's a very important point. The importance of a chemo port is often underestimated, so that has to be kept in mind. Next slide, please.
But again here comes the issue, financial issue.
We are talking about what needs to be ideally
okay,
done.
Okay, yeah.
Anyway, next question. Yeah.
Dr. Gaurav.
Hello. Hello.
Hello.
Yes,
Pathoda. Can I?
Pathoda. Yeah, tell me, Pathoda.
Can I give a comment on last question?
Sure, Pathoda.
Yeah. I have some different opinion regarding the chemotherapy, neoadjuvant chemotherapy is concerned. You are following up the patient in the neoadjuvant chemotherapy weekly, not because of assessing the response. It is rather on the reverse way. The disease is not responding, that needs to be checked during the follow-up. Rather than whether it is responding, then we go for the surgery. It's not like that. So it has been seen that if you complete the entire neoadjuvant chemotherapy, what has been planned as a neoadjuvant, that is directly correlated with the pathological CR, and the pathological CR is directly associated with your survival benefit.
Yes, Pathoda.
So
I hope.
Yeah.
I hope we'll continue with the next case. We'll be discussing the same scenario in the next case.
Okay. Okay.
Now, question is to Jadu sir once again. Like we have a good explanation of the tumor. Like how will you go about doing surgery for this patient? Jadu sir.
Hello. Yes. Can you hear me?
Yes, sir. Your voice is very faint. Could you be louder, sir?
Yeah. Can you hear me now?
Yes, sir. Now it's better, sir.
Hello. Can you hear me now? Yes.
Yes, sir. Now it is better, sir.
Yeah. Regarding. Yeah. Definitely. Yeah. We should. What I believe that I always go for the original volume of the disease.
Okay, sir.
Okay, I look for that. So you should give the residual, but chances, I am afraid that chances of positive margin and recurrence will be definitely one issue, but that is one issue. Then what was earlier philosophy was to remove the tumor and then do not put drain. It is not like that. So the follow is always you close the defect by mobilizing the surrounding. If you have adequate breast tissue, and you always mobilize the surrounding breast tissue so that you close the defect. Orient the specimen properly. Before removing the specimen, you should orient the specimen. You mark it so that pathologists can identify the proper orient him so that he can give the report. And if you have the frozen section, if you feel it's doubtful, then you should go for frozen section whenever it is required. I do not use regularly this frozen section. And you should assess the margin always after removal of the disease, after the removal of the tumor. And the nodal clearance, it's if you have the you go for sentinel node biopsy, you can go after neoadjuvant chemotherapy also. Otherwise, if you do not have, you at least clear level 1 and level 2. No need to go for level 3 clearance.
Okay,
And
sir.
always place the drainage close to the incision site. And if suppose patient requires subsequent mastectomy, in that case you can include all the scar together.
Yes, sir. True, sir. Almost all points covered. Next slide, please. Now my question is to our pathologist, Dr. Anupam Sharma. Anupam Sharma, sir, are you there?
Yes. Yes.
My question to you is like how important it is to put the specimen in the transport media. Like why is it important to put it as early as possible?
Yes, it is very important to put the specimen in neutral buffer formalin as early as possible, because apart from histopathology, we need to study the biomarkers in carcinoma breast. So we should be very careful because there may be some loss in the antigens which are protein. So we should immediately put it in a neutral buffer formalin. And secondly, the fixation time is also very important.
Yes, sir.
Because the tissue must be optimally fixed, and there should not be any under fixation or over fixation of the tissue.
Yes, true, sir.
The minimum time for fixation is 6 hours, and the maximum is 72 hours. So we should be very careful, because that under fixation or over fixation may leads to false positive or false negative ERPR HER2 results. So fixation step is very important.
Yes. Next slide, please. Anupam sir, like can you go through this pathology report and tell us like how important are all the points in this report?
Yes, the final histopathology IDC grade 2. So actually, in a pathology report, we should give, it should be complete actually. We should give the gross examination, what are the things we have seen in the gross examination. We should mention everything there. Then apart from the gross examination, then we give the histopathological report. That is the histological type and the grade. Here we find it is a IDC grade 2. So, and that scoring also we should give the modified Bloom resection score also we should give. Then here the residual tumor size is 1.5. That is the 1.5 the diameter. And we should, while doing the grossing, we should ink the margins, and we should measure the margins from the tumor. So here superiorly it is there 2 centimeter, inferiorly 1 centimeter, medially 2 centimeter, laterally 2.5, anteriorly 0.5.
Yes, so we have an R0 resection.
Yeah,
and
R0.
we found that out of the 15 nodes, all were reactive. And so final pathological stage was like YPT1C and 0. Can I have the next slide, please? Next slide. My question is back to my medical oncologist, Kakoliba. Like, what additional systemic treatment does this patient need?
Yeah, that's what. So after the surgery, we after finishing the basic chemotherapy along with the HER2, we'll have to give 1 year of adjuvant. Right now, the evidence is for 1 year of trastuzumab, but soon there may be we may need to add additional agents. But right now it is 1 year of trastuzumab. ERP are negative, so no hormonal therapy. So that's it.
Okay. Next slide, please. Next slide. Is Dr. Indipur Singh here? Hello. Do we have Dr. Indipur Singh in our panel? If not, then Dr. Partha Mehdi, is he here?
Yeah, I'm here.
Can you tell us about the adjuvant radiation plan for this patient?
Yeah, good evening, everyone. First of all, thank you for allowing me to speak in this esteemed panel. So as we can see, this is a left-sided breast cancer in a young patient who is having a good response, and she is likely to have a long survival with all the new treatments. So giving a proper radiotherapy dose to the target volume while avoiding dose to the breast and avoiding dose to the underlying heart and lung is very important. So I believe a CT-based simulation in this case is a must. We should not go for conventional 2D techniques in this case, and our target volume for this case will be definitely the whole breast, and no scope of partial breast irradiation in this case, although their post chemotherapy response is T1, but we will still treat it as a T3 and 1 disease. The next issue will come is that maybe some oncologists, radiation oncologists would still want to go and treat the axilla and the supraclave in this patient, because the patient was initially locally advanced stage 3 disease, and if for upfront mastectomy would have gone for treating the axilla and the supraclave, but because there is a good response and the adequate lymph nodes have been dissected from the axilla, and none of them are positive, I would think that giving adjuvant radiation to the whole breast will suffice, and followed by a boost to the tumor bed. Tumor bed and a 1 to 2 centimeter margin around the tumor bed. So this time the tumor bed will consist of the clips placed by the surgeon at the time of breast conservative surgery, not the original 9 by 7 centimeter volume, because as the surgeon has reduced his surgery because of the good response, so we will also decrease our volume of boost, but not the initial 40 grain initial target volume, which is the whole breast. And I think if IMRT is available, IMRT should be done for this patient.
Actually, there are two schools of thought. Like Jadu sir told just now that he will remove the original tumor volume. Probably in that case, he will need to do some oncoplastic surgery.
Yeah.
And the other philosophy is like to remove the reduced volume, which is actually practiced by us. In that case, maybe you would do what you have said just now. So next question would be to you again. Next slide, please. What fractionation would you use?
So the conventional fractionation has been 50 gray in 25 fraction to the whole breast, followed by 12 to 15 gray of boost to the tumor bed and 2 centimeter margin. But now gradually we are going to more and more towards hypofractionation in breast cancer. Data has been extrapolated from early breast cancer. Following lumpectomy, people have given 40 gray in 15 fractions over 3 weeks, or 42.5 gray in 16 fractions, or 45 gray in 20 fractions over 4 weeks. So all these have been shown to be equivalent to 50 gray in 25 fractions, which has now been increasingly been incorporated in locally advanced breast cancers also. We are safely treating the axilla and the SCF also in locally advanced with the same fractionation. So I'd like to stick with 40 gray in 15 fraction in this patient, followed by a boost of 12.5 gray in 5 fraction to the tumor bed.
Okay, fine. Next slide, please. We'll quickly move on to the next case. Our next case is
Gaurav, before
yes,
that,
sir.
one question.
Yes, sir.
If this
Yes, sir.
patient had been a ERPR strong positive patient,
yes, sir,
would your management change? Would you still consider neoadjuvant, or would you operate upfront with flap?
Yeah, I'd still consider neoadjuvant chemotherapy because he wants breast conservation surgery. So it would be good to give a trial of neoadjuvant treatment before going ahead with surgery directly, because that would result in a.
What if there are microcalcifications in the entirety of the mass?
Yeah, means that needs to be taken care of, because we need. That is one point where probably some form of extreme oncoplastic would help in an upfront surgery. If she wants a BCS, still strongly keen on a BCS, then probably some form of extreme oncoplastic would help in that scenario.
Okay, thank you.
Our next case is about a 56-year-old postmenopausal lady. She has been staged as clinically CT4B and 2 M0, left breast IDC grade 3, and a triple negative breast cancer. The tumor is like 12 into 10 centimeters, and there is an axillary nodal mass lateral 3 into 3 centimeters. Next slide. Kakoliba, like what systemic treatment would be appropriate for her?
Yes, so this is actually pretty straightforward. We would definitely, since it's triple negative, even nowadays, even if it is not really locally advanced, we still do systemic treatment in the beginning. So it would be dose dense AC followed by dose dense paclitaxel, 2 weekly, total 8 cycles. Finish it all, then send for surgery. So that would be my suggestion. And once the surgery is over, if there is a good, because it's triple negative, there may be a very good response. If at all there is residual, there is evidence that later on, after the radiation, everything is over, I should give a few cycles of capecitabine. So that's the entire plan.
Okay, that was one scenario where this case could have gone, but unfortunately, it's the opposite scenario. Next slide, please. We'll consider the opposite scenario. This disease progressed after 4 cycles of chemotherapy. The tumor became like 15 into 13 centimeter. There was impending ulceration. The nodal mass in the axilla also increased in size. Next slide. Question to Dr. Niju would be like, in the event of progression on chemotherapy, do we need to repeat the metastatic work?
Yes, definitely. As this is already locally advanced and not responding to chemotherapy and it is progressing, there is always chance to spread to other organs. So I will obviously advise for repeat metastatic workup.
Okay, fine. Next slide. Palasda.
Yes.
Palasda, are you here? Yeah. Like in the event that we do a metastatic workup and we find the indeterminate liver lesion, small lesion on the CT scan, how would you suggest to use our investigation to clarify that doubt?
Hello.
Hello. Did you get my question, Palasda?
Yeah. Okay, you first have to look for the quality of CT. If it is single phase CT, most of the time there is a confusion regarding whether it's hemangioma or some metastatic lesion, or sometimes some benign lesion like adenoma or some hemorrhagic cyst may mimic like metastasis. So if it is the CCT quality is not good, you better prefer a triple phase CT.
Okay.
Okay. Although detection of metastasis, the MRI is superior than CT scan. Although in some cases MRI also is not possible to give a conclusive result of some intermediate lesion. So it's better to do a PET scan if possible.
Okay. Okay, fine. Point taken. Next slide, please. Back to Kakolika, like does changing neoadjuvant treatment, that is considering a second line, produce any response in such?
It does, but it's a very poor prognosis. I mean, if it's 4 cycles of AC which has been done, we can add a taxane and see, but it's very poor. The prognosis will remain guarded. So even though there is not much evidence, so in such a case, along with paclitaxel, we generally add carboplatin, because platinum triple negative tends to be sensitive. So just to induce a response. But we have seen a few responses, but they come back very fast. Generally don't do.
Next slide. We move on to Jadu sir. Should we go ahead with mastectomy in this case right now? Hello, Jadu sir.
It's a bad disease. Node
Yes,
was 3 centimeter. Now lymph node has become 4 centimeter. Definitely you should look for metastatic. Hello.
Yes,
Can
sir.
you hear me? Yeah,
Yes, sir. We can hear you, sir.
Look for again metastatic workup, and I will be hesitant to operate this patient. I will ask for, if there is nothing like kind of toilet mastectomy, I will ask for radiation oncologist to, if possible, to give radiotherapy instead of surgery, and then again see what is happening. And because if you operate also in no time, this patient will recur. I have seen patient operating also, but they are coming back again very soon. With 4 centimeter node, you do not know what is the status of the axillary vein. All will be stuck actually in this patient. But before start going for surgery, I think definitely you should see giving radiotherapy to these patients particularly.
Next slide. Next slide. Quite different to what Jadu sir said. We did a mastectomy and put a LD flap for this case. That is the other option that can be explored. But like he said, it's a bad disease. Some cases may land up with local recurrences, unlike this case, of course. Next slide. So the histology, final histology, it came out to be a high nodal burden, like 20 out of 35 nodes were positive, and they had perinodal spread. The tumor size was also 15 centimeters. Next slide. Like Kakoli, in the event of such a thing, would you consider systemic treatment in the
Yes, yes. I mean, I'm assuming they have finished, the recommended cycles before the surgery. I'm assuming that, and then you proceeded with the surgery. Capacitabine will have to give maybe 6 to 8 cycles capacitabine, but it's a very bad disease. Actually, just like Joduda said, I have seen a real life patient like this, almost like this, progressed after a few cycles. Then we changed the chemo, somehow responded to come for surgery. Patient died in 2 months after surgery. Believe me. I mean, they in a month they came with liver mets. Actually, they came with jaundice, not just liver mets. The patient came to first follow up, came with jaundice, and liver was studied with mats. In 2 weeks time, then again I started capacitabine, couldn't give the full dose because of the liver thing. A patient died of liver failure in the next 2 weeks. It was that aggressive. So these diseases are very, very aggressive. No matter what we do, I don't think we can do much really.
So we will all keep that in mind. Next slide, please. Question to Partho is like, he has already answered this, when do you include axillary nodal patient for post-op radiation? Could you just revise it for us? Like,
in this case, we have to irradiate the axilla and the supraclavicular nodes also, because there is a high volume, large nodal burden clinically, and 2 disease in the axilla. And pathologically also there are 20 nodes positive. Extracapsular extension was positive, I suppose. So all these are indicators of irradiating regional lymph nodes. In spite of having a adequate axillary dissection, we still have to go with irradiating the axilla in these situations. And also someone might advise irradiating the internal memory nodes also in this case, considering that it's a tumor that has involved all the quadrants, and it has almost reached the medial quadrant. So internal memory nodes may also be included.
Okay. Next question to you is a follow-up on Jodusa's advice regarding this case. Next slide, please. Like, what is the role of radiation in the neoadjuvant period in this patient? Like, either singly or concurrent with chemotherapy? What did you prefer?
So there is no such hard evidence to say that there is a role of radiation in the neoadjuvant period in breast cancer, which has improved the disease-free survival or overall survival. There is a report from Adyar Cancer Center only. They published it last year. They reported on 100 patients of stage 3 and above, stage 3 cancers who were inoperable, and they did 46 in 23 fraction radiotherapy along with the chemotherapy cycles during the second and third cycle of chemotherapy. And they showed that there was a very good pathological complete response rate, more than 30%, and 2-year event-free and overall survival were also very high, 70 to 90%. So, but that was a retrospective one of report, and as of now, there is no evidence to suggest that we must give or there is a benefit. There is a trial which has started last year, the NeoRad trial, which will complete accrual in 2030. And so we have still a long time to wait. But yes, considering that all the options are failing in this patient, I think we can give a trial of radiotherapy to increase the chances of margin negative and increase the chance of disease-free survival in this, but purely on a personalized basis. There is no evidence to suggest that we must do it and there is any benefit.
Okay, thank you so much. So allotted time was like 30 minutes and we have exhausted that. So I thank all my panelists because it was a very interactive and very interesting session. I hope all our audience was fully engaged, and thank you all. Thank you so much.
Thank you so much.
Thanks a lot. Thanks a lot. You are our star as always. You finished on time. Thank you for that. And all of you, please hang on. We just have a small formality. Next is the, but it's an important thing to do. Our general body meeting. Please be logged in, and we'll start off with the welcome address by our President, Dr. Bhuyan, sir. Bhuyan, sir. So please unmute yourself, sir.
Unmute.
Yeah.
Fine.
Yes.
Now, can you hear me?
Yes, sir. Please, sir. Please.
A very good evening. It's 9 o'clock, and I see slowly few people have joined very recently, and they are senior people. I welcome you all. We have 34 people at the moment in the net, in the Zoom, and it's a good number to have a general body meeting for AONEI, because in the earlier years also, when we physically meet in the annual general body meeting, people number becomes less. In fact, this 34 numbers is a really good number to say. And I thank you all for being here to have the general body meeting, which is so very important for us for planning things to take the organization forward. Now, very unfortunately, we have to miss out Vikas Jagtap, who had been doing all the things for the last 2 years, and he had to rush to Mumbai for his father's ailment. Last night, he gave me an urgent message that he has to leave, and he will leave this morning. Early morning, he left Shillong, and in the evening, only an hour back, I confirmed that he has arrived in Mumbai. In this hurried situation, he has failed to transfer the minutes of the last annual general meeting minutes. He could not hand it over to Caleb. Rest, all the other informations and all the other responsibilities are being taken care of by Caleb for this annual general meeting. I thank Caleb for taking this responsibility, and I hand my mic to Caleb to take it forward. In fact, it will be accounts next. So Caleb.
Yeah.
Yeah.
Thank you, sir. So, like sir said, I couldn't get it from his room. He had kept it there in a hurry and left it. I couldn't access the room now today. So I'll just give you a brief overview of what happened in our GBM last year. So the GBM was held last year in Pinewood Hotel in Shillong, where we had our annual conference. And in that, the following things were discussed. One was that the audit accounts had been already audited. That is what Vikas informed, which is a good thing for our association over the past few years. And then we discussed over a lot of things. One of the important things we discussed was the role of a journal for AONEI. And I had presented a report because I was entrusted with the responsibility to look into this. And we decided that it may not be very feasible to come up with a report for it. Because it may not be feasible for us to come up with a journal on our own. So we decided that we can collect some articles and then we can come up with special editions with other journals. So that is what we've discussed. So as a follow-up of that, I've spoken with the Indian Journal of Surgical Oncology. So they are willing to publish our journals. They'll come up with a special issue wherein about 15 to, if we come up with around 10 articles, they will publish it for us. So that is what we discussed with regard to the journal. Then with regard to the, we wanted to encourage residents to write more articles. Like I remember last year we had close to around 30 abstracts, I think, overall. So we thought that these abstracts should be converted into papers, and we thought that we should come up with a system to encourage our residents to publish this. So on a formal note, it didn't happen probably because of the pandemic and other things. We couldn't follow up on things. But then on informal note, some people did approach me, and we were able to help them unofficially, of course, with the permission of their supervisors. And with regard to the website, we have renewed the domain renewal has been done, but the hosting,
Caleb,
there is some issues
Caleb,
which are
1
being
minute.
followed.
Hello,
Yeah.
Dr. Caleb.
Yeah.
No, you are continuing serially, or you are in the minutes of last
Yeah,
meeting?
I think Caleb, we discuss one by one.
Yeah.
So accounts, little detail, Ritesh can tell about the accounts. If Ritesh is on the line, no? Ritesh is on. How much money we have and all. Ritesh Tapkire.
Because at close to 20 lakhs are there, sir. I'm not very sure it's between
Sir,
20
actually,
and 22 lakhs.
sir, actually, Vikas is managing everything. And probably actually he did not have time to give me the handover regarding the accounts.
Okay.
You are the treasurer. You are supposed to know.
No, I am not actually. He is only managing everything because he has done everything about the bank detail.
No, he
and
is the treasurer. He is the secretary. Everyone.
Sir, I'll just brief a little bit whatever information I know, because we discuss often together. So around 20 lakhs is there, sir. Something between 20 to 22 lakhs is there in the account.
22, approximately. Yes, 22, as I know.
Yes, sir. 22 lakhs is there, and then it is all completely audited. The tax is all clear and paid, and the auditor even suggested, because this year we don't have much of any revenue this year because no conference. So this year he said, auditor also suggested that we spend off money because otherwise we are just paying tax. So this year the major expenditure, one expenditure has been towards renewing the domain payment for the website. The other expenditure has been towards this conference hosting. So we tried whether we'll do it on our own with some drug companies getting a Zoom, but then there was a lot of other things also to be done, and it has been a good decision, of course, in retrospect, because with Vikas gone now, with a lot of coordination work was done, which has been taken care of by the our event manager, Mr. Ravindra Purohit.
This, as Vikas had discussed with me, the total expenditure for organizing this meeting on Zoom will not be more than ₹1 lakh. It should be within ₹1 lakh. This was what he had informed me when we were discussing these things. And some bit of it was there in the AONEI executive committee meeting also, group also, WhatsApp group also.
Yeah, Jadu sir, you wanted to say something?
No, to organize this Zoom meeting, it's costing ₹1 lakh.
Sir, it is much lesser than, this is very much lesser as compared to other quotes we got, sir. So that's why we decided on this.
And in an ideal
we could have organized free also.
Everyone if we could. But even if you look at the adult population in our country, and we would say that we would like to vaccinate the entire adult.
Yes, sir. Yeah, please go on, sir.
Hello?
Yeah. Sorry, sir. There was some disturbance from somebody else. Please tell me now.
Yeah, no problem. I'm really surprised that it is costing ₹1 lakh to organize.
We'll have to get it from Vikas, and I'll ask Vikas to give it in the general body.
I have doubt.
The general body means in our WhatsApp group for information of all regarding this expenditure of this meeting. Because exact amount, he just discussed it should be less than ₹1 lakh. I also don't know whether it is 80,000, 40,000, or even 90, 95,000. So I'll ask him when he comes back.
It's plus or minus, sir. It's plus or minus 1 lakh, but still,
it should be less than ₹1 lakh.
Sir, it was very reasonable compared to the other quotes we got. So yes.
Okay.
Yeah.
Regarding the income tax issue, as I know, we don't have any income tax pending. We are income tax clear at this moment.
Yes, sir.
Till date. Okay.
Yes, sir.
So this was known to me. Audit is up to date.
Yes, sir.
Yes, it is. Regarding the website, you have already told Caleb. Anything else? Some people may have some inputs. We have many people in this group. So take opinion from them.
Yes, sir. No, regarding newsletter, we couldn't. I asked for contributions. Not many contributions were there. I'm glad because many people have directly sent to many journals. So we are planning to do only an e-newsletter. So we couldn't get many contributions this time. So
some opinions from Silchar, some opinion from Impal, some opinion from BBCI, or some opinion from state cancer hospitals all around us, Northeast. Our members are there, and I think they are present. Some of them are present. Some input.
One thing, sir, regarding this, whatever amount we have, if we make FD, will it be more beneficiary, or is the same thing keeping in current account? 20 lakh is huge.
Jodu's voice is very faint, you know.
Sir, Dr. Jadu is asking whether placing the amount in a FD will give us more benefit.
We have been discussing this issue over in most of the meetings, in last couple of meetings. We have not done that. But I think other than, I know, more than lying in the savings account, it can be put.
Hello.
Dr.
Hello.
Rubu, you want to say something, please?
Yes. Yes, was it Rubu? Rubu Sunko?
Sir, I think it was by mistake, I think, sir.
Oh, somebody else's voice. Anyway, to answer Jodu's query, we have been discussing it in most of the meetings, but we have not done it. I don't know. The execution part is always good.
I think Ritesh should look after to that, sir. Ritesh can look after on that, sir. Whether it will be.
I think Ritesh and Caleb, both of you discuss,
Sir,
and let
FD,
Vikas come back. We can put
the interest on FD in most
a part of it in fixed, I think.
Not all. Yes, exactly, sir. Part of it.
Maybe 50%, maybe 10 lakh or 10 lakh we can put for 5 years. And if required, we'll break it anytime.
The problem on FD is less than 5%, sir.
Yeah, sir, the only thing is the interest which comes is very, very marginally higher, and whatever interest comes also, that is taxable. So then
it's less than 5%.
But in current account, you not get anything, I think.
Yeah.
You get anything?
If we do it for 5 years, then it is tax free, sir. If we do it for 5 years, then it is tax free. If we do it for 1 year, then it is taxable.
To make it 5 years plus?
But the interest is less than 5%, sir. It is close to 4.5%.
50,000 in a year.
I see it in two ways. I personally see the account thing and banking thing in two ways. Number one, if it lies in our current account or savings bank account, anytime then account is hacked, this money can go out. We may lose this money. But if we transfer it to a fix and keep it separately, this money remains safe. That's number one.
Yes, sir,
and secondly, it will also earn some amount of little bit of extra interest. Both sides it will be taxable. And the issue which we had been discussing over time to keep it in fix will also be probably done. So this can be a point which we can discuss subsequently, maybe in executive committee. So this point can be noted down as a serious discussion being done during this meeting. Maybe let 10 lakh of rupees.
Sir, we will discuss with the auditor, and based on whatever advice he's saying, we'll go with it. Is that okay, sir?
Yes.
Sir, 5%, 10 lakh over 5 years, you will get 2.5 lakhs, I think.
No.
The 10 lakh, if you get 5%, you'll get at least 20. How much? It will be nearly like that, 50,000. Okay, next.
Right. So, Caleb, please go ahead.
So, with regard to the audit website newsletter, like I told you, this year we plan to do only an e-newsletter, but that also because of poor response, we've not gone ahead with it. It's still, if people are giving me a few articles, I'll still make a e-newsletter. But next year, hopefully, we'll have a proper hard copy newsletter. And overview of last year's activity. And last year's activity, most of it, I mean, everything was wiped out because of our of the pandemic. But if anybody wants to say anything, you can please. I don't think any activity was done.
I say one thing here.
Yes.
I have seen many of our members, uploading the activities they have done in their respective places during the entire pandemic year. These activities are, cancer activities or activities in cancer field or even in COVID field. they have done. A lot of them have done it. And I take pride that members of our association have done it, although many of them have not done it under the banner of AONEI. Anyway, it doesn't matter whether you take the banner or not, but these are activities done by our members. I take pride in that. I encourage that all the members should make initiative to do something and contribute to the growth of the organization, including ideas, sharing of ideas with the president, secretary, and in the group also. Whenever you have some idea in mind, this will go a long way in the growth of this organization. And we make a next year plan if possible.
Yeah, we can go ahead with next year plan. So I think next year first will be the annual conference. I think Dr. Arup Rai Burman was willing to host this year annual conference also. Even this year he was willing to host there. So I'm sure that next year February he will surely be able to host it. Is Dr. Arup around? Dr. Arup. Okay, sir, I think we can safely assume that he will be willing to host next February. Does anybody else have?
Or you? Yeah, I can host in Jorhat Medical College.
Okay, Aftab is willing to take it to Jorhat.
Yeah.
Yeah.
Maybe a year after that.
It was decided by Dr. Arup, huh? Yeah. Caleb.
Yes, sir.
The last time Dr. Arup decided.
Arup is not in the loop.
Yeah, Dr. Arup was willing, sir. So Arup only, I think he will surely do it.
Talk to him, I think, first.
Yes, sir. If in case he backs off, then we can ask Aftab to do it, sir, next year.
Exactly.
Yeah, I'm ready.
Good to have it in Jorhat.
Thank you, Aftab. But meanwhile,
thank you so much.
If Aftab is ready to do it, if Dr. Arup is willing, is accepting to do the next annual conference at Tripura, maybe Aftab can do a midterm CME. What do you say, sir?
Yeah, I'm.
Yes.
I'm ready.
Okay, that's very good. That's very good. And in Assam, all the meetings till now has been in Guwahati, so it should go out of Guwahati.
And Jorhat is a beautiful place. You will like it.
Sure. Thank you very much.
And anybody else volunteering for any other CME? Yes, anybody else volunteering for another CME? Dr. Ganesh Das, sir.
Yes.
You were talking,
so,
sir, doing it
in GI malignancy. Maybe after Jorhat, maybe after midterm CME.
Okay,
end of this year.
Okay, if you can come up with a tentative time frame, it will be good, sir. Then we can plan with our.
Yes, let's Vikas come.
Okay.
So then inform.
Okay. So is there an approval from everybody on that? Sir, Bhuyan, sir. Please tell your
Yes,
views.
for what?
No, Dr. Ganesh Das is proposing that he will do a CME on GI.
Yes, he has given it in the WhatsApp group also. Very much encouraging thing. Ganesh should take it an initiative, think of it, and give a time frame. Inform little early, and it should be a good CME. Why not?
Pardon? Jadu sir, please tell.
Yes.
Guwahati, CME?
Yeah, Dr. Ganesh Das is
Guwahati.
proposing in
end of this year, end of this year.
Yes.
Maybe August, September.
Okay.
I don't know what will be the COVID situation, but if everything comes conducive, we should do it.
Yeah. After what is your proposed date if we are doing it as a CME and not as a midterm CME and not a annual conference, please?
Midterm CME, I think so. August, like that, it would be better. I think.
July, August.
Okay.
July, August, yeah.
Would it be raining there in Jorhat or how is it?
In Jorhat Medical College only.
Not difficult.
Okay. Okay.
Yes, sir. There's all facilities, all there. Auditorium is there,
Okay.
and everything whatever needed for a CME, it's there. So as a CM midterm CME, even you can host annual CME also.
Okay, we'll discuss it, and then after you keep in touch with us. Us means the
yes, sir, sure.
executive committee. Okay, and we'll definitely do
yes,
it.
sir.
We'll
Yes,
take
sir.
confidence of the other people and involve everybody. Okay.
Yes, sir.
Finally, the extension terms of office bearers. It's a very important issue. Caleb?
Yes, sir. Yes, sir.
Yes, sir. Because of the situation of virtual meeting, the situation is that the term of the office bearers has to be extended by at least 1 year now, because we cannot have
next is
because we cannot have an election at this moment. So
Yes,
this
sir.
one issue only. I cannot hear.
Yes, sir. Yes, sir. Now it's fine, sir. Please tell us.
No, what is the opinion of other members regarding extension of the committee?
Yeah.
That is what
should continue till another next AGM.
Yes, yes. I think so. Everybody.
Yes.
I think so. Everybody is agreeing to it.
Okay, then it's okay.
Yeah, if there is anybody who's objecting, please unmute yourself and speak. We'll wait for a minute, maybe.
No objection. No objection from anybody.
Okay. Okay, then if there is any other issue. Last thing on the agenda is the election. So the election we will do it next year at
next AGM
at Tirupura and the GBM next year.
So when I will be informed regarding whether it will be a midterm or annual. Because for your information that we are doing some oncology cases, like we have here we have a ACF like palliative center, clinic center. So there I got a lot of palliative cases, or doing palliative surgery also a lot of, and some curative surgeries, and so
I think we can talk to Dr. Arup Roy even next week also. Even tomorrow, if he's around, we can talk to him. We will sort it out and do it at the earliest. You can be in touch with Vikas once he's back next week itself. We can finalize that.
Okay, fine.
We can discuss it on the AONEI group also.
Okay. Thank you. And regarding the topic also, like what would be
discuss it and we'll finalize it.
Yeah.
After you yourself think of a topic, which topic you want to discuss or which topic you want to make. That's a good initiative to start with. Okay, we'll modify if required. Okay.
Yes, sir.
Come up with your own idea.
Yes, sir. Yeah, I would like to take a topic which all are involved. All the surgeons are practicing here. The surgeries they are taking
I mean, all surgeons mean head and neck, gynae, and general surgery. You cannot mix up. No, you have to take one topic like CA stomach, CA colon, maybe CA ovary, maybe head and neck. Something only one. When you do a CME, it has to be in one. Or we'll have to have a sort of this, mix up things, which will not be good. Okay. So find out which one you want, which one you are more interested. Okay.
Okay, sir. Thank you, sir.
Okay.
Is there
anything else, Caleb?
Yeah. Anybody else want to say? Senior members, sir, Saikya, sir. Anybody else? Dr. Ashish. Anything?
Ravi is silently there. Bhargav is silently there.
No, I am there. Nice to see you all.
So I was interrupted by a call that time, but I feel that Dr. Vikas and Dr. Caleb is doing a really good job. So I feel that you all should continue with the
definitely
with your post.
Definitely, I appreciate it.
it's a situation of compulsion at this moment that we have to carry forward.
Sir, even if it was not
okay.
compulsory, maybe we could have asked them to continue, sir.
Anyway, next year we hopefully meet,
Yes,
and then we have many things to do. Okay. So if no more opinions from any members, no input any further, so we can ask for a vote of thanks.
Yeah. So on behalf of the Executive Committee of AONEI and Vikas, to thank all of you for joining in here and staying until late, though we have been very late here. Thank you all of you for being here. Thank you so much. And we'll meet again tomorrow. Thank you.
Okay. Please, all of you, please join by 4 o'clock in the evening tomorrow and make this meeting a successful one. See you all tomorrow. Bye, friend.
Thank
you.
Thank you.
Thank
you.
Thank you.
Good night. Good night.
Bye-bye.
Bye.
Bye-bye.
Bye-bye. Take care,
Bye-bye.
everybody.
In fact, in this meeting, I have seen participation from across the country, which would not have been possible in a physical meeting. So virtual is, a virtue sometimes. Thank you very much.
So always we should have virtual.
No, we can. What we learn,
Physical
what
meeting.
I have learned, we can have a hybrid meeting where we put a virtual part where members who are staying outside the state who cannot come can participate. So it's a good thing to think about in the next subsequent meetings. Thank you all.
Thank you, sir.
Bye-bye.
Bye.
Bye.
Bye. Night.
Bye-bye, Kakolich, Rubusungku, everybody.
Now all are welcome for banquet dinner.
You all go for banquet.
Virtual banquet meal.
Virtual banquet dinner.
Virtual banquet dinner. That's it.
Gautam can also join.
Huh?
Gautam can also come join.
Yes, yes. So if we have a virtual meeting, we can have people from across the world.
Wow,
We can
Good thing.
have something and we can start together.
You find out if WhatsApp can send, the physical things by some means. Yeah? Packets.
Okay. Good night.
Okay.
Okay. Take care. Good
Janagana
night.
Mana. Thank you very much.
Okay.
Bye.
Good night. Night,
Bye
everybody.
bye. Bye
Bye-bye.
bye. Bye bye.